So good morning everyone. We are expected to start within next 5 minutes. Please be seated. So good morning everyone. I welcome you to this ART Fertility Clinics second edition of Annual Scientific Congress in India. This year our Congress key theme is Entering a New Epoch in ART. The conference will bring forth the latest clinical advancement and research in the field of assisted reproductive technologies, as well as showcase the unique approaches and treatment in reproductive medicine. The Congress features participation from top international IVF specialists, health organizations, and related experts who have pioneered reproductive medicine techniques in their respective fields. We shall attempt to identify and address region-specific challenges in infertility, as well as highlight personalized treatment and present successful case studies for new learnings. Last but not the least, the Congress gives us an opportunity to network with the most renowned international clinicians, embryologists, and geneticists in the field of reproductive medicine. We hope this Congress provides all the delegates and the participants with a stimulant environment and an enjoyable interaction. Thank you for being part of this wonderful gathering. It is our tradition to take blessings from our Almighty when we begin something new and light the lamp. So for this, may I invite Professor Dr. Human Fatemi, Dr. Parul Katiyar, Dr. Dakshayani, and Dr. Nalini Mahajan ma'am for this.
शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शत्रुबुद्धिविनाशाय दीपज्योतिर्नमोऽस्तु ते दीपज्योतिर्नमोऽस्तु ते शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः 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 शत्रुबुद्धिविनाशाय दीपज्योतिर्नमोऽस्तु ते दीपज्योतिर्नमोऽस्तु सम्पदः शुभं कुरु त्वं कल्याणम् आरोग्यं धनसम्पदः.
Thank you so much. So with this we begin with our first session for the conference. For this I'd like to invite Professor Dr. Human Fatemi as our first chairperson. It is my great privilege to introduce him. Professor Dr. Human Fatemi graduated with an MD in 1999 at the Universitat Brussels with magna cum laude. In 2005, he won the Pfizer Educational Grants as the Best Graduate Fellow in Gynecology in Brussels, Belgium. In 2008, he was recognized as a subspecialist in reproductive medicine and surgery by ESHRE and European Board and College of Obstetrics and Gynecology. During his training and later on also as a consultant, he has performed several studies in various fields of gynecology and reproductive medicine and surgery. He successfully defended his PhD in endocrinology of luteal phase in stimulated and substituted cycles in 2008 at the University of Brussels, Belgium. Professor Dr. Human Fatemi has authored more than 150 internationally peer-reviewed articles and several book chapters. He has held more than 150 invited spoken presentations at international conferences, and in 2009, at the age of 35, he received the title of clinical professor from the University of Brussels. I invite you, sir. Please welcome.
Thank you very much, Dr. Azadeh, for the kind introduction. Before going ahead, I would like to welcome you all for the second edition of ART Fertility Clinics Congress. What I always say is science is dynamic and we need to be dynamic. So we need to update ourselves. It's like your iPhone, you have to update every few months, and the same is with science. Now what we did, we tried to bring a lot of innovation, knowledge, and the idea of not following a dogma. So the meeting today, we have brought clinicians, scientists, geneticians, top after top from the world, who are going to present the latest update on the research they have done. We had this meeting yesterday in Dubai. I can tell you, in Dubai it was extremely interesting and it was really a great learning for all of us. I highly would like to engage, that you engage in discussions, that you ask questions, that you criticize also the speakers in order to learn from each other. It's also a great opportunity for all of us networking and collaborating, but the most important thing for today's meeting should be to engage and to communicate with each other in order to learn and improve our knowledge. I hope we all have an inspiring and fruitful meeting today, and that will have a long-lasting impact on our clinical activities. It's my pleasure to ask the first chairperson, Dr. Nalini, to join and introduce the first speaker, which is me, unfortunately for you. Dr. Laura Melado was supposed to give this lecture, so last moment she could not join us, so I'm going to present on her behalf.
I will also introduce the second chairperson.
So good morning everybody and welcome to this session. I think Dr. Fatemi has already been introduced by Dr. Azadeh, and he really doesn't need any introduction in this setting or in fact across the world in a global setting as well. He's one of the people who has pioneered a lot of work in the area of infertility and the endometrium and ovarian stimulation protocols. I mean, he has worked in probably every area that you can think of in the field of fertility. So without much ado, please start.
Thank you very much, Dr. Nalini. Can I please have the first slide? Can you go back, please? Back. So the title, which was initially given to Dr. Laura Melado, who is our medical director in Abu Dhabi, was AMH and why we should not follow a dogma. Now, if you look at the ovarian reserve of a woman, it's very interesting because the ovarian reserve of a woman, it's a very inefficient system. It's extremely inefficient. You know, when you have a baby girl in the uterus of a mother, she has around 7 million eggs. 7 million. Now you might say, but who needs 7 million children? Who needs 7 million eggs? We don't need that, right? The thing is, the moment that child is born, you go from 7 million to 1 million. Good. You would say 1 million is still enough. I don't need 1 million children. But you don't have any period when you are born. So what is happening when you have your period? You go from 1 million to, let's say, 300,000, 400,000. Still you would say, who needs 400,000 children? The problem is, from these 400,000, you would utilize in your whole life 300 to 400. And the worst news is, most of those eggs would be genetically abnormal. So you see, it's a very inefficient system, yet it's 8 billion of us out there. So somehow the system seems to work. Now if you look at the ovarian reserve, you see that at any given age, you can have a high ovarian reserve, you can have a medium or normal ovarian reserve, or you can have a low ovarian reserve. So it could be 30 years, poor responder, 30 years normal, or high responder. So age, per definition, is not an indicator of ovarian reserve. Globally, you go down, but at any given age, you could be normal, hyper, or poor responder. So I think this is important to mention. Now, when we look to the ovarian reserve, obviously there are various factors that we're looking at. You will see today antral follicle count, AMH, what have you. There are many variables that we look at. Now, anti-Müllerian hormone has been described as a quantitative marker of the ovary. But this is wrong. AMH is not only a quantitative marker of the ovary. It seems also to be a qualitative marker of the ovary. Why? Because when you have oocytes, within these oocytes you have your genetic information. And it seems that independent of age, your anti-Müllerian hormone is predictive not only for the number, but also for the quality, with other words, also for the genetic information of that oocyte. And that has been highlighted in several studies which have been published in the past. So it is not only a quantitative marker, it's also a qualitative marker. Now, obviously, you also have antral follicle count. I always say what you see is what you get. You see something and you know you're going to get that. And I think that's important to highlight. Now, when you look at folliculogenesis, it's a complex process. Not all of it is fully understood, but obviously you go through a certain process of follicular development, starting from your primordial follicles, primary, secondary, pre-antral, antral, pre-ovulatory corpus luteum, and so on. So basically this is the process, and the whole process takes, we don't know exactly, but most probably 5-6 months. That is what it is taking. Now at a certain point, you are gonadotropin dependent, but at some point you are gonadotropin independent. But what is important is that the anti-Müllerian hormone, which is produced by primary, secondary, pre-antral and antral follicles, is not produced as a marker, is not produced as a qualitative or quantitative marker. It has a different function. The function of AMH is in fact to prevent very small follicles, primordial follicles, to be recruited. So it's basically there to prevent that all the follicles would be recruited. That's the primary task of anti-Müllerian hormone. Now we know that, and this is something very interesting, I learned that 2-3 years ago. I didn't know that. Did you know that most of AMH is not produced by small follicles? the highest amount of AMH is produced by the follicles that you can see. So 70% of the AMH that you measure in the systemic circulation is produced by the follicles that you can visualize. What you see is what you get. And once the follicles become bigger, 8-9 millimeters, it stops producing. Now obviously the old scans didn't have very good resolution, but I think you all agree today with the new scans that we have, you have really a good visualization of the number of eggs that you're having. And obviously with the more modern techniques of 3D, you have much better imaging system. So if you take a look at the serum AMH, the very, very small ones, apparently they are not vascularized, so there is nothing being absorbed or produced, but what you see is basically here. And the most of contribution, the highest contribution of AMH is basically from early antral and antral follicles. So the biggest amount of AMH which is produced are by follicles that you can see on your ultrasound. Now, up to 8 millimeters, we know that those follicles are producing the AMH. And this graph beautifully demonstrates how the production of AMH is going and how you see it's going down. And you see the highest amount is at 8 millimeters. Once you go to 9-10 millimeters, you have a drop. So they stop producing AMH. Also, if you stimulate a woman, obviously when you have a multifollicular growth, those follicles will stop producing because they're becoming bigger. So you see a significant drop. Now, when we know that up to 70% of the AMH is produced by follicles you see, the antral follicles you see. If I would ask you, is the AMH a reliable marker? I would say yes. On the other side, you all have seen, you see a patient today, she has X amount of antral follicles. You see the very same patient after 1 month or 2 months or 3 months. Will she have the same antral follicle? No. This is called inter-cycle variation, meaning between the cycles you will have a significant different antral follicle count. Now if you know that you have, I don't know, 25-30% intercycle variation, and if you know that 70% of your AMH is produced by your antral follicles, you can make your calculation how your AMH will differ simply because of what we call biological variation which is present. The other problem with AMH is, and this is something which most of us most probably don't know, is that the AMH itself has isoforms. It's like FSH. FSH has isoforms, also AMH has isoforms. So basically you have the pre-pro AMH, you have the pro AMH, AMH and C, and what we do, based on which assay that you are using, there are proteins on the surface that is capturing that area in order to measure your AMH. So you see, these are different assays. This assay is capturing here, this assay is capturing here, this assay is capturing here. So based on the spikes of the proteins that you have on the surface of the AMH molecule, these assays capture how much AMH you have. I cannot change the slides anymore. Okay. So if you take a look at the AMH molecule itself, so you will see that there are fragments, and these fragments based on the isoform will be expressed differently, and the measurement will be differently. So as you can see, you saw the picture previously, based on the spikes of the proteins that you have, each assay is going to capture a different area, and this is important. Now, this is why also different assays might give you different results, because they are looking to different areas of that particular molecule. So this is why we know that there are significant variations between the assays. So as you can see, within the assay you have up to 20%, and between the assays obviously you have higher variation when you measure. Now what we know is that basically with ovulation you always have a significant drop of AMH in a natural cycle. So in a natural cycle you have your follicles, but when you ovulate there is always a significant drop. But what is more interesting, we have seen that there is intercycle variation. So between the cycles you have a variation, but you also have intracycle variation. So within the same cycle, you also have a variation of more than 20%, and obviously up to 30% between two cycles. So these are papers we have published over the past 4 or 5 years. Now you know when a lab is measuring the AMH, I always compare it, it's like you're taking a bus. Let's say you go from here to the next city, and the bus has 50 places. You go with 1 passenger, or you go with 50 passengers. Obviously it's more economic if you take 50 passengers. So the same is with AMH. You run 1 patient or you run 50 patients with this assay. Obviously you're going to wait until you have 50 patients until you're going to run the system. So what do many labs do? They freeze the sample. They freeze the sample until they have the 50 passengers, then they run the test. But what happens if you freeze that sample? If you freeze that sample, you can have up to 230% variation. I mean, there are several studies looking into it. So imagine you have variation if you freeze. You have assay variation. You have intercycle variation, intracycle variation. So add this all together, then you see how reliable it would be to rely only on AMH. Hence, this is why we always say AFC is more reliable. Now, this is some data. These are some data that we have presented. Dr. Laura presented at last ESHRE. So let's say you take patients with Bologna criteria, poor responders, and then you look with the same stimulation, what would be the range that you would get with these patients. So you see the range of the number of eggs with the same entity, with the same group of patients, differs from 1 to 14. It's huge. 1 to 14 with the same range of patients. So this is another point to make sure that we do not simply rely on it. Now, I'm going to share with you a very interesting clinical case which I have seen last year and which I had asked Dr. Laura to write it down. And the paper was accepted yesterday, coincidentally yesterday, for publication. So it's going to be, you see, data which are going to be published in the next 2 to 3 months because it just got accepted in Fertility Sterility Reports. So the patient is a 33-year-old woman. She was sent to me with a normal BMI. She was sent to me by a gynecologist being in the menopause. And she wanted to have 1 more child. AMH was 0.08. So this is a patient who was referred being in a menopause, and she was indeed in secondary amenorrhea, and was referred to do a final trial of IVF possibly with what she has left. So we did a scan with her, or I did a scan with her. Do you know what I saw? The most severe PCO you can imagine. The most severe PCO that you can imagine. But her AMH was 0.08. So how is it feasible? How is it possible that you have a patient who is on paper in menopause, on ultrasound, PCO-like ovaries? So what we did, we collaborate with a lab in the US, Anschlab in Texas. So we communicated with them. We said, guys, can you please run this with different assays? So you remember you have different spikes. Every assay is capturing a different information. So let's use different assays and see whether with different assays we're going to have different results, because obviously it's in contradiction with our clinical finding. So what they did, they used, as you can see, different assays, and all of them came out almost close to 0. And we said, okay, let's have a look at inhibin B but the inhibin B production was okay. So there was no problem with inhibin B or estradiol production, but there was a problem with anti-Mullerian hormone. And that not with one assay, not on the same day, on different days, and all of them came close to zero. So that was indeed a very interesting case. So what we said, okay, there must be a problem with one of these spikes of the AMH, which the assay is not capturing. So we did a whole exome sequencing, and what came out? It came out that she has a gene defect on chromosome 19, which is homozygote, and basically this is leading to an abnormal expression of the AMH, called AMH gene variant. And this has been for the first time described, and it's going to be published in the next few months. So this was a very interesting case that you cannot really always rely on AMH. What you see is what you get. So if I put everything together, AMH versus antral follicle count, we know that AMH has analytical variabilities. There are no standardization across assays. You have seen different assays use different spikes, different proteins, so they might give you different results. And also the technicalities play a role. Who is working in the lab? How detailed are those people working in the lab? You know, when we moved first to Abu Dhabi, I took the sample of one patient and I sent it to 10 different labs. Same patient. I just wanted to know how reliable it is. I had 1,000% variation. So these are also the analytical variations that you have, and I can tell you it's also very present within India itself, because I have seen different labs with different results. It's not always very reliable. And of course, as you have seen, you have significant biological variations. It's normal to have intercycle variation. It's normal to have intracycle variation. It's normal that with ovulation it's going down, because most of AMH is produced by your antral follicles. Keep in mind, the biggest amount of AMH is produced by a follicle of 7 to 8 millimeters. This is contributing to a lot of AMH. AFC, it's easy to perform, non-invasive. It's very dynamic because the biology, the physiology of a woman is dynamic. It's not static. Hence, it's important to see how the body would react to a certain way of stimulation. And again, seeing is believing. What you see is what you get. Thank you very much for your attention.
I think, should we invite questions or at the end?
As you wish.
I think we have enough time, so
Yes.
if there are any questions, floor is open for discussion now. Till somebody asks a question, I just wanted to sort of put forward my observations. What we have seen is when the AMH levels are on the lower side, if you see more AFC, more often than not, the pattern of oocyte recovery will follow the AMH rather than the antral follicle count, because we know that also atretic follicles or non-active follicles will also show up on the high resolution ultrasound. So that is an experience that I feel.
Yeah, absolutely. And you know something we are observing, sometimes you have a patient who has an AMH, I'm going to say something, 1 nanogram per ml, so not on the highest side. And this patient might have 3 or 4 eggs, or the same patient might have 15 eggs. So with the same level of AMH at the same age, you might have lower harvest of eggs or significantly more eggs. But it seems that with lower AMH, if you harvest more eggs, you do not end up with more good quality embryos. You'll have a big loss. And the second observation what we have is, it seems also to be linked to the estradiol production per follicle. Because if the AMH is low, it means also the granulosa cell activity is not very active, inhibin B is less, estradiol is less. So when you stimulate these women, the estradiol per follicle is also less. And it seems to be linked also to the quality. So with the same amount of AMH, you can harvest more or less eggs, but if you have more eggs with low AMH, the quality of those eggs is less.
Would women with who have, sorry, go ahead.
Sorry, sir. It's about the case study you just told us about, the paper which is accepted now. I saw that she is a multipara, and we saw that her AMH was very low, and in various labs it was found to be, and finally we came to know that it was a gene variant. But then she had conceived earlier, and she is only 33 years. How do we find out such patients?
You know, this patient basically has no infertility issue. The question that you could ask me, why do you see the PCO aspect? That's the question.
Yes.
Does anyone have an answer to that?
Yeah.
Because I just explained it in one of the slides.
So because of low AMH, maybe the FSH is high?
No.
AMH has an inhibitory effect on the recruitment.
Can you give the microphone to Dr. Parul, please?
So I think it's because AMH has an inhibitory effect on the recruitment of follicles. So.
Absolutely. So you have seen AMH is the handbrake of the primordial follicles not to be recruited. But AMH is not doing the job because there is a problem with the structure of the AMH, so it does not cover the receptors. It's not doing what it's supposed to do. So what is happening with this patient? There is no break. The follicles are being recruited, and by the way, one of the proposed treatments for poor responders would be to develop an anti-AMH, that you would block the AMH to take away the inhibition of the small follicles to be recruited. So most probably when the patient was younger, it was like a PCO patient, but once a while she was ovulating because she used to have some cycles, irregular but some cycles. And now with age, she went to a complete PCO-like environment. She didn't ovulate. This is why she had infertility issues. But I think this is an important point. This is also what we described in the paper, that she had these PCO-like ovaries because there was no inhibition, as Dr. Parul correctly mentioned.
And was this the reason for her amenorrhea also now? Because
Yes,
that
yes,
is surprising
yes,
why.
Yes, absolutely. Please.
You mentioned that AMH is a qualitative marker as well. It is not like what we taught is like it is a quantitative marker. So I would like to differ in that, because in clinical practice, if we see women with 40 years of age or more than 40 years of age and AMH is normal, like 4 nanogram per ml, but still we cannot find good eggs and good embryos. So how can we?
You know, 2 days ago, before we had the workshop and the congress in Dubai, we had a research meeting where we were analyzing our own data, because I had the impression that patients with low AMH, independent of age, forget the age, have significantly higher chance or risk of having had miscarriage or ectopic pregnancies in the past. Because I believe most of ectopics are not because of tubal factors, it's because of aneuploidy, because the embryo implants where it's not supposed to implant because it's aneuploid. And what came out, it's a beautiful graph, and we're going to publish it soon. So we just analyze it, the data is there, so we're going to publish it in the next few months. We saw, and if you look at the graph, let's say you stratify less than 35 and more than 35. Let's look at less than 35. You see the prevalence of miscarriages is like this, and then when the AMH goes normal, the miscarriages go down, and then when the age goes up, the miscarriages go up again. So basically what we see is that independent of age, low AMH is a sign of aneuploidy. It's a sign of aneuploidy. But then you have to be cautious. You might say, but some papers did not demonstrate it. Yes, it is true. Some papers demonstrated. We demonstrated it. Lamarca demonstrated it. Fanchin from Paris demonstrated it. But then Juan Garcia Velasco did not demonstrate it. Some others from EV did not demonstrate it. You could say, why are there contradictory reports about this issue? And in German they say, the devil is in the detail. The devil is in the detail. So you have to look to detail. Now if you have a young woman with a low ovarian reserve, The question is, why does she have a low ovarian reserve? Does she have low ovarian reserve because a surgeon who was hyperactive destroyed the ovarian tissue with a cystectomy somehow when she was younger, but the remaining eggs are genetically of good quality? It's just iatrogenic reduction of ovarian reserve. Or is she born with low number of eggs, or possibly has cancer in the family, because this is linked to DNA repair damage mechanism, as we published in Fertility Study last year. So there are multiple reasons why you have low ovarian reserve. So most probably the etiology why you have low ovarian reserve is a contributing factor to the quality and or quantity of your eggs. So this is why personally, I believe if the patient didn't undergo any surgical operations in the ovaries and she has low AMH, for sure it's not only a quantitative but also qualitative marker. If you ask me, do I prefer to see a 40-year-old with an AMH of 3 nanogram per ml, or I prefer to see a 25-year-old with an AMH of 0.2, give me the 40-year-old, because I know she will get pregnant.
Thank you very much, Professor Fatemi. It's my pleasure now to invite Professor Luca to give his talk on how to define a suboptimal responder. He is the scientific director of the of SIS-MER, which is the Italian Society for the Study of Reproductive Medicine, and he holds the position of scientific director at IIARG and IIRMSA in Lugano, Switzerland. He's also an honorary professor at the School of Biosciences of the University of Kent. He's an author of more than 290 papers in the international scientific journals, and publisher and co-publisher of 9 books. He's also an active member of several international scientific societies, and we've had the pleasure of listening to him at various conferences. Dr. Luca.
Yeah, thank you very much. The topic of my presentation is a topic that is not really easy to speak about, because it has different point of view. First of all, as you can see, I asked to Dr. Ferraretti to join the presentation because she's the senior author of the so-called Bologna criteria. First of all, why we should define suboptimal responder, and then suboptimal to what? Because are we talking about suboptimal response to multiple follicular growth, or are we talking about suboptimal response to oocyte recovery or to insemination because we have very few eggs fertilized, or a suboptimal response to the embryo development, or to the embryo viability, or even to the uterine receptivity? So first of all, suboptimal response, probably here we would intend to multiple follicular growth and oocyte recovery, but sometimes we are struggling to get one extra egg, one more egg, and in fact we don't have the full vision of our clinic, of our laboratory. Just to give you an idea, if you look at what is happening in our labs at the time in which cells cleave, you see how chromosomes are desperately trying to find their way to be in the right time, at the right time, in the right place. But if you take data from the literature, and in this case I want to show you the data from this paper. So here you have centers, they are all American centers, or centers in the United States, where oocyte donation program has been put the data together. And you see here, for each center, the percentage of euploid or aneuploid embryos that have been generated. What I want to show here is that despite we are talking about the best possible viable eggs that are around, because they all belong to the oocyte donation programs of these centers, the huge variability between the centers in terms of quality of embryo produced is amazing. In underlying one single factor, that is that in fact we can get one extra egg, 2 extra eggs, but in fact if the lab is not working properly, all this really has very little to do with the final result, that is the term pregnancy. So the problem is how should we define a suboptimal responder? Is a suboptimal responder, and in this case I'd like to go back to what you just heard, a poor ovarian response, or because of previous surgery, exactly what Human has just finished to say, or a patient that underwent chemotherapy or radiotherapy, or would we have a suboptimal response in an advanced maternal age patients? We have only two instruments to try to understand if there is a suboptimal response. One is the so-called Bologna criteria that, as you probably are aware, is very simple system to classify the poor responders. So advanced maternal age, or one previous poor response, that means no response or less than 3 oocytes, or an abnormal ovarian reserve test. But is also accepting the 2 episodes of poor to maximum stimulation that for us are sufficient to define the patient as a poor responder. On the other hand, there is another classification, the so-called Poseidon classification, where the patients are divided into 4 groups, and they are divided according to their age. You see, less than 35 or more, and they are group 1 and 2, unexpected poor or suboptimal ovarian response, while the group 3 and 4, they were in some way expected, so closer to the poor of the Bologna classification criteria. It's interesting because unexpected poor is a difficult definition to say. What does it mean, unexpected, in this case? So in fact, when you look at the age, for instance, and you look at, in this case, at our data, you see that from the age of 35, 37, you look at the number of eggs here. Apparently, if we stick with this classification, we have all these patients that will be considered suboptimal or poor responders. That is not the case, because of course you cannot expect that you can classify all these patients, thousands of patients, only on the basis of having 7 or 8 eggs to be poor responders. So when you look at almost 500,000 cycles from the data from Sunkara, you see that even here 40% of the total cohort is based here. And only a minority, in fact, is lower, and you have between 10 and 15% of the cohort that is around 4 and 6 oocytes. So what could be called moderate poor, the mild end of the spectrum. When you look at these two classifications, how they have been accepted from the scientific community, you see here the percentage of the number of citation of Bologna criteria that when you compare to the Poseidon citation, again, you see that after a few years that the paper is around, there is a tendency to plateau the number of citations, but again, apparently the majority of the authors, they prefer to stick with something that is more clear, more strict. So poor responders more than suboptimal responders. So how can we define, anyway, the suboptimal responder? Well, these are the concepts why we should define suboptimal responders: to choose the most suitable drug, to choose the most suitable doses, to personalize the treatment, to evaluate maybe specific regimens, but again, also to allow comparison among the different studies, and to try to select a more homogeneous patient population for future trial. That's probably the reason why we should define, if you really want to define a suboptimal response. But what can be considered an optimal response? So, because once that we have the definition of optimal response, that we can classify patients that are suboptimal responders. Probably the definition could be that the response that offers the best chance of ongoing pregnancy and the most cost effective. So, is that still correct? Talking in terms of number of oocytes that depend on ovarian reserve, that is also related to age, or the probability of a pregnancy that depend not only on the quality but also on the quantity. And furthermore, all the patients should have the same definition. Let me try to explain you better. When we look at the age of a patient or poor ovarian reserve, or when we look to poor responder patients, actually we are looking for the quality of these eggs. There will not be many, but at least we want to have a quality that is acceptable for all the process. But when we look to patients that most of the time are younger and they have to go in programs like PGT for monogenic disorders or for structural arrangements, or when we have a severe malfactor, so we know that we need possibly more eggs because the fertilization rate and the development of the embryos would not be optimal, or when we look at patients that are coming to our clinic for oocyte freezing or for social freezing, in fact, we are looking for quantity of eggs. But when we have in front of us patients that are PCOs or have severe endometriosis, or they repeated more than once or more than twice a failure in the treatment, or when they had at least 2 or 3 miscarriages, so they are recurrent miscarriage patients, we are going to look for quality but also for quantity. So the definition, in fact, of suboptimal, again, should also be considered according to the type of patient that we have in front of us. Even to be more clear, the majority nowadays thinks that the correct number of oocytes is between 10 and 15. Some also believe that between 12 and 18 is the right number to be considered an optimal responder. So everything that is below should be suboptimal. But are we sure about this? I mean, a young PO for premature reduction of ovarian reserve, which we collect 6 or 7 or 8 eggs, should be considered, in fact, a suboptimal responder? I'm not so sure about this. And what about those patients in which we are doing a very simple stimulation because they are easy patients, and we collect 6, 7 eggs? They should be considered as suboptimal responders. Take, for instance, the data from these papers. You give 100 milligrams of chromosine citrate for 5 days, and then you give a maximum amount of 500-600 units of FSH, and then you look in a program in which you expose this patient to a maximum of 3 embryo transfer, and you consider the program that is concluded if the 3 embryo transfer are done or if a pregnancy has gone to term. And then you end up with a group of patients that, of course, they are the best patients that you can have in your clinic. So they are young, they are naive, they have no severe malfactor, no endometriosis, the ovarian reserve is normal, they have normal regular cycles and possibly normal karyotype. And when you look at the results in terms of term pregnancy, so babies born, inside 3 transfers, it doesn't matter if they are fresh or frozen, you end up with 75-72% of women that deliver the baby, despite they had, as you see, a limited number of oocytes collected, around 5-6 eggs. And what is interesting is they are locked in this system for which we can guarantee to them 3 embryo transfer, and you stratify them by age. In fact, the cumulative live birth rate, it doesn't change between this group and this group for a very simple reason. The older ones are exposed maybe to 1 extra embryo transfer, but in fact, at the end of the day, all of them got what they wanted in the same percentage. Again, talking about full-term pregnancy. Should we consider them poor responders? Or suboptimal responders? I don't think so. And that is the same for women in which you collect less than 10 eggs and they have a conventional stimulation with a normal reserve. Again, why they should be suboptimal? Or when you collect less than 10 eggs in older women with physiological reduction of the reserve, would you consider a suboptimal response of 40-year-old woman in which we collect 8 eggs, 9 eggs? Or for other special programs, like for instance, patients in which you collect a limited number of eggs when they are going to enter a PGT program. So, In other words, the criticism that has been done for Bologna criteria, I think, is not justified all in all. The Poseidon criteria can be used to identify more homogeneous population to test the interventional trial. This is what has been said. But in fact, when you look at this so-called unexpected poor ovarian response, so with a low prognosis group, so group 1 and group 2, that they also have divided in terms of number of ovocytes, as you can see. So they are the young and they are the older. In fact, when you look at the so-called subgroup A, most of these women are simply hyper-responder, and they could have a much better response if we just change the protocol, if we increase the dose, if we modify even the use of the drug. So none of these women actually belong to the poor responder according to the Bologna criteria. And only few of them, in fact, will repeat the same performance if you change the protocol. When you look at the subgroup 4 and 9, so the subgroup B, again, even these women are mild poor responders. So again, these two groups, in fact, do not clearly define what a suboptimal patient is. And when you go to the other two groups, so the low prognosis groups, so that are called group 3 and group 4, again, less than 35 years and more than 35 years, again, they are expected poor responders. So they, again, most of them go to the Bologna criteria concept. So when you compare the two classifications, you end up with this graph that is quite simple to understand. Here you have Poseidon 1, 2, 3, 4, no Poseidon, and here you have Bologna criteria and no Bologna criteria. And in fact, when you look at the group 1 and also to the group 3, there is no statistical significance in terms of the euploid rate. And also between no Poseidon and Poseidon group 1, the cycles, which there is at least one euploid embryo able to be transferred, again, there is no statistical difference. So in other words, this classification doesn't seem to discriminate properly when you compare to the more drastic concept of Bologna criteria, where the difference is quite huge. I'm just saying this because deciding in one way or another to define a suboptimal response is something that I'm not so sure that is so important in our clinical practice. I think it's better to be more drastic, just looking how to treat differently the poor responders instead of subclassifying patients according to the Poseidon patients. Why? Because if you look at the Poseidon classification, in fact, you have different group of patients, including, of course, what has been defined as a poor by the Bologna criteria. So, in other words, we are not sure that the Poseidon criteria can be used to have a more homogeneous populations to test interventional trials that are different. It was also proposed to change the definition of poor based on a combination of heterogeneous criteria to a concept of low prognosis. Again, if we do this, then we will mix again patients with different basic profile in terms of response to the stimulation. So also this I don't think is justified. So the primary goal of the Poseidon criteria is to offer clinicians a pragmatic system to guide therapeutic management. But in fact, most probably this is not the case when you go to clinical practice. There are being published recipes how to handle patients once they are divided according to Poseidon criteria. But if you look at this paper, you find that again, data are not really very much consistent. This one doesn't work anymore? Oh yeah. So, to conclude this part of my presentation, if you look at what is in this human reproduction update review, I think that it's interesting that we can summarize everything here. Choosing to define the population based on the Bologna criteria appear to be a safe approach, because they are actually really discriminating the poor responder. If the researchers opt for more relaxed definition, including a group of suboptimal responders, they should be prepared to justify the decision. And that is also the same thing that is happening in a day-by-day IVF routine and in our clinics. Now, in fact, if you look at the criticism, well, I disagree on this for the reason I just told you. The primary goal is to guide the therapeutic management if you use Poseidon, and that could be done, but has not been done yet. The Poseidon criteria can also be used to identify more homogeneous population. I don't think so. And I don't think that it makes any sense to try to, again, mix together different group of patients. There are other pieces of information that are coming out. I invite you to read this paper that is just coming out. It's in the proof now, where the authors, the ART clinic authors, in fact, revitalize the concept of having FSH tested at the beginning of the cycle. Mainly because, as it was mentioned by a human being before, there is an intercycle variability that it makes sense to look after, mainly those patients that are borderline between being inside or outside the Bologna criteria. And here you have the data that, again, I like to show you with a strong correlation between IMH categories. They have been divided by categories, and also, again, they have been divided by the antrafollicular count categories. And you see that there is a relationship between FSH, the level of FSH at the beginning of the cycle, and the performance in terms of follicular growth and ovocytes. Now, why don't we change completely the paradigm? We are still keep going with the same concept, more eggs, better quality, and we complain if we have one egg less. Why don't we change completely the concept? Why don't we start from the end? We need, in a young patient, 3 blastocysts to give to her the chance, one by one, to have 70–80% of delivery? Okay. How can we get these 3 blastocysts? We need a certain number of embryos at day +3 that are able to cleave further down. And the gap between these embryos and these blastocysts, depending on many factors, not only of the female but also of the male. Don't forget the severe male factor can impair the development of the embryos from day +3 to day +5. To have this number of day +3 embryos, you need a certain amount of fertilized eggs. And to get these fertilized eggs, you need a certain amount of ovocytes that you collect. This not necessarily has to occur only in one shot. Because if you have a poor responder or a patient that on Bologna criteria, or if you prefer a suboptimal responder, you have few follicles, few eggs, few fertilized, few embryos day +3, and maybe just 1 blastocyst. So instead of using that blastocyst, that most of the time will not bring to the success that you are explaining, if PGTA is done, it's better to freeze these blastocysts, wait to do the analysis, go back to the patients, repeat the treatment. She will perform almost the same, getting maybe another blastocyst, doing biopsy. Don't do the genetic test, freeze it, and do this again until you get the blastocyst that you were agreeing with the patient to get. Once that you have all the blastocysts, you can go ahead either with the transfer or even better with the PGT analysis. So an accumulation of blastocysts, then the patient will know out of 3, 4, or 5 blastocysts how many transfers she will be entitled. And since they are euploid embryos, and if the uterus is okay, it doesn't really matter, but the success rate will remain the same as she would be a normal responder. So the paradigm would be engage our couples in terms of a number of blastocysts or a number of viable embryos that we need to reach a certain success rate. It doesn't matter, as far as the agreement is done, how many ovocyte recovery or how many stimulation you have to do, as far as they really understand that this is a program. Because, to conclude, if you look at the proportion of cycles with the trophectoderm euploid blastocyst in the group of patients over 38, you see that the majority, not, but almost 42% of the cycles had 0 blastocyst euploid to be transferred. And one patient out of 4 has only 1 blastocyst to be transferred. So if you want to reduce this column and go more on the right direction, you need more ovocytes, 10, 11, 20, and again you have the percentage, the proportion of trophectoderm euploid blastocysts in relation to the number of collected ovocytes. So you need to engage these patients in having more than 1 ovocyte recovery. And if you do so, you end up that you can calculate the number of pickups in relation to the number of collected ovocytes that you need to have. So if you want to have between 11 and 20 eggs, in this group of patients, you need at least 1.5 ovocyte recovery. If you want more eggs to reach the position I was telling to you before, so 3 euploid blastocysts as an average, they have to go between 2.5 and 3 ovocyte recovery. So I stop here, just saying that instead of focusing desperately of having 1 extra egg with different quality, why don't we change completely our paradigm with our patients? It's only a matter to explain to them. Percentage of baby borns, number of blastocysts needed, because of your pathology, because of your age, because your AMH, we need 15, 20, 25 eggs. You need 1, 2, 3, 4 ovocyte recovery. Fine. This is the engagement between the clinician, between the clinic, and the patients. Thank you very much.
Thank you very much, Professor Luca. This was a very thought-provoking lecture. And I do completely agree with you. What comes out the clinical level, how we interpret clinically is very different from whatever is theoretically said. But the limitation that we have in India is of cost. And even though we would like to tell our patients, and we do tell our patients, to pool those sites, there are many of them who cannot afford it. So that is one limitation we have. I think we'll have time for just one quick question because we are already out of time, but one quick question we could go ahead with.
While you're waiting for the question, if you don't mind, just to amplify what you have said, not only in India, but in many countries anyways, there is a matter of economical resources. What you can do is to propose a package, as we are doing, of a certain amount of embryo transfer, and the patients having a huge discount and being engaged also because of economic reasons at the beginning of the treatment. You are moving the concept from one treatment from one cycle to a treatment. Okay?
Thank you.
In absence of any other questions, may I ask you something, Prof? So the limitation, another one that we see in India is amongst the places where we are doing donor egg stimulation, the law itself limits us to around 7 or 8 oocytes that can be used per patient. In that kind of condition, how do we improve our stimulation so that we have less but better oocytes, because we really cannot get more oocytes from these women, from the donors?
We go back to what Human was saying. It depends on the reason why you have the so-called suboptimal number of ovocytes that you collected. So there is a huge difference among different patients. So the clinical history and not only AMH or the age should drive you to modify your way of stimulation. And for sure, don't forget that the only 100% proof of a suboptimal or a poor response is when you have done one cycle. All the rest, most of the time, is just predicted. But if you want to know on that specific patient, luckily you have to have one cycle at least.
Thank you.
Thank you.
Thank you so much. For the next talk, may I request Professor Dr. Barbara Lawrence Professor Lawrence is an expert in fertility preservation before cytotoxic therapy in women with malignant diseases and fertility preservation. She has authored and co-authored 97 PubMed reviewed articles in international journals as an esteemed member of ASHRAE. Professor Barbara.
So, good morning to this foggy India this morning. Because when I opened my curtain, I couldn't see anything. I hope it's a bit better now. So, thank you for having me here, and thank you for your kind introduction. So, what I want to talk today about is the question whether one size fits all when we are talking about final oocyte maturation. So, of course, why is it an important question? Because over the last years, we are increasingly tailoring our treatments to the patient's characteristics and patient's needs. But triggering, usually it's like the general guideline, trigger around 17. But we really have to rethink. My medical director is always saying unthink and rethink to see whether this is correct or not. So what do we want to have? When we do an ovarian stimulation, we need to have the M2 oocyte. Because we can have a wide range of oocytes, we can have them from GV oocytes, M1 oocytes, or on the other end of the spectrum, just only degenerated oocytes. But those oocytes will not give us an embryo, will not give an euploid embryo or a pregnancy. So which means this is what we are needing. We need the M2 oocytes. So now I want to take you back a little bit to the textbooks to just emphasize how is the development of the oocytes and what we might have to consider when we see different types of patients. So just briefly, not to bore you, we know that follicular development begins very early in life, approximately the 4th month of fetal life. At this time, oocytes are migrating into the gonadal ridge, thereby undergoing mitotic divisions, which means the number will increase. So when they are arriving at the gonadal ridge, they enter the first meiotic division, which means they prepare to reduce the number of chromosomes. Also then what happens, that some somatic cells from the gonadal ridge will surround those oocytes, and we have very small rudimentary ovarian follicles, extremely small in size. As just mentioned, meiosis starts at this time point, but then it stops. And this is something what we know, that the oocytes are just arrested meiotically for a long time. So then at one point, the oocyte will get an impulse to grow. Right now, we do not know exactly which is the impulse, which is just starting this follicle, this oocyte growth. However, there's quite a lot of growth, so the oocyte is growing a lot, from 40 to approximately 100 micrometer in diameter. And during this process, a lot of macromolecules and organelles are produced and stored. So why? Because those are the ones like the food which will support embryo development for the first days until the embryo is good enough to implant and will be supported from the mother side. Already what is interesting to know that this physical growth of the oocyte is finished at a quite early stage of the follicle development. So we'll have to make sure not to mix up the growth of the oocyte and the follicle development. So for the oocyte growth is finished at an early antral stage, which means significantly before the follicle growth is finished. But just as to remind you, the oocyte is still meiotically arrested. But of course, at one time, the oocyte needs to acquire fertilization competence. And we have to differentiate two different processes, which is one, the nuclear, and the other one is a cytoplasmatic maturation. So let's have a look what happens in a cytoplasmatic maturation. So the oocyte will have to prepare for fertilization. It means it has to be able to fuse with the sperm, it has to be able to decompose the sperm chromatin to form the pronuclei, and in the end also to prevent that further sperm will enter, because we just want to have one sperm in one egg. So the process of nuclear maturation is a process which will lead to a haploid content. So when the oocyte is arrested at the meiotic prophase, it contains a very large nucleus which is covered by the nuclear envelope, and it will be the so-called GV oocyte. So the GV oocyte will break down. This is mediated by a surge of LH. However, interestingly, it's also mediated when you are just releasing the follicle, the oocyte from the follicle itself, mechanically. So after the breakdown, we have the M1 metaphase, and our embryologist, Dr. Ibrahim, you will hear from him later during the day. He had shown that already those eggs we might be able to use, but of course, in the end, we need to have M2 oocytes. So the extrusion of the first polar body will then finally lead to a haploid chromosome content, and meiosis 1 is completed. So meiosis 2 starts then, but the oocyte will arrest at the M2 stage, and then this meiosis part 2 will only be finalized after fertilization. That's a nice overview just to see it again more visually. So the GV, the breakdown, we have the M1 oocyte, then the anaphase 1 coming to the M2 oocyte, but the whole process will be just completed after fertilization. Here just again to give you a visual impression, so I'll just put together the microscopic pictures and the figure. So now, in ovulation, how does ovulation work in a natural cycle? So what we have learned and what we are looking at is that estradiol is our main important parameter, what we think is inducing ovulation. So when estradiol levels are above a range of 200 to 300 picograms per milliliter for approximately 50 hours, this is the stimulus to trigger the surge of GnRH, which consequently will release LH and FSH from the pituitary gland, and this will lead to the rupture of the dominant follicle. However, there are some findings which will have to make us rethink what really happens, because, for example, when you are following an ovarian stimulation, sometimes you have higher levels of estradiol, and you do not have an ovulation, even if you do not have a downregulation at this time point. Further on, what was shown when you give letrozole, which is reducing the estradiol levels, which when you give letrozole to a woman who is excuse me, having regular ovulatory cycles, then this will not have an impact on the time of the ovulation. Further on, what was seen that when progesterone is injected, this will lead to a rise of gonadotropins. And also the group of Dortzev et al. Had shown when a single injection of 5 milligram of progesterone IM, this can induce ovulation, and they have published a case report of 2 cases where they went ahead with injecting progesterone in oil, and one achieved a pregnancy. So what we know from detailed hormonal assessments is that there's a small rise in the progesterone before the LH surge is really coming. And it seems that this small rise, I mean, it's not really extremely distinct, but when you do detailed blood tests, you will see it. So this rise is linked to a change of the basement membrane of the follicle, which is a sign of the upcoming ovulation. So progesterone binds to hypothalamic receptors, and thereby it's like activating the GnRH signaling pathway, and it is inducing the LH surge. So now, of course, we can ask ourselves, what is LH important for? And we know that LH is extremely important to coordinate different events. So it has to coordinate the resumption of the meiosis, the loosening of the cumulus cells, and the rupture of the follicle. So all these events which I have just mentioned, they can even occur without having LH around. However, because then those events are not coordinated properly, and because the fertilization window is quite small, the chance of having a pregnancy is extremely low. So, we just discussed how ovulation occurs in a natural cycle. Now, when we want to induce ovulation, we need a replacement, a substitute, right? Because otherwise ovulation will not happen. So, for the last years, mainly the gold standard was ACG. Because ACG is very similar to LH and it's acting at the same receptor. And when you are looking at those pictures, how the molecules are composed, you can see they are extremely similar. Only ACG, the beta chain, is a bit longer, and this is also explaining the longer half-life time of ACG. However, there are also other substances which can be used, and we are using, for example, often GnRH agonist, especially in cases of a high responder patient to avoid ovarian hyperstimulation syndrome, because if you administer a GnRH agonist, this will release endogenous gonadotropins from the pituitary gland. Also, we could use kiss peptide. So kiss peptide is even acting at a higher level, so it will stimulate the hypothalamus to release endogenous GnRH from the pituitary gland, and then it further goes down the cascade. So now, after I gave you again these basics, let's come back to the original question, which is when to trigger. And before the availability of a pituitary suppression, usually trigger size was like 17 millimeter. Why? Because of course the bigger the follicles became, the higher the risk that maybe ovulation will happen at a time point when we don't want it and when we do not can collect the eggs properly. So when we are asking us our questions, when do we trigger, when do we A, B or C, of course we like to go to guidelines, because this is why guidelines are done, just to help us and to support our decisions. So when we are looking at the ASHRAE guidelines here published, we are a bit disappointed because the ASHRAE guidelines are regarding when to trigger quite vague. It's very opposite to, for example, when you are looking at the recommendations for stimulations, they are quite detailed, but here, looking at the trigger decisions, they just say, have a look at the endometrial thickness, have a look at the hormones, and then case-to-case decision. So why is it like this? Because there are not many studies really looking into the association between follicle size and the outcome. So ASHRAE says, just look into different things, see the patient, the age, the response to the ovarian stimulation, ovarian reserve at all, what is the patient burden, how long is the stimulation, then some objective factors, how are the hormonal levels, and then put it all together and make your decision. And they give us a quite wide range of follicle sizes, 16 to 22 millimeters. So now, question is, does one size fits all? Our patients are different, maybe not as different as those guys in this picture, but still they are different. They are different in age, in BMI, ovarian reserve, how they respond to the medication, and so on. And even we can break it down further. For example, in an age group, in the same age group, let's say we have a patient of 40 years of age, so some will have a good ovarian reserve and some will have an extremely low ovarian reserve. So now we always have to think about those patients what we are treating, and we'll have to sometimes to distance us of what was published. And I just want to show you a few examples. So when we are looking into publications regarding the age of menopause, in Western countries, average age of menopause is approximately 51 years. But then we see 10% of women experience menopause at an earlier age, and some women, really thankfully a small percentage, but some still have a premature ovarian insufficiency, which means before the age of 40. So now let me show what's the patient's characteristics of the patient population we are treating in the UIA. So those are data coming from our center. They had been published by my colleague, Dr. Laura Melado. And as you can see here in this beautiful graph, so blue is a high ovarian reserve, gray is a normal, and yellow the low one. So let's have a look at this group of 31 to 35. In this age category, 25% of patients are already having a low ovarian reserve. Let's have a look to the group for 36 to 40. This goes up to almost 50%. And nowadays, with women following their career, finding Mr. Right a little bit later, postponing the desire to start a family, 50% is quite a high range in an age group of 36 to 40 because social life changed, right? So, and I think it would be also interesting to do this in Indian population to see how it looks like. And there had been some data published by a Spanish group and Dr. Manish Manka, right? So, who also showed that it seems that in Indian population, the ovarian reserve seems to be lower compared to what is published from Western population. So, the group of patients who have a low ovarian reserve, who have like previous failed conventional stimulations, they are a very vulnerable patient population. So, for us in Abu Dhabi and in Dubai, it's also additional more complicated because those patients are not allowed out of cultural aspects, out of religious and law regulations, they are not allowed to go for oocyte donation. So which means each egg, especially in the patient population with a low ovarian reserve, is very crucial and valuable. So now we can often have easy information from the patients themselves. So we just have to ask, for example, what is your cycle length? And we can use this information to tailor patient treatment. Those are data coming from fertility awareness apps. A lot of women are using them nowadays. So this explains why we have a very high number of cycles included in this analysis. And when you are looking here with an increasing age, the cycle length will go down. So which means cycles will become shorter. And this is also something which is really very easy to ask your patients. One of the first questions what we are asking, when was your last period? Was this a cycle length, right? And then what we can see that the shortening of the cycle, it is attributed to the shortening of a follicular length. So it's not the length of the luteal phase, but it's the follicular length which is shortened. And as you can see here nicely, the follicular phase length is going down significantly, whereas the luteal phase is staying more or less stable. So also the ovarian reserve was shown to have a major impact. So those are data coming from a prospective study, and they were looking into the relation between cycle length and AMH. And yes, you can see here, low ovarian reserve, low AMH have a higher odds ratio, a higher risk for having shorter cycle. And again, this is attributed to the length of the follicular phase. This is an older study, but it's a very nice study because it's quite detailed. Of course, because it's older and they did more detailed assessment, the numbers are smaller, so they compared younger age groups to older age groups. Again, here we can see a shortening of the cycle length attributed to the length of the follicular phase. But what is also beautifully shown here is that the maximum follicle size is smaller in the older patients. Don't be, distracted by a not significant p-value. We shouldn't always only look at the p-value, because I think here it's a question of the sample size, and most likely if they would have included more patients into this study, most likely a positive p-value would have come. But the important message is the older women ovulate at a smaller follicle size. Why is it so? Because what we are seeing when our females become older, there's a change in the pattern of gonadotropin secretion. What happens? We are seeing already an elevated FSH at an early follicular phase. And this is also one of our parameters which is telling us maybe there is a low ovarian reserve. If a patient, for example, comes into your consultation, she just tells you she has shorter cycles and maybe outside only the basal hormones had been done, no AMH, no AFC. If you see FSH is quite a bit elevated, this already has to go put up the red alarm and saying that most likely it's a patient with a low ovarian reserve. So those changes obviously happen because there's a decreased production of inhibin by the ovary and also in a change of the production of the GnRH releasing hormones. Interestingly, obviously LH is not impacted. So this early rise of FSH will lead to an accelerated growth of the follicle and also will lead to an ovulation at a smaller follicle size. But not only the gonadotropins are changing, also the hormones are changing. And because we have an elevated early FSH rise, we also see that usually the estradiol levels in the older patients increase faster compared to younger patients. Again here, we do not see a difference in the secretion of progesterone. So now, knowing all of this, how do we translate it into the decision when we are triggering our patients? And unfortunately, there are not many studies published. So I would like to point to this study, which is coming from the group of Norbert Gleicher from the States. So maybe you are aware, this is a center, they are treating many, many patients with an advanced maternal age and with a low ovarian reserve. So what they have observed is that in patients above 43, they have seen a higher risk of premature luteinization of the follicle. Also, when they had been triggering at a standard follicle size of like 19 to 20 millimeters, often they collected overmature or degenerated oocytes. So to change this, they decided they will trigger in future at a follicle size of 16. And they were looking into two different populations. So one patient population was the advanced maternal age, and the other one had been younger patients, but with a poor ovarian reserve. So let's see what they found. So they had, like for this group, for the patient group of older than 43 years of age, they had like two different follicle sizes at triggering very early, which was like approximately 13 to 15, 16, early trigger 16 to 18, and the standard trigger, which was 18 to 20. And as you can see nicely here, the group with the early trigger, meaning being triggered at 16 to 18 millimeter, they had a significantly higher chance for having high quality euploid embryos and having a successful pregnancy. So now let's have a look at a younger patient group. So the ones with a poor ovarian reserve. Here they were looking into two different sizes of triggering, early trigger and standard trigger. And I think the important message is here, when they did an early trigger, they had a higher percentage of having mature oocytes, a lower risk of having atretic oocytes, and in the end this will result to a better chance of having high quality embryos and also having a better pregnancy rate. So I would like also to point to data coming from our own center, because we have a lot of those women. And as mentioned, in our setup, they do not have any other chance, so the egg is the last straw. This is the last way to get a pregnancy with an own egg, because oocyte donation is not allowed. So we were looking into patients who had a failed previous conventional stimulation. We just followed them up like a monitoring, and at the time points and when they developed an own follicle above 10 millimeters, we started to support follicle growth. For this analysis, we just only included patients who had only one follicle, where we had an ultrasound at the day of the trigger and where we retrieved no oocyte or one oocyte. Because for us it was important to know exactly which oocyte was coming out of which follicle size. So in the end, we could include in this analysis 160 cycles. So this is just graphically represented how the trigger size was distributed. Some patients were triggered earlier, and some patients, of course, when they were coming back for a follow-up, the follicle was already like 18, 19 millimeter, and then immediately we triggered them. So what we can see, so out of 160 patients, in the end, so there had been all the patients which had been triggered. 153 patients in the end could undergo an egg collection. 7 patients did not have an egg collection. Why? Because they came to the clinic on the day of planned egg collection. We did a scan before we sent them to the OT, but then unfortunately they had already ovulated. I will finish soon. So when we are looking now into the risk, what are the risk factors for them to ovulate? And it's very clearly and significant that the bigger the follicle size, the higher the risk to have a premature ovulation, and we would lose this valuable egg. So now when we are looking into what is coming out of different follicle sizes, when we want to see, did we get an egg, did we get a fertilization, you will see that there's no difference. And this is good news, because in the end, we know also when we are looking into the chance of having like an embryo which will develop to a blastocyst, we did not see a difference regarding the follicle size. As such, this is good news, because we know that when we trigger at a smaller follicle size, we reduce significantly the risk that a patient will ovulate prematurely and we are losing the egg. And also what we have seen, that eggs coming from smaller follicle sizes, they still have the full fertilization competence, and they can develop to an embryo which can give a pregnancy. And we have seen pregnancies coming out of follicles as small as 12 millimeters. So what's the conclusion? I think we'll have to make sure that we are tailoring our approach to our patients' needs, and we'll have to, even with easy questions, we can get a lot of information. One of the important questions is, what is the cycle length? So usually shorter cycle lengths point to a reduced ovarian reserve. So, and we have seen that those women, they will benefit from triggering at smaller follicle sizes, because it will reduce significantly the risk of losing this oocyte. And as mentioned, we have seen pregnancies coming out from eggs which we retrieved from follicles which were as small as 12 millimeter. Thank you very much.
Thank you, Professor Barbara. A very enlightening talk, and something that always we should keep in mind, that when we have women who are poor responders, older age group, we shouldn't stick to the preconceived dogma of 17 to 18 mm. We should try to trigger them earlier. Any questions? We can take one question.
Thank you, ma'am. Very nice talk. I wanted to know which is the earliest indicator of ovarian aging according to you. Is it the drop in AMH or the rise in FSH? Earliest indicator of ovarian aging.
Well, I think you'll have to take it as a puzzle. You'll have to put the different pictures together, because we have seen just previously from the presentation from Professor Fatemi that sometimes AMH is not reliable. Sometimes we see discrepancies between AFC and AMH. Also what we often see when we are looking at our stimulations, so we see even a patient has like several AFC. When we do the basic scan, we still already see an elevated FSH within the range. So I would not like to just identify one single parameter. I think you'll have to see it as a complete picture. You'll have to look at all the things what we can have. I mean, even if they cannot afford an AMH, you don't want to do a blood test, but at least have a look at the antral follicle count, have a look at the FSH. And we just lately had a publication from my colleague, Dr. Raquel, where we were seeing that even the FSH, which is within the normal range, we might not be able to trust it, because if it's in the higher level, this might already be a very early indicator that something is going on.
Thank you.
Thank you, Barbara, for an excellent lecture. I always look forward to your talks and your papers. And I just wanted to ask you one thing. You know, it's very, we can give a trigger at 16 or 17 or 18. Is there any way in which we could predict that we are going to land up with more M2s and not M1s and GVs?
No, unfortunately
because
not.
that is always the biggest worry and concern, and
Yes.
especially in this age group and in the PORs, that's what you land up with many a time.
Unfortunately not, and you have seen maybe in this graph where we had shown whether the chance of having a mature oocyte or not. I mean, there was no difference between the different follicle sizes. And I think also what we'll have to consider, I mean, when you trigger a normal patient or a patient with an advanced maternal age who has not only one follicle but a few, I mean, also then you will have a discrepancy in the size, right? So when you trigger, but usually you get, I mean, all ranges of oocytes out of those follicles. But I think the important message is not to wait too long. Maybe you don't have to trigger at 12, but don't trigger at 18, maybe just go to 15, something 14 to 16.
Professor Barbara, will it matter how we trigger? Also, when we trigger, yes, we have discussed. But if we don't want to get immature oocyte, would it matter how we are triggering this woman?
So, I mean, those patient population had different triggers, but usually we are taking a dual trigger just to be on the safe side. And we are collecting in those cases also after 34 hours instead of after 36.
Thank you. Thank you, everybody. We close this session and look forward to the next one. Thanks.
Hello. Yeah, thank you so much, Dr. Nalini ma'am and Dr. Richa Jagtap. Quickly moving forward to our next interesting panel discussion, which is on fertility management in PCOS. I would like to invite our moderators, Dr. Sonu Balara. She is Director, ART Fertility Clinics, Gurgaon. She is a well-known IVF and infertility specialist. She is trained in endoscopic procedure and artificial reproductive techniques at the prestigious Army Hospital Research and Referral, New Delhi, and has over 25 years of experience and knowledge in reproductive medicine. Dr. Balara is an avid scholar and has written a book on DNB Part 2 Obstetrics and Gynecology, which was published in April 2012. Our second moderator is Dr. Parul Katiyar, who is a senior infertility expert with over 2 decades of clinical expertise. Dr. Parul holds an MD in obstetrics and gynecology from JN Medical College, Aligarh, and has master degree in human reproduction from the University of Valencia. She has further received an advanced clinical training at the infertility unit at Yale Medical College, USA, and Endrofert, Brazil. She is currently the co-medical director of ART Fertility Clinics, India. I welcome Dr. Parul and Dr. Sonu, ma'am.
Good morning, everyone. So we invite on our panelist. Dr. Meenakshi Dua.
So Dr. Dua is a clinical director at ART Fertility Clinics, Gurgaon Clinic. Welcome, Dr. Dua. Our second panelist for the session is Dr. Shrestha Sagar, who is a senior consultant at ART Fertility Clinics in Delhi. And then we have Dr. Akash Surana, who is a senior fertility specialist at our Vashi Clinic. Is Dr. Akash?
Yeah, he's there.
Welcome,
He's
Dr.
there,
Akash. Yeah.
And Dr. Manjushri, who's a senior consultant at our ART Fertility Clinic in Mumbai. And Dr. Abhilasha.
Dr. Abhilasha is a consultant at our ART Fertility Clinics in Hyderabad. Welcome, panelists.
So today we are going to discuss about the most common scenario which we encounter in our OPD. So anovulatory infertility patients, polycystic ovarian patients in So
as we all know that PCOS is a very common problem, and to start this panel we have a case scenario for a couple presenting with primary infertility.
So this is a female who's 30 years old, and the couple, she has irregular periods coming after every 2 to 3 months, lasting for 3 to 4 days. She has a BMI of 32. She's a non-smoker. She has normal tubal evaluation, and the male has normal semen parameters. So, Dr. Abhilasha, how would you further investigate this patient?
Because her BMI is high and she is having irregular periods, I would like to do an ultrasound to see for any polycystic ovarian morphology, and then we'll further go into the hormonal evaluation.
So only ultrasound, or can you elaborate what other investigations you would like to do?
Hormonal evaluation like day 2 hormones, LH, FSH levels.
To come to a diagnosis, Dr. Akash or any other panelist, what other investigations you would like
First,
to do?
in the history, I would like to know whether the patient has some physical features of hyperandrogenism. Because if she has irregular menses and if there are features of hyperandrogenism, then there is no need for PCOS diagnosis. We will have to come to a conclusion that she is a PCOS. But yeah, definitely I would like to do a sonography also to see whether she is PCOS morphology on that. If all these features are there, then I don't think so need of AMH is there for diagnosis. But for treatment part, if you are going for IVF, then you can do an AMH test in those. For the diagnosis, I think so this is sufficient.
Yeah, sure. So of course, we should also be doing other hormones like thyroid, prolactin, etc. to just rule out if there is any cause for her irregular menstruation. So all those tests came out normal, and on ultrasound we had this picture. So now, Dr. Manjushri, can you please elaborate on this and how do you define it?
So I can see multiple follicles which are probably in the range of 2 to 9 mm. I can't see the sizes over here.
Yeah.
But yeah, and by definition it can be called as PCO morphology if the follicle number is more than 20 per ovaries. And I can see only one plane over here, but probably there are more than 20 in that ovary. So definitely based on this we can consider.
So the latest recommendations of 2023, so they say that per ovary you should ideally be having more than 20 follicles.
But even if you are seeing in one plane and if you see more than 10 follicles, that is also considered to be a PCOM now, the recent guidelines.
So of course, Dr. Shrestha, can you please elaborate on the current diagnosis, the methodology and the definition for the diagnosis of PCOS?
In the current diagnosis, if we are able to see more than 20 follicles in one ovary or more than 10 follicles in one plane, it is known as PCO morphology, and with the clinical or biochemical hyperandrogenism and history of irregular menses, that is included in the current diagnosis, current recommendation for the diagnosis of PCO.
Is there a role of doing AMH in adult population, especially coming to you for infertility?
It is not mandatory for the diagnosis, but it can be included for the adult population, but it is not recommended for the adolescent girls.
Do we have any cutoff for AMH, like they have included AMH in the latest recommendations? So do we have any cutoff levels? If any of our panelists, or Dr. Manjushri, you can comment on that.
No cutoff levels have been defined per se, but they'll have AMH in the higher ranges.
More than 5?
Yeah,
More than 5.
No, they say that because of ethnicity or variation due to age or intercycle or variation, so they have not taken any cutoff for the AMH, but it has been included in the latest recommendations.
And yes, if they so these 2023 guidelines, this is the major difference, that they have included AMH because it is more with time it has become more accurate and more common, and only AMH, even if there is no ultrasound, if it is on the higher side with the clinical features, you can diagnose it as PCOS. And yes, if you have, as Dr. Akash said, if you have irregular menstruation and hyperandrogenism present, then there is actually no need for USG or AMH to clinch the diagnosis of polycystic ovary syndrome. So how would you manage the case further? Dr. Dua, will you like to elaborate?
I will do the baseline hormones just to know how much is her LH, FSH, and based on that I will start, because she has anovulatory cycle, so I would like to give her some ovulation induction. we can start with letrozole. That's the supposedly better than over clomiphene, because more ovulation is more, and the chances of pregnancy conceptions I have also seen. The papers have shown that the pregnancy rates is higher. So we can start with letrozole.
Yeah, very right.
2.5 milligram once a day.
Yeah, very rightly said. So because she has slightly higher BMI, we can probably counsel her for some lifestyle modification. It will be good if she is able to lose some weight and control the metabolic syndrome associated with it. And ovulation induction is the first line of therapy.
Okay, like Dr. Dua has already mentioned, she would like to give her letrozole. So that is the recommended first line of treatment for ovulation induction. And compared to CC letrozole, it improves the pregnancy rate and the live birth rate. And it is an attractive option because it often yields better ovulation rates and has lesser anti-estrogenic effects. So moving further,
would you like to use metformin in such a patient? And what is the role of clomiphene currently? And is there a role of combination therapy also?
Metformin will depend if she really has insulin resistance. So if she is hypothyroid, yes, thyroid metabolism also has role with insulin resistance. So that is an indirect marker that she has, and then we can give metformin. Or if the newer guideline says if the BMI is more than 25, then we can add metformin. Otherwise, it doesn't really have much role. If she's a lean PCO, then it doesn't have a much role.
Yeah, very rightly said.
okay, now the patient has not conceived even after 6 ovulatory cycles with letrozole. How would you proceed further? Dr. Manjushri, can you elaborate on this?
Have we tested her tubal status? We have
yes,
not.
We have already done that.
Okay.
So all other investigations are normal, and we have already done 6 cycles with letrozole. So how would you proceed further for this patient? She's
because she has ovulated on letrozole, there is no role of giving gonadotropin just for the sake of ovulation induction over here. And definitely if she has missed even after ovulation, that means she needs something further. There is a probability of fertilization failure or anything, and I'll advise her for IVF.
Yeah, very rightly.
So according to the latest guidelines, this is the algorithm.
No, so actually, as Dr. Manjushri, you've just elaborated. So if a woman is ovulating on letrozole, probably there is no need to add gonadotropins. There is no role of using gonadotropins for her. And of course, there is not much role of laparoscopic ovarian surgery also in the current management of infertility associated with PCOS. And if the patient still doesn't conceive, we have an option of offering them an IVF treatment because it has got much higher success rate, and an ovulatory woman not conceiving after even induction, probably there are more problems associated which we are not able to identify, and IVF will be a better solution in such a case.
Anyone would defer, like you will straight away move to IVF, or you would like to do any other any of the panelists, if you would like to defer?
If she is ovulating, then we can continue with the ovulation induction. We can change. I think I will like to give 1 cycle of gonadotropin because it's more physiological. Endometrium is more physiological, and we can get better ovulation. We can control LH surge as well in that. But because she's a PCO, she might form multiple eggs, so we might have to switch to IVF eventually. And role of ovarian drilling, that's another option if she doesn't want to go for an IVF. But generally that also doesn't help much. If she was ovulating in those 6 cycles, endometrium was good, then even those drilling is not going to actually add to any extra benefit.
So because of cost effectiveness, anyone would like to do an IUI for some cycles, or you would straight on move to IVF?
We can do IUI. That's just, we are thinking that semen is normal, so
yeah, so
she can just add.
Maybe because she's already ovulated, normal semen parameters, so not sure if IUI is really going to help her. Exactly. She can maybe try for a couple of more months with medication, and then the couple was counseled here and they agreed to do an IVF cycle. And now we present to you the stimulation that we did for her. The first thing is that when we are moving for an IVF, what protocol would you prefer, and what gonadotropin would you like to use? Dr. Shrestha, would you like to elaborate?
So for PCO hyper responders, basically there are two choices. We can use recombinant or we can use highly purified. There is a study published in Fertility Sterility in 2020, and that is a megaset trial, HR trial. In that they stated that highly purified minotropin is much better for hyper responder in terms of quality of eggs and low risk of OHSS.
Yeah, so actually contrary to our perception that we should be using FSH because for women with PCOS because they have a high LH, etc., etc. This was a very interesting non-inferiority randomized trial in which they compared the outcomes for use of highly purified HMG versus recombinant FSH. So what they found was that if you see here, whatever they did, the black graphs are the HMG graphs, and what they found was that though they found less number of eggs in the highly purified HMG arm, however in the end they had similar quality of blastocyst in both the arms, and they had less treatment emergent adverse events in the HPA HMG arm versus the RFSH. Live birth rates in fresh transfer wherever it was possible was better, and even live birth rate was higher when they took all the cumulative embryo transfers in that period. Of course they had that caveat that maybe some transfers didn't happen, but they had a higher live birth rate. This HP-HMG usage was seen to reduce the miscarriage rate as well, even when euploid blastocysts were transferred in a frozen embryo transfer. So probably using HMG is as good as using a recombinant FSH and is non-inferior, and probably because of less adverse events it should be used or preferred to use in PCOS stimulation.
So now further we have started IVF stimulation for this patient, and these are the baseline investigations on day 2. So the E2 is 50, P4 is 0.1, FSH 5.4 and LH 20. So we have the clinician has started with 225 IU of HMG for this patient. Now, Parul.
Meenakshi, you are very keenly looking at the stimulation. Can you please tell is the stimulation okay, and how would you do something different here?
Actually, LH is very, very high. So LH has a ceiling effect, and sometimes follicles may not grow. And I feel HMG dose is also higher for this patient. We can start with 150 or maybe 187.5, slightly lower, so that we can form 10 to 15 follicles and not 30 follicles.
Yeah, so actually use of high basal LH, probably the studies have not really shown much difference in the outcome, but would you like to comment on this profile here on the day of start of antagonist? So antagonist, when the patient came, the antagonist was started and the blood was drawn. So would you comment something over here?
So the antagonist is slightly delayed. Maybe it could have been started on day 4 because LH surge has already come up.
Yes.
That's because of so many follicles are recruited.
Yeah. So here actually we missed starting the antagonist. So we have to remember that in hyper responders and poor responders, they tend to have early LH surge, and therefore in such a patient probably starting and monitoring her early and starting an antagonist a day prior would have been a smarter thing to do. After this, however, we monitored, and because we were worried when we saw, and somehow the antagonist was able to suppress the LH surge and the stimulation was continued. And on the day 8 of cycle and day 7 of stimulation, this was the follicle size, and a day later a trigger was done. That was given, which was given with decapeptyl. On a day prior to the trigger, she had an estradiol level of 3000 picograms per ml. Would you do the same, or would you change something, Meenakshi?
I will go little slowly on this stimulation. It might take 12 days because PCOS is irregular cycle. She need not, eggs should not mature in 10 days or 9 days. We can take it at 12 days, so slightly lower dose. Here also FSH is very high for her. We can reduce dose of HMG so that better recruitment and better growth of follicles are there. this might lead to more of immature, or maybe like we are causing a premature, we are making them prematurely mature, and we'll get more immature or GVs, or maybe poor quality eggs in this case. If we go 2 more days extra at a lower dose, we'll get better quality eggs.
I would prefer instead to give a trigger on day 8 only in this patient, and I would like to add 2000 of HCG also in this patient. That would give a better quality of oocyte. Already the follicles are 19, 18, 17, 15. More than 3 follicles are more than 17. Even your progesterone is 0.8. If you are waiting for 1 day, the progesterone will jump and the quality of oocyte will go down.
Dr. Akash, can you elaborate, like why would you like to add HCG in this patient?
Basically, when we give a decapeptyl, the rise and the fall is generally not that as the physiological. So there is a nuclear maturation, but the cytoplasmic maturation lags behind. And as a result, you may get an M2 oocyte, but the quality may not be good, and you may land up with not very good quality of blastocysts at the end. So it's better before progesterone rises, you give the trigger when the follicles are already ready.
But if the E2 level was here was 8000, would you do the same for this patient?
Depending upon number of follicles also, how many small follicles were there. If there are more than 35 or something, no. 30, even more than 30 I would have not given. But yeah, in this case, if you see they are below 30, you can explain the patient. Yeah, again depend upon the type of patient you are having. If the patient is educated, compliant, if there's going to come for a follow-up, you can explain the patient that giving 2000, you may have slight discomfort. You may explain them the initial features. If they are okay and if they are coming for a follow-up, definitely in this patients you can give. You may add a letrozole in this patient. You may even add antagonist later on to prevent OHHS symptoms.
That is later, we'll come to that.
That is why starting stimulation with a lower dose would have helped probably, so that the number of follicles would have been little bit under control, and then we would be able to give dual trigger.
Yeah, so actually because of a high BMI, the clinician had decided, she's the same patient we've been discussing, that she decided to start with a stimulation of HMG with 225, and probably because there is that thought that HMG is less potent than FSH, and she was using HMG, she decided to use a 225 unit.
But her FSH is increasing, so she's absorbing it.
Yes, so yes, her FSH is increasing and her systemic FSH level is pretty good. And I agree, because all the numbers of follicles on, she was ready actually on cycle day 8 or day 7 of stimulation as per this stimulation, and there is no additional benefit of prolonging the stimulation. It only will increase the estrogen level in the patient, and probably because
but per follicle estrogen is very low.
Yeah. Yeah, but a lot of them are more than 10, follicle total numbers, these are the total numbers. So, next slide.
I would just like to add one thing, like this patient only letrose was given. So even in this patient before, we would have stimulated with gonadotropins in 4th or 5th cycle. We would have come to know how the patient is responding. So on that part, we would have started with a lesser dose. Because if you just see the history with BMI 30 to 225 dose is fine. You don't know how the patient will respond. But if we had a previous history of at least 1 or 2 cycles with gonadotropins, maybe 75 if not, we would have understood whether the patient is having a multifollicular growth. So you could have started a bit lesser.
But I don't think so that how will we be able to compare between a 75 and a ovulation induction protocol versus a protocol wherein you want to stimulate and get more eggs?
I'm not comparing, but if you are stimulating with 75 in patients and you are getting 2-3 follicles, that means the threshold of this patient is less. See, whenever a follicle crosses the FSH threshold, then only the follicle starts growing. So we can just have an idea. I'm not telling that it's a stimulating cycle, I'm just telling you can get an idea. Certain patients may have a hyper response with letrose also, like they produce 2 to 3 eggs. So in this,
and we can always step up in PCOS. We don't have, because she's not a poor responder, we can always step up.
So agreed. So probably we could have started with a lower dose. Antagonist should have been started a day prior, and we need to think again if we did the right thing by giving her an agonist trigger, because as because as per, if you see this graph, this is what Dr. Akash was trying to say, is that with a GnRH agonist, the surge of is very fast, and it is the fall is also very fast. So this causes a very quick luteolysis, Whereas in a natural cycle, the surge happens, then there is a plateau, and then there is a gradual decline. Versus HCG, wherein there is a surge, there is a plateau, and because of its very higher bioavailability and long half-life, it stays in the systemic circulation for a pretty long time. So definitely this is good for oocyte maturity as well as the corpus luteum or the luteal phase of the patient. And because of the rapid luteolysis, sometimes not adequate cytoplasmic maturation occurs, and wherever possible and safe, we can use dual trigger, and you can use a low dose HCG along with an agonist triggering, and of course monitor the patient after the trigger is done to rule out or to look for signs of hyperstimulation. And this is the only pitfall for the use of HCG, that it can sometimes cause OHSS, and it should not be used in patients who are extreme hyperresponders and who are having more than 30 follicles that are growing. So this patient, this was how we would do a stimulation in this patient. Ultimately, as Meenakshi said, she had a lot of immature eggs, but because there were a lot of eggs, we did get some embryos in the end, and that is how the whole cycle was taken care of. There was some learnings, and I hope she doesn't need a repeat cycle, and she'll be able to get pregnant with her embryos that were formed in that cycle, which will be transferred in a frozen embryo because she took only a agonist trigger and they have a deficient LH or a luteal phase after this, and of course they are anyhow at a risk of hyperstimulation.
So Dr. Abhilasha, now how would you prevent in this patient that she may not go into OHSS?
So post pickup, I'll like to give the antagonist, and also I will keep her on letrose, cabergoline, and meprate.
So you would start all the letrose, cabergoline antagonist, you would start all of them, or and what else?
For this patient,
we won't need Dr. Abhilasha. If she was given an HCG and we wanted to be very cautious and we didn't want any OHSS, probably using of course there was a freeze-all that should have been done, and we would follow up with antagonist, letrozole and cabergoline, and of course monitor the patient regularly. I think this is how we would probably do it.
Dr. Meenakshi, can you just elaborate something about IVM?
In vitro maturation IVMS, and it was started with patients who PCO where the risk of ovarian hyperstimulation was very high. This was when we used to do fresh transfers, and because now with frozen transfers and agonist trigger we hardly get to see ovarian hyperstimulation, but when there were times when long protocol was done, and that time in PCOS they used to land up in OHSS, so IVM was suggested. IVM means we are going to aspirate follicles when they are around 10-11 millimeter without giving a trigger, and then mature them inside the lab. So that will reduce, or there won't be any risk of ovarian hyperstimulation in that patient. And later on, once we mature them, fertilize them, grow them as a blastocyst, and then transfer, so the pregnancy, we can achieve healthy pregnancies without any ovarian hyperstimulation. So that's what IVM is in PCOS patients basically.
Dr. Shrestha, do you have in mind any other protocol that you would like to use for this patient apart if you were not using an antagonist protocol? Long protocol we can use, but it's not it should not be used. Better choice is antagonist protocol only.
Yeah,
usually
PPOS
we can do. Yeah.
That's for LH surge, but ATTAC protocol to prevent LH with short protocol only, but with
So basically now we also can use PPOS regimes wherein apart from the short protocol, and it is also equally good and has been shown to have reduced incidence of OHSS in these patients, and the problem that we have, especially with the agonist protocol, that we have to only use HCG trigger, and there is an inherent risk of hyperstimulation that is significantly reduced in these patients. So alternative regimes, not for this patient, but yes, for patients who have had a history of severe hyperstimulation, or yes,
basically obese patients.
Yeah.
PPOS will work very well there. You don't know whether GnRH antagonist is absorbed well or not. and also in patients where already the LH surge was there, like PCOS. So we can start from day 2 itself progesterone.
So sometimes in obese PCOS or obese women, antagonist is not effective, and for those patients a PPOS regime is sometimes more effective and useful in preventing an premature LH surge, and it can be very effectively used in those patients. So thank you everyone for your active participation in the discussion. Thank you very much. Thank you.
Thank you.
There's a question.
Are there any more questions?
Do any of you use the low dose HCG like 200 international unit while stimulating?
In such patients?
Yes, in such patients.
Why are you with HMG? So we use it in certain patients, especially when we see that despite a good follicular response, we don't see a good estrogen level or estrogen secretion. Then in those patients we do use, but mostly not with HMG cycles. Mostly it is being used with recombinant FSH cycles, because HMG itself has a low dose of HCG activity. So that is where we use.
Not in PCOS patients.
Yeah, not in PCOS, but we do use low dose HCG.
Normal responders or low responder, poor responder can be tried, not with PCOS.
Yes.
I don't know if you have noted that one of the side effects of doing IVM is that in the consequent cycles, they try to respond more in bracket normal, so the hyperstimulation risk is reduced because you have done a sort of transvaginal ovarian drilling. So what we do is when we do IVM, in fact we are freezing the few blastocysts that we can obtain, and their quality, at least in our hand, is not very good. But then we start again another stimulation cycle that most of the time it goes in a different way. Less follicles, more competent ovocytes, less ovocytes. So we use IVM also as a sort of transvaginal ovarian drilling. And in fact, in 60-70% of the cases, for a few months after the transvaginal ovarian drilling, the patient have a different response to the same regime of stimulation. So I don't know if you have noted it, but this could be helpful for some difficult patients.
Dr. Luca, I have no experience with IVM. This is only theory, so really sorry.
Okay, but I mean, it doesn't matter. You just do an ovarian drilling instead of doing laparoscopically. You just do transvaginally using one of the needles that are already commercially available. It doesn't matter what you get. Few eggs, GV eggs, difficult to mature, forget them. But then try 1 or 2 months after, you will see a difference. Not in all the patients, but in 60-70% of them.
Okay, thank you.
Thank you so much. Thank
Excuse
you,
me?
panelists.
Yeah. Hi. I disagree with 2 points which are told. Please correct me, seniors, if I'm wrong. One point was that the patient is ovulating, so there is no need to add gonadotropin, it was told. But I think there are so many papers which tell that even in a patient who is ovulating in a ovulation induction with just letrose, just adding gonadotropin itself improves the pregnancy rate. And there is a paper, I'm not able to quote, but it says that adding gonadotropin is as good as laparoscopic ovarian drilling. And
So that was only the like one of the panelists they were saying, but yes, you can add gonadotropins, and with IUI they have more success rate if you try another 2-3 cycles with that.
Yeah, and second point which I disagree is to consider LOD. I think it's obsolete now to use that, because once I think even in the results, once the patient achieves pregnancy, second biggest pain is premature menopause. I think at this time we shouldn't consider things like that. Thank you.
So I think I would just like to correct the young lady, or at least discuss with her that LOD is not obsolete. I'm actually one of the opponents of LOD. However, we have in our country people who cannot afford IVF, and in that section of people, LOD can be very helpful if they have a very bad PCO and not ovulating with all your drugs. They can't afford gonadotropins, they can't afford IVF. So LOD is definitely not obsolete. Please don't say that and don't think it, because there is we have a wide range of affordability in our country. So why should we not give the lower socioeconomic group an equal opportunity to get pregnant? So we have to choose our patients well, but it's not obsolete. And we don't have to, be over enthusiastic about the drilling. Drill in the proper fashion by the guidelines, and the results are fairly good.
Thank you so much.
Dr. Majan. Thank you, panelists, for your.
So thank you Dr. Parul and Dr. Sonu for conducting this panel. We'll quickly move on to our next session, that is session number 2. For that I'd like to invite the chairperson, Dr. Barbara Lawrence. She has specialization in gynecology and obstetrics and prenatal medicine, followed by gynecology and gynecological endocrinology and reproductive medicine. She is an expert in fertility preservation before cytotoxic therapy in women with malignant diseases and fertility preservation for those undergoing cancer treatment and cancer survivor. She has co-authored more than 97 PubMed reviewed articles in international journals and is an esteemed member of ASHRAE. Her main focus is on the treatment individualization and luteal phase support in IVF ICSI treatment. My second chairperson is Dr. Sabhyata Gupta, who is chairperson and Department of Gynecological and Gyneco-Oncological, Medanta, the Medicity Gurgaon, India. She is the first gynecologist to do robotic surgery in India. Her field of special interest include gynec-oncology, fertility preservation, robotic surgery, laparoscopic surgery, and cosmetic gynecology. She has contributed to various textbooks, national and international journals, and is a recipient of many prestigious awards. Dr. Gupta is at the forefront of innovative medical practice and is a member of prestigious organizations such as International Gynecological Cancer Society, the European Society for Gynecological Oncology, and FOXY, and Indian Medical Association. Over to you, ma'am.
So, a very good morning again, or almost good afternoon. So, welcome to the second session. So now it's my immense pleasure to introduce my colleague, Professor Barish Atta. So many of you will know him also from his publications. He is working with our team in Dubai. So he has served at several editorial boards. He is a member, executive member, committee member of the ASHRAE and the president of the Turkish Society of Reproductive Medicine. So he is looking in many different things in ART. And now we have the pleasure to listen to him regarding the impact of endometrial sickness on the outcome. Please, Barish.
Thank you, thank you. Yeah. All right, still good morning. It's a pleasure to be here again. And for the sake of time, let me start with the presentation. Yeah, next slide, wonderful. Yeah, the subject is endometrial thickness and whether it affects the outcome. So what I'd like to do, these are my disclosures, none of which are relevant. And what I'll cover in the next 20 minutes is, I like to take a look at the history, how we got the idea that a thin endometrium may be a bad thing. Okay? It's always good to know the history so you understand the rationale, how the idea evolved, what are the gaps, or how it makes sense or how it doesn't. And then I'll review the studies that led to current practice, and I'll review some of the methodological aspects of these studies to see if they're convincing enough for us. And I'll also try to explain, in my opinion, how a proper study would have been done, and whatever the study is available today, with the current results, with the currently available literature, how can we take a decision on endometrial thickness? So what I've been telling, most of it is published in this recent paper we published in RBM, and I think it's open access, so anyone who is more interested can just read it. So here's the history. You may be surprised that, or let me put it this way. Have you ever thought, when the first IVF was done, actually for the first couple of years, ultrasound was not available at all even, right? So let alone measuring endometrial thickness, they were not monitoring follicular growth with ultrasound. It was, cycle days, hormone levels, laparoscopy, etc. And the first ultrasound studies started to appear like 1984, 1985, which is almost like 7-8 years after the first IVF live birth. And the equipment they used those days initially were abdominal probes with much lower quality images than today. And forget about the quality of the equipment. I mean, our colleagues back then didn't know much about ultrasound. Let me give you an excerpt from one of the papers looking at endometrial thickness, a 1980 paper. They said, we were monitoring endometrium through the stimulation cycle until 2 days before the trigger, because ultrasound could trigger ovulation. So this is really written in the paper. Okay? Or we can't see endometrium if the uterus is retroverted. Okay? Anyway, so that is the level we were, that's the equipment, that's the experience. And then first papers started appearing, looking at endometrial thickness. They were what we would correctly call hypothesis generating, okay? So, or exploratory studies. So IVF was new, they were reviewing their IVF results. Let's say one paper from Toronto, Canada, like by Robert Casper. So we reviewed our results last year, and in a way, we kind of compared everything between people who got pregnant versus who didn't. And yeah, endometrium may be different. And interestingly, nobody with an endometrium of 6 millimeters or less got pregnant. The overall number of women in the study was 120. How many with endometrium of 6 or less is not mentioned. Was it 1, was it 2, was it 10? Probably not. But anyways, that is how the idea and the kind of magic number of 6, 7 first appeared in the literature. Okay? It has been proven that people may get live birth, may achieve live birth with way thinner endometrium. So it's been published so many times, 3 centimeters, like 4 centimeters, 3 millimeters, 4 millimeters, 5 millimeters. Okay? The question would be, are women with thinner endometrium less likely to achieve a pregnancy and live birth, everything else being equal? So let's look at that, okay? The next step to make sense of all these things is, everything should happen for a reason, right? Everything happens for a reason in life. I mean, it's not random. So why, if you assume a thin endometrium is less receptive, then why would it be less receptive? I mean, embryo is a microscopic thing anyways. It doesn't require a particular depth to implant. So this is a study from Japan. It's a well-designed study. What they did is they got endometrial biopsies on the day of ovulation from women with thin versus not thin normal endometrium. And they defined thin endometrium by 8 millimeters, not 6, not 7, not 9, based on their own IVF data, sort of arbitrary. But anyways, still even with that threshold, what they observed is thin endometrium was less vascularized, and there was lower expression of vascular endothelial growth factor, and actually ultrasound indices of blood flow were suggested resistance, and they concluded, thin endometrium is thin because it's not vascularized well enough, it's not oxygenated well enough, and that is probably why it's not receptive enough. Okay? But even before this publication, people already had this idea, and you could find papers, patients with thin endometrium being prescribed aspirin and even Viagra to improve blood flow. Okay? So it's a theory, it's not proven, but we were already treating people. Then Robert Casper, who's a great guy, very good researcher, wonderful scientist, and I think almost 25 years later, or at least almost 20 years after the first paper suggesting the 6 millimeter threshold, he came up with a different theory. So in summary, what he was saying is, over time, we realized that embryos do not do great with high oxygen pressure. The intra-abdominal environment is low oxygen pressure, and several studies showed if you limited the oxygen tension to less than 5% in the incubator, embryos grew better. So maybe it's not having too little oxygen, but it is having too much oxygen when the lining is thin, because when you transfer the embryo on a thin endometrium, so this microscopic embryo is closer to the basal layer, which is better vascularized, the vessels are thinner, higher oxygen tension, maybe higher level of reactive oxygen species, and that's why it's bad. So the point I'm trying to make is, so the idea that thin endometrium, once you rule out other problems, just originates from retrospective fishing experiments. We do not have a unified theory why it would be bad in the first place, and the available theories are 180 degrees apart, like too little oxygen, too much oxygen. Okay? So is there a reason? Is this like convincing? I mean, at least for me, not at this level. But this is what happens in medical literature, especially after electronic publishing. Okay? Look at the number of papers. So this is even like not a recent slide. Endometrial thickness and IVF, 600 papers. So not a solid theory, not a solid whatever. I mean, threshold, 600 papers with multiple meta-analysis. Right? And usually they end up saying, oh, thin endometrium is a bad thing. Right? Let's start with the meta-analysis. Okay. So for meta-analysis to make sense, the studies you include in the meta-analysis, you pull in the meta-analysis, should be, I mean, if not exactly, more or less looking at the same thing, right? Trying to answer the same question. And if you look in detail, those 600 studies measured endometrial thickness on different days. I mean, even sometimes in days that wouldn't occur to you. It's not necessarily the day of trigger, it's not necessarily the day of ovulation, it's not necessarily the day of progesterone rise, always. A lot of different times. And then they do not define thin endometrium with one common threshold. I'll show later. Various thresholds are used, varying between 6 to 14. So I'm not like misspelling, 6 to 14 millimeters. And variety of study designs, and most of these studies, surprisingly somehow, even before concluding that thin endometrium is a bad thing, they report interventions which improved either the endometrium or the pregnancy outcome. Okay? So it's really, I'd say, pretty heterogeneous, to be polite. So an important methodological issue, this is something I really want to highlight, because we tend to be convinced easily when a study is pretty large, right? So when you read a title like 96,000 embryo transfers, so once we analyze 96,000 embryo transfers, we should be very close to truth. So it's convincing. So 96,000, forget about the rest, 599 studies, so whatever this study says, it should be okay. Is it the case? Actually, it's not. Okay. So regardless of the size, even if it was 6 million, what really matters is how the original data is generated. Okay? Is it applicable to your practice? Does it reflect the natural course of events? But one important thing is, while the earlier studies had very small sample sizes, just like 100 patients, 20 pregnancies, etc., statistical significance is a mathematical phenomenon. Okay? So if you have a large enough sample, anything would look statistically significant. Right? Then you have to make sense of it. Is it clinically relevant? So clinical significance is a different thing, statistical significance is a different thing. So while false negativity is an issue with a small size trial, actually when the studies are big enough, everything will look statistically significant, doesn't necessarily mean it is really important. So in that particular study, just to highlight, we eventually sent a letter for it, unfortunately. There are multiple confounders. Confounder it's a variable, it's a factor that is related to endometrial thickness by itself. Let's say estradiol level, let's say the number of egg follicles, so estradiol levels, higher stimulation to endometrium. But it is also related to chance of having a live birth regardless of the endometrium, because you have more eggs, you have more embryos, you have better choices, right? So there is the textbook confounder, and in this study, these confounders were not adjusted for simultaneously, okay? So you can't really isolate the effect of endometrial thickness. It's just an example. The second thing, so using again that same study, but in general, most retrospective studies about endometrial thickness, from early on, like late 80s, early 90s, even when I started training in IVF, and thin endometrium was an issue. People were canceling transfer. Okay, so the patients were denied transfer. Your lining is thin, so come next month. Your lining is thin, we'll do something different next month. Your lining is thin, we'll give you estradiol through mouth, vagina, rectum, ear, wherever, like as much as possible. And anyways, so when anyone did one of these easy studies, I call it easy because you measure endometrium, you register it, it's in the patient charts, it doesn't cost you much, so anyone can do an endometrial thickness study. We reviewed the charts, we looked at endometrium pregnancy rates, but your data, just like that national registry, does not reflect the natural course of events. If you were canceling embryo transfers because endometrium was thin, or if you were introducing another intervention when the endometrium was thin. So what reflects the natural course of events would be if you just continued with your usual management and transferred the embryo on a thin endometrium and then compared, like different thicknesses, that would be, the real study, okay? And is this just an assumption I'm making, or is it really the case in literature? What we did to understand if this is the case, we looked at the prevalence of thin endometrium defined by 7 millimeters or less in the published studies. If people did the same thing, as biology would affect mankind or womankind or humankind similarly, you would expect to see more or less similar prevalence, right? Here, how variable it is, actually in the biggest national registry, it was too low, so which you can say, in Canada, they must be cancelling a lot of transfers because endometrium is thin, whereas this one is one of our studies, like we published from Istanbul, where we were transferring regardless anyways. Okay, so you see the range. So that is why retrospective studies are not necessarily reliable in the context. Then you need to look at the time, what type of equipment was used, blah, blah. But the point I'm trying to say is, if you want to take a decision, a clinical decision, an important clinical decision like transferring or not, when you're not transferring, she's not getting pregnant, so it's really important, okay? So based on any measurement, be it endometrial thickness, be it whatever, you need to be confident in the precision, accuracy, reproducibility of that measurement, right? So endometrium is not a triangular prism made of, let's say, marble, right? So it is a tissue, So it's not even similarly thick at every section. So ideally we should be doing the exact mid-sagittal vertical, right? But even in that plane, it's not a rectangle. It has its curves, so where do you really measure it? Anyways, so the point is, depends on equipment, depends on patient's echogenicity, etc., the position of the uterus that day. How reliable is it? Let me show you this study. It's one of my favorites. It's from Switzerland. Nice, well-educated, prosperous country using good equipment properly, well-trained doctor. Here, 2 doctors do endometrial thickness measurements at the end of stimulation on the same patients without knowing each other's measurements. Right? This is called a limit of agreement analysis. This is the mean endometrial thickness of 2 measurements. This is the difference between the 2 measurements. See the range of difference, 2.5 to minus 1.5. So the range of difference is like 4 millimeters. So that doesn't necessarily mean it's 4 millimeters all the time, but it could be 1 millimeter, it could be 2 millimeters, etc. And then if you have an arbitrarily defined threshold, just variation. So I scan the patient, I say, oh, it is thick enough. Then you scan the patient, no, it's thin. It's the same day, same patient, 10 minutes apart, right? You can say when it's thin, the variation could be less, but the point is, it's not really that precise of a measurement, right? Secondly, how to analyze the data. Let's say you were transferring, regardless of thickness, you have like a kind of a native experiment, you are doing proper measurements. If you observe an association between endometrial thickness and live birth rates, like between any variables, is that association necessarily a cause, does that necessarily reflect a causal relationship? Right? So association doesn't mean causation. One of the most important criteria to assume a causal relationship in the context would be observing a gradient, a biological gradient, a dose-response effect. Right? So if endometrial thickness matters, you would be easily convinced if you saw a linear relationship between live birth rate and endometrial thickness, like saying with increasing endometrial thickness, live birth increases. So it may not be the case in biology all the time, but there may be different relationships like too thin, too thick, U-curved, okay, inverse U-curve, whatever. But you should first visually analyze that, whatever, say, curve distribution and understand what type of association may exist. Then you should, if you observe one of these, then you should adjust your analytical strategy based on that relationship. Okay? So you read a paper, 40,000 cycles, we did a regression analysis, we introduced this and that into the regression, then it came out significant. So that doesn't mean anything. Right? There are different regression models you can fit based on the underlying distribution. Sometimes it's totally wrong to try to fit one model to the wrong distribution, but the SPSS or whatever software doesn't tell you that. Right? So when you run it, it runs it and gives you a number. It is up to you to decide whether that number makes sense or not. Okay? So a lot of other details, I won't get into it. But just reading that someone did a regression analysis and then something came out significant does not mean it's really important. Ideally, the editors should have asked people, how did you introduce these things in detail? And they should have been asked to present a measure of fit of the model to the data, like how well it fits, how well it explains that distribution. Anyways, these are usually actually almost never available in the paper, so beware of fancy statistical terms when you read a paper. And here's what I mentioned when we looked at what defines a thin endometrium in literature, because you read a meta-analysis. Thin endometrium, is it bad? Yeah, it is bad. And what's a thin endometrium? You look at the studies. Can you believe? I was shocked actually. 14 millimeter to define thin endometrium? Like probably 80% of patients will have thin endometrium, or they don't know how to measure it really, to be polite, but anyways. So that is the case. And that brings another question. With all these studies, why, actually if we did a survey here, what is your threshold for thin endometrium? So what I observe in general, people are like kind of like 7. Why? What I come to understand when I look at the literature and analyze everything, so I think because it's conveniently low. Right, so if you choose 8, a higher proportion of your patients will have thin endometrium. It's a problem for you. Then you start canceling, trying to do something. The patient is stressed, you are stressed. If you choose 9 or 10, again, like higher number of patients. So I guess 7 was conveniently low, and somehow by convention, without unwritten agreement, so the profession agreed on 7 or 6. That's not data-driven, absolutely. Okay. So how would be the ideal study? I just explained it should be prospective. Management shouldn't change based on endometrial thickness. So you have the opportunity to observe what happens in nature, really. And then the data, when it accrues, it should be analyzed in the way I described. Look at the distribution. If it makes sense, then you try to explain, make sense of it, and try to quantify. If you find an effect, try to quantify the effect estimate. So what I'm trying to say is, let's say endometrium being 6 millimeters as opposed to being 7 millimeters decreases the chance of live birth by 20%. It is relative, right? So if you are expecting 40%, it would be then 32%. Then is there a way to increase it? What would it take? Is it worth the difference, etc., etc.? They would be different questions if you first complete the other steps. So we have to take a decision today when we see a patient with what we think is a thin endometrium. We can't tell the patient, oh, the ideal study doesn't exist, so I don't know what to do with you. So it's up to you, shared decision making, etc. So I really appreciate involving the patients in decisions about themselves, like empowering them, informing, but this is like dumping the uncertainty on the patient, right? So that would be, so it's not inappropriate. I mean, if you can't make sense of it, how is she supposed to make sense of it? Right? So what should we do? Your endometrium is thin. I don't know if it's a bad thing. It may be a bad thing. I don't have something to improve it. So shall we proceed with the transfer? Then the patient would probably never see you again. Okay. Anyways, so we need to make sense of these with the available data. Then I would prefer to look at the prospective studies. Okay. So prospective studies, they don't suggest thin endometrium is a bad thing. The majority is from retrospective studies. So if you would be doing an evidence hierarchy, we should probably believe in the prospective ones. Secondly, we published 2 retrospective studies, but retrospective in the original data was generated without management based on endometrial thickness. So I had come to think years ago that for me it didn't make sense, and my practice had changed. I was transferring anyways. And with one of my former fellows in Istanbul, we published this like 3 years ago. You see, rule out intracavitary pathology, make sure the pattern is fine, and make sure premature progesterone exposure is ruled out. Then just move with transfer. So it's like, I think we had like close to 300 or 300 something transfers, fresh and frozen. Sorry for the small numbers, but there wasn't a linear relationship or U-shaped relationship or nothing, and it looked, consistent across the whole range, and you got pregnancies at the whole range, and almost no predictive value of endometrial thickness. This paper underwent, I think, again, multiple revisions, multiple rounds of review, like 4 or 5 people reviewed it, etc. Because when it's something against mainstream, it's very difficult to get them published. Then when I joined the team, I realized they were doing the same. They had a data set, and we analyzed it again in a similar way. This paper again went like 4 rounds of revisions in the journal. Every time the referees suggested acceptance, the editor added 1 or 2 more reviewers, which I understand it's a reasonable thing to do, like make sure it's proper. I wish they do it for all the papers. This time we showed just last minute probably the distribution with graphs rather than the table, as in the former paper. This better. You see, this is overall, this is artificial cycles, this is natural cycles. I don't see a linear or a particular U-curved relation or whatever, like U-shaped relationship here, so it looks random to us. Then if you look at live birth rates with thin endometrium, Okay, so in this study, this is all PGTA cycles, almost 47%. Istanbul study was without PGTA, almost 42%, so it's in agreement with the overall data. And if we think, these peaks are, representative of the best endometrium, probably it's not. You see, like, there are these dips, it looks like, random, and if you think this is best, then why don't you think this is also, similarly good? So should you try to aim like 11 millimeters, or if you can't get 11 rather than 8, let's get 5? So, I mean, you can put this in writing if you want to. Someone will buy it. Anyways, so, and this is what happens in natural cycles, so this is something you don't have any control over it. We looked at, if the women in this bracket were different from women in here, naturally, I mean, we couldn't find a significant difference, but though something like they seem to have a tendency toward better embryo quality, but anyways, you need to accept what it is. So again, no predictive value, almost no. So we did a similar thing. Now it's being prepared for full text, 8,000 single euploid blastocyst transfers, this time US data, same results. Okay. And obstetric outcomes, you find papers showing, bad, doesn't matter. You need to reconcile them, is a question. But more importantly, I'm not aware of an intervention that really changes endometrial thickness. So rather than dragging into it, probably if you rule out other stuff, it's in every way, like time-wise, financial-wise, psychology-wise, probably better to move forward with the transfer for everyone. Thank you. And it's the recommendation of ESHRE. It's not something new.
Okay, dear Baruch, thank you very much for this nice presentation and the very clear conclusion. For the sake of the time, so I think we can allow one question. Is there any?
Sure.
There's one more. Yes, please.
So most of the times we take only individual thickness into account, but if we consider all the scorings like Applebaum, so if we see the Dopplers or the pattern or the peristalsis, so do we take all those factors also while deciding whether to transfer or not, or just the thickness is fine?
Okay, so thank you for the question. This question comes very often when I do a presentation in India. Okay, so I understand Doppler is popular here. And endometrial thickness measurement is something very simple compared to Doppler, right? Even that's not reproducible properly. Doppler, you need to find, which vessel, you need to adjust the angle of insonation, etc. It is much less reproducible. Right? And it is, I don't think it's a measurement at that size of vessel that you could take a clinical decision on. Okay, so umbilical artery, it's huge, right? And then even when we take a decision, obstetric decision based on umbilical artery Doppler, it's not about the small numbers or cutoffs. We're looking for huge changes like loss of diastolic flow or inverted diastolic flow. So that is clear. But here, I mean, it's a tiny whatever. You don't even know which vessel you're measuring. You can do the uterine artery, but studies don't really show anything. So I don't do Doppler. I don't recommend you do Doppler. I mean, it looks nice, but just confusing. Ira is already dead, right? Was never live born to start with. So you can say, then all the ERA tests were run in one lab in the world, right? So people were collecting, sending. And did you ever see one paper that showed it's effective over the years despite having all the data in the same place? No. And then recently, in the last 2 years, you saw multiple papers showing that it doesn't improve the results. The concept is nice. It may be the case, but even if the concept will work one day, it's not the era one.
One last question, Dr. Barbara, sorry. Dr. Baris, I just wanted to ask, as we label that endometrium, even if it is thin, would not impact the pregnancy, but my question is, why would it be thin? Does it not tell us something about some infection or something that would have led to that problem?
Right, so good question. Yeah, what I'm trying to always highlight is, we need to rule out other obvious pathology. I mean, like a scarred and thin endometrium is a different than, just a normal looking thin endometrium. So what I'm saying is always refers to, properly trilaminar looking, like normal contour, normal endometrium. Right? So the other things are different. So basically, scar, treat as much as you can. I mean, if you suspect of an infection, but I don't know if really endometritis makes it thinner. I don't know. Anyways.
Yeah, so just a question, because what we sometimes see is women who come after a miscarriage or a curettage, and we do a hysteroscopy. After we see a thin triple line looking endometrium, the cavity looks clean. It's like nice spacious cavity, yet we continue to see a thin endometrium. So the thought here is that probably there was some damage to the basal layer, because of which the lining or endometrium is not growing. Would it really be a cause or no?
We always try to individualize everything. Oh, it's great, fine, but these would be like unique situations. So basically, for that type of patient, do you know if her endometrium was thicker before? That's the first question, right? And then let's say it is now looking lush, nice, but thinner. Is there any way that you can change it? So probably your option, like pragmatically, is still like moving forward.
Yes, so probably it's the option of
rather
moving
than
forward,
cancelling and cancelling and cancelling.
Yeah. And do you think there is something like a thick endometrium as well?
You see some papers, it's I don't know why it attracted less interest, but once you rule out intracavitary pathology, that would make it look thick, like an unnoticed polyp, fibroid, etc. I wouldn't think, or hyperplasia, let's say, I wouldn't think a thick endometrium itself would be a bad thing. And I mean, there's no way to shave it, so.
Thank you, Dr. Professor
Thanks,
Barris.
Dr. Barris. And just one comment that your paper and your findings have been thought changing, path changing, and we were always stuck with the endometrium thickness, and we have moved away from that.
Wonderful.
And we have seen that it doesn't impact our pregnancy rate so much. So thank you for that.
Thank you. I mean, really nice to hear. Sometimes people send photos, messages away. So I transferred this after the paper. She's pregnant, etc. So it's something really very simple, but if it helps, people really like everywhere. Nice. Thank you. Great.
Thank you, Professor Barris, for clarifying the doubts and a wonderful lecture. And we'll move on to the next lecture. And I'll invite Professor Dr. Human M. Fatemi for his lecture on the endometrium hostile for the embryo. Professor Human M. Fatemi graduated with an MD degree in 1999 at the University of Brussels with a great distinction. And in 2005, he won the Pfizer Educational Grants as the Best Graduate Fellow in Gynecology in Brussels, Belgium. And in 2008, he was recognized as a subspecialist in reproductive medicine and surgery by ESHRE. And during his training and later on also as consultant, he has performed several studies in various fields of gynecology and reproductive medicine and surgery. He successfully defended his PhD in endocrinology of the luteal phase in stimulated and substituted cycles in 2008 at the University of Brussels, that's Rijke University, Belgium. And Professor Fatemi is the author of more than 150 internationally peer-reviewed articles and several book chapters. He held more than 150 invited spoken presentations at international conferences, and in 2009, at the age of 35, he received the title of clinical professor from the University of Brussels. Congratulations as well, doctor. And yes, we are here to listen to your much awaited lecture. Please.
Thank you very much for the kind introduction. We are going to have actually very challenging presentations and thoughtful presentations. You have heard from Professor Barris, the thickness does not matter. And now I'm going to tell you, the uterus is the worst place for an embryo to be in. So you might say this is a crazy conference. I left my Sunday to come to a meeting to listen to this nonsense. But actually, at the end, I hope we can clarify it makes a lot of sense. Now, I remember when I was in Belgium, we had an expert, her name was Claire Bourgain. At that time, she was one of the top experts of the endometrium. And we had a meeting, and I was a junior resident, and she looked at me and she said exactly what you see here. The endometrium is the worst place for an embryo to be in. I said, this lady is crazy. I mean, the uterus has been designed to get and deliver a baby, and she's telling me that endometrium is the worst place for an embryo to be in. Now, it took me many years to understand that she was right. And I'm going to try to highlight for you why she was right. Now, you see, and you have heard from Boris, what we do now, we put the scan and we say TK. It's good. We are happy with that. Ibrahim is happy with that. So the thickness is good and everyone is happy. But is it really the truth that you just measure the thickness and you look at the shape of the endometrium and we are happy? Is it that simple? Or is it possible that it is much more complex than what we are looking at? And this is exactly the point what we need to highlight. You have seen this slide from Boris. This is a paper we published a few months ago with a lot of difficulties. I think it was not a normal delivery, it was a vacuum extraction, and really we had to pull a lot to get this paper published, but at the end we managed to publish that paper. And these are thought-changing papers. And you know, it's getting for us more difficult to publish papers because people follow the mainstream. People follow a dogma. When I say people, it's also the reviewers, it's the associate editors who do not dare to think out of the box. But it's important to think out of the box in order to go to next level, in order to unlearn and relearn what we know. Now, the embryo implantation is a very complex process. I think we just know a fraction of what has been published and how an embryo implantation is working. We know there is a kind of adhesion, we know there is a kind of invasion, we know there is a kind of interaction between embryo and endometrium, but we don't know exactly how it works. But there is one thing that we know since about 100 years. You guys are going to say, he's coming all the way to India to refer to a paper which is 100 years old. Yes, I do. Because these papers, we always try to reinvent the wheel again. But sometimes you have to go back in time to understand that maybe we need to rethink what we have learned over the past. Now, what we know is that the ovary is the main source of steroids. When I say steroids, mainly estradiol and progesterone. But not only. It's producing many other factors. But these steroids are the main source of steroids, and these steroids are having one main function. And this function is on the endometrium and myometrium, but specifically endometrium. We know that implantation itself is very complex, but you have one king. And that king is controlling all these factors. So if you can control the king, you will control the rest. So it's in our interest to see whether we can control the steroids, because we're going to control the rest of it. Now, what do these steroids do? We know that before you ovulate, you have a very, very small peak of progesterone, and thereafter you rise. Now, when you rise, there is a certain level of progesterone which initiates what we call secretory transformation. So basically, you go from proliferation, the endometrium becomes thick, it's building up, but the moment your progesterone level goes above 1 nanogram per ml, approximately 1 nanogram per ml, you change the direction of the endometrium. Instead of going from proliferation and continuing further, it changes to what we call secretory transformation. So these are two different entities. You have the follicular phase where the follicle is growing. You have the luteal phase where you have a corpus luteum producing mainly progesterone. But the endometrium is also undergoing a change. The endometrium goes from proliferation to secretory transformation. And these are two different entities. Now, why is it important to know this information? Why is it important to understand that from 1 nanogram per ml, approximately 1.2, 1.3, 0.9, something is happening. And this something is called secretory transformation. It is important because with the initiation of secretory transformation, I don't want to say on hourly basis, but for sure on daily basis there is a change of endometrium, on daily basis. So every day you see changes. Actually what you see here is hours. But let's simplify and go to the days. On daily basis there is a change of the endometrium from the time of progesterone exposure. Now we know in order to have a successful pregnancy, you need to have a good embryo and a good and receptive endometrium. If one of those is missing, not TK. So you have no pregnancy. So it's in our interest, in the interest of patient, to have a maximum synchronization between a receptive endometrium and a good quality embryo. But we are very simple people, you know. We go to conferences, myself until 5-6 years ago, using this slide, saying, yeah, the window of implantation is LH7 to LH11, it's 5-6 days, so it's very good. But then you have to be self-critical. So who said that? Who said that the window of implantation is maybe 5 or 6 days? Who said that? It was published in 1973. But what was our knowledge 50 years ago? Almost non-existing, I would say, at that time on the window of implantation. But yet, we still refer in all our publications to the window of implantation. But maybe the so-called window of implantation is not 5 or 6 days. Maybe it is shorter, and maybe it's not the same with everyone. Maybe people have different length of window of implantation. So recent studies, gene expression models, brought some light into this big black box of window of implantation. So this is a paper which was published in Nature Medicine. And if you take a look, these are the gene expressions. In the proliferative phase, you have a slight down regulation, the late proliferative phase. Even when you go from proliferation to secretory transformation, nothing is happening. Even the moment you are exposed to progesterone, 1, 2, 3 nanogram per ml, nothing is happening. But look what is happening after around 120 hours. Suddenly you have a down regulation. It's a sudden drop. You have a sudden drop here, very clear. So you have estradiol, you have progesterone, you did already the switch from follicular phase to luteal phase here. The switch is done. But on a gene expression, nothing is happening. When do you see something happening? It's after 120 hours. Then you have suddenly the down regulation here. But the moment you have the down regulation, you remain on a level for around 2.5 days approximately. But look what's happening after 2.5 days. Again, suddenly, you have further down regulation. So if you go over it, you're going to fall down. So that means this is our window of implantation. So what we need to understand is based on the time of progesterone exposure, there is a window of implantation which needs to be respected. If you have the best embryo, you put it here, 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 anywhere. Will she become pregnant? Of course not. This is why the uterus is a hostile environment. In a cycle of 28 days, How do you say 2? Do days, it's receptive. Maybe 2.5. Half I don't know in. 9? Aye. So it's only 2.5 days where it is receptive. And this is exactly why we say the endometrium is a hostile place. Now this is the part of the endometrium. Now I'm not an embryologist and I don't have any knowledge on embryology. But what I know is that every egg, every zygote, every embryo has a different division pattern. Would you agree that every embryo is dividing differently? Or would you say, no, they are all same? They are not. They are same, but different. Right? So you have every egg and every embryo dividing on a different pattern. You can have a blastocyst on day 5, you can have a blastocyst on day 6, and you can have a blastocyst on day 7. Do you think that those embryos need to be individualized and synchronized with the endometrium on a more detailed manner? Most probably they do. So first we need to understand time of progesterone exposure. Secondly, we need to understand how that embryo is dividing. Just a simple study, day 5 or day 6 blastocyst, put back in 6th day or 7th day of progesterone exposure. Results are different. Miscarriage rates are different. Why? Because you need to synchronize that embryo much better. It is not that one size fits all. You cannot put those embryos on the same time. And if you take a look, again, an old study, on days, these lines represent days of the cycle. Follicular phase, luteal phase. And as you can see in the luteal phase, see how many changes you have on daily basis. Every day you have changes. And this is exactly because of progesterone exposure. Now obviously the moment your progesterone increases, this is a paper we have published when I was in Brussels, we saw also significant differences in gene expression. Now what happens if you stimulate a woman? Obviously your endometrium is advanced, mostly 30 hours. But some women have an advancement of more than 2 days. So normally they have an advancement of 1.5, 2 days. But if you have an advancement of more than 2 days, so let's call it 3 days or more, look what is happening with the pregnancies. Ibrahim would say 0, right? None. They do not get pregnant. Why? Because you fall off the stairs. You are beyond your window of implantation. That embryo cannot be accepted because there is no receptive endometrium. This is a paper Dr. Carroll, who is present today, has published recently. When you have a patient, one of our concerns is when we stimulate that patient will have what we call premature progesterone rise. So let's say you stimulate a woman, you do not want the progesterone to go up, because we know if this happens, the receptivity goes down. That we know. But did you know, if you have a patient who has, let's say today, a progesterone of 0.7, which is okay at the end of stimulation, nanogram per ml. Let's say at 3-4 p.m. today, and you trigger for final oocyte maturation today at 8 p.m. Let's say 4 hours later. What would be the progesterone for that patient 2 hours after the trigger? Just 2 hours after the trigger. Double. So if it is 0.7, it will be 1.4. Within 2 hours. It means even if you don't have a premature progesterone rise during the stimulation, with your triggering, you have a rapid rise of progesterone. And that will for sure contribute to a shortening of the window of implantation. So this is why it is extremely important that we understand the embryo and endometrium need to be fully synchronized. It is not that easy, but they need to be fully synchronized, the embryo and the endometrium. Of course, there is another factor which is called the endometrial aging. So also an endometrium, like the oocyte, is undergoing an aging. But our knowledge there is still very limited, and we need to have a better understanding whether based on the aging of the endometrium, we need to adapt possibly the dose of progesterone, but maybe also the time of progesterone exposure in order to have a better synchronization. Now, something which is also interesting to know is that the endometrium and the embryo, they have a nice chit-chat together. They talk with each other. Sometimes they speak different languages, but usually they understand each other. The embryo gives a signal to the uterus, I am good, let me sit. The uterus says, okay, have a seat, or do not have a seat. So we call it developmentally impaired embryo or competent embryo, a good embryo, a bad embryo. And usually they give different signaling. So it means an abnormal embryo should be rejected. But it's not always the case. Because sometimes you have a miscarriage, sometimes you have even an abnormal child being born. Why? Why does the endometrium accept an abnormal embryo where it should be rejected? This is a beautiful study which was published about 10-12 years ago. You see, this is a normal woman. This is a patient with recurrent miscarriage. This is the uterus. This is a high-quality normal embryo. You see the cells of the uterus are surrounding that embryo. So this embryo is implanting. This is a 3pN abnormal embryo. So you see the cells of the uterus are rejecting that embryo. So that embryo is not implanting. Normal embryo is implanting, abnormal embryo not implanting. But this is a patient with recurrent miscarriage. Normal embryo is implanting, abnormal embryo is implanting. So that uterus is not selective. It is receptive. So the uterine cavity, the endometrium, also needs to be receptive to accept an embryo, but it needs to be selective. It should not accept every embryo. If it is too receptive, what happens? Every embryo will implant. If it is too selective, even the good embryo will fail to implant. So ideally, the uterus needs to be selective and receptive. Hence, this is why some women have recurrent miscarriage, because they have a very friendly uterus. All the embryos are implanting, but they should be rejected, which is apparently not happening. So just to conclude, I think by now, after what you have seen, it is acceptable to say that the endometrium is a hostile environment. It's not a very friendly environment for the uterine cavity, for the embryo, because it's only receptive for 2, maybe 2.5 days. To achieve a pregnancy, we need to understand and respect the basic physiology. Please keep in mind the time of exposure of progesterone is important. Do you know one of the reasons that the paper that Dr. Baris just presented, we did not see any difference in endometrial thickness and outcome, is because of time of progesterone exposure. And this is something many people disrespect. Even a lot of publications do not respect the time of progesterone and synchronization of embryo and endometrium. This is much more important than the thickness of endometrium. And ideally, you need to synchronize the embryo and endometrium to a maximum. Thank you very much for your attention.
Thank you, Dr. Fatemi, for the nice and informative lecture. And we'll allow just 2 questions. So please, anybody having a question in mind or any comment? So no doubt left, I think, in anybody's mind. Thank you, Doctor.
Thank you very much. Thank you. Yes, Dr. Parul.
She has a question, yes.
She always has questions.
So my question is about the window of implantation, what you just mentioned. Does it also depend on the dose of progesterone exposure or the dose of progesterone to which the patient has been exposed?
I thought we had a deal that we don't ask difficult questions today, Dr. Parul.
Yeah.
It's a very important question.
This is an easy question for you.
It's a very good question. So there are 2 factors that we need to put in equation. One of them is obviously you initiate the secretory transformation. So this happens from 1 nanogram onwards. But then you need to maintain that, and you need to work on the neovascularization of the endometrium and blood supply in order to accept and have enough blood supply to the embryo. And there you start having a big diversity among patients, and this is why many studies are looking to the dose and systemic circulation level of progesterone in order to have a pregnancy or no pregnancy. Personally, I have my doubts on many of these studies because they have many shortcomings, but there is one group of patients which would most probably benefit from a higher dose of progesterone. And these are the patients who have endometriosis/adenomyosis. Because those patients, they have endogenous aromatase activity. So they produce their own estradiol. And we know that this estradiol is working on progesterone receptors and progesterone receptor resistance. And there have been many publications in the past few months. One of them was from Denmark, from Peter Humeidan's group, where they clearly demonstrated that women with endometriosis/adenomyosis would require significantly higher dose of luteal phase support in order to have the same pregnancy rate as non-adenomyosis. So most probably you have a subgroup of patients, adenomyosis, endometriosis, who would have progesterone receptor resistance because they have aromatase activity, and they would require most probably higher dose than what we usually give for normal patients. This is one entity of the patients. Now, we are submitting now with Dr. Lawrence our abstracts to ESHRE, and one of our colleagues, one of his topics is obese women. Now, obese women, they also have a lot of fatty tissue. Now, fatty tissue has aromatase activity. Hence, when you have obese men, they have breasts like women because they have aromatase activity. They produce estradiol. Now, we saw with these women also a lot of miscarriages after PGTA, a lot of miscarriages. So we are thinking it might be that obese women are the same entity as adenomyosis women. Because first of all, the absorption is less if you're obese, if you give vaginal progesterone. Secondly, these women, because they have high aromatase activity, they might also have more progesterone receptor resistance. So it might be that this subgroup of women also would benefit from higher dose of progesterone. First of all, absorption is less. Secondly, there is progesterone receptor resistance. But thank you for the very important question. I think.
Sir, So anything, I mean, for the timing of the transfer, can we decide based on the pace of the embryo development? If the embryo is slow, should we transfer late, or I mean, it's 120 hours for all?
So currently we are running a study to look into that. So what we did up to now, when you have a day 5 blastocyst, sometimes you have a day 6 blastocyst, as you have seen. You don't have always day 5 blastocyst. Sometimes you have a day 6 blastocyst. So we are still transferring a day 5 or day 6 blastocyst on 6th day of progesterone. which is not 100% correct. So what we are doing now is a randomized control trial, and Dr. Carol is the leading researcher in that project, is to randomize the patients day 5 or day 6, 6th day or 7th day of progesterone, to see whether these 1 day difference would make a difference.
So I think I've seen one more question. So one short question, one short answer, and then we'll continue.
Dr. Fatemi, does the route of the administration, subcute, IM, or the vaginal, change the transformation process to the secretory change? How quickly would it change?
Thank you for the question. The transformation does not change, but the absorption is different, and the systemic absorption is different. So if you take vaginally, there is a publication by Buletti. It takes you 3 to 4 hours until you have a full absorption and systemic absorption. Intramuscular, within minutes, you have a systemic absorption. So the timing differs. It's a couple of hours difference. Secondly, the value of absorption in the systemic circulation is much higher intramuscular systemically than vaginally. But you need it vaginally, you need it in the uterus. Of course, systemically also important, but most probably some patients who have immunological issues would also benefit from systemic absorption. So not only local, but also systemic absorption.
So thank you very much.
Thank you.
Now we are continuing for the sake of time. And it's my absolute pleasure to introduce Dr. Carol Colan. So she is an RCOG accredited subspecialist in reproductive medicine. She is working since, I think, almost 8 years with us now in the Dubai clinic. So we have the pleasure to have the Dubai team with us today. So she's talking about how we define ovulation, especially regarding the endometrium, and this fits nicely in what we heard lately. And also regarding one publication, which was also a bit difficult to get published because it was out of the box, and this is something what Dr. Fatemi had mentioned previously. Now it's highly cited because it has an impact how we are planning. Please, Carol.
Thank you so much, Barbara, for that really kind introduction. And it's such a pleasure to be here with you all this morning, to meet colleagues from India and to meet all the attendees. And I really hope you'll find something interesting in the presentation. So today I'm going to talk about how to define an ovulation, particularly in terms of the hormonal changes that we see in spontaneous ovulatory menstrual cycles. Now, I'm sure you're all well aware with all the graphical representations that we've seen in our textbooks over many years, but you'll be really quite surprised at how there is a significant gap in our knowledge and deficits in our knowledge in terms of ovulation. Even today, there is not a uniform, agreed definition of a detailed description of ovulation in terms of hormonal changes. And this really reflects a very significant gap in our knowledge in what really is the most basic aspect of reproductive medicine. Now, why is there now this focus on ovulation and natural menstrual cycles when we've taken this on board for so many years? But now with the advent of frozen embryo transfers, which are comprising the vast majority of transfers in many countries, we are now looking at the optimum means of preparing the endometrium for these transfers. And there's a few different options, such as natural cycle, modified natural, stimulation, and artificial with HRT. Essentially, for a successful transfer, we need a healthy, euploid, good quality embryo, and we need a receptive endometrium. And the optimal means to prepare the endometrium is still very controversial. It's by no means agreed. But certainly the natural cycle does appear to be gaining momentum in this respect. Evidence is now pointing towards an increased risk of hypertension in pregnancy when the pregnancy is conceived in a cycle without a corpus luteum, so essentially the HRT medicated cycle. So this now brings in a whole new dimension to the decision-making process when deciding what protocol we should be using. Initially, we were looking at what protocol is going to give us the best pregnancy rate. But now we're thinking of which protocol is going to give us the best pregnancy rate, but also the safest outcome for the mother and also for the baby. And further evidence is now, I suppose, driving us towards natural cycle, because the evidence is suggesting that the natural cycle is also resulting in better maternal, obstetric and perinatal outcomes. And then the next issue is, how do we plan the transfer of the embryo in the natural cycle, when to date we have no agreed definition for ovulation? And this leaves the reproductive medicine specialists at risk of making an error when planning the transfer and reducing the pregnancy rates. So this is the current ovulation paradigm that we are so well used to. So as far back as 1976, Young and his colleagues suggested that the dominant follicle produces estrogen. And when we had an estrogen peak of 200 to 300 picograms per mil, sustained for about 50 hours, then that would trigger ovulation. This is what we have all come to know and accept since we started our study. But let's take a closer look. So also at the mid-cycle, we also see an increase in FSH. And this all too often is never mentioned. And it has a very important physiological function. Firstly, that FSH is driving the production of LH receptors on the granulosa cells, thereby securing the function of the corpus luteum in the luteal phase. Secondly, it will help with nuclear cell maturation, and then thirdly with cumulus cell expansion. And as we know, the endometrium will grow and become receptive when exposed to progesterone, and thickens in response to estrogen in the follicular phase. And then we come to another aspect of the cycle which is often ignored. And this is a little physiological increase here in progesterone about 12 hours before the LH peak and ovulation. So this was described by Spearoff and Hoff back in 1982-1983. And they felt that even though this was a very small increase, physiologically it was of immense importance. And they suggested that it potentiated or augmented the positive effect of estrogen on triggering the LH surge. So here we have the LH, and here we have again emphasizing the increase in the P4. And Devoto et al. 2009 felt that this increase in P4 was related to LH due to the increase in the LH amplitude and frequency. But then Dazortsev and his colleagues in 2020 suggested otherwise. They felt that this increase in P4 was LH independent and was more related to the follicle growth and the disintegration in the follicular wall. So what they felt essentially is that as the dominant follicle is growing, it becomes vascularized and eventually becomes inflamed. And when this happens, there is more oxygen being driven into the follicle. And when the hypoxic milieu of the intrafollicular environment is taken away, it can actually maybe release some of the granulosa cells from the luteinization block. But secondly, what they suggested was that when the hypoxic environment is present, it's encouraging endothelin-1, which inhibits P4 synthesis. But once we remove the hypoxia by the increased blood supply, we remove the blocking effect of endothelin-1, which drives the P4 synthesis and actually feeds back on the hypothalamus to stimulate the GnRH release, thereby acting on the anterior pituitary to increase LH and FSH mid-cycle surge. So what does the progesterone do? I think we're all in agreement, it induces secretory transformation of the endometrium. Very important. And there was a very interesting study in 1997, Tchaikovsky, and he looked at young fertile oocyte donors and non-fertile oocyte donor recipients. The oocyte donors underwent gonadotrophin stimulation and had endometrial biopsies on their day of egg collection. And what he found was that a progesterone level of 0.9 on the day of HCG had a positive predictive value of 78.6% for secretory histology on the day of retrieval. So even at progesterone levels that low of 0.9, it's affecting the endometrium. So essentially ovulation is related to this transformation of the endometrium. So why then did Spearoff say so many years ago that the onset of the LH surge is the best surrogate marker for impending ovulation? Why was this the factor that we took on board and based all of our studies of the natural cycle on, when in fact it should have been P4? Well, another interesting study by Maria Alliand looked at the hormonal trajectories of individual women in spontaneous ovulatory cycles. And what she found was that the hormonal trajectories differed significantly from the mean hormonal curves that have been provided in research studies. So we know that cycles can vary from woman to woman, but also even from cycle to cycle in the same woman. So that's very important when we come to deciding on planning embryo transfer, that one cycle does not always follow the next. And then Erdin and his colleagues in 2022 revisited ovulation and the LH surge, and they performed a systematic review and meta-analysis, and this is really interesting. So the first question they asked is, what is the definition of the onset of the LH surge, on which we have been basing all of our studies on the natural cycle? So what he found was that there is no universally agreed definition. Some of the definitions looked at the fold increase in LH from baseline, and that fold increase varied from 2 to 6. And then he looked at the baseline LH levels on which the fold increase was based. And that could have been the LH on the preceding day, 4 preceding days, or all throughout the follicular phase. Again, no agreement. Other studies looked at standard deviations above the average. The most common definition is T-Start et al., and that's used mostly in the papers. And that suggests that the onset of the surge is when we see a 180% increase above the mean of the preceding 4 LH levels. But as we can see, numerous definitions. The second question was the duration between the onset of the LH surge and ovulation. So if we're taking the onset of the LH surge as the best predictor of impending ovulation, then we are assuming that the time between the onset of the surge and P4 rise is acceptably constant. Well, what Erdin found was that the mean duration was 33.9 hours, but the range was 22 to 56 hours. So how can we accept the onset of the LH surge as accurate when we're planning and making such an important decision as when to transfer the embryo in the natural cycle? And their third question was the LH surge configuration. So I think we all now know that the LH surge is not uniform in cycle to cycle, or even from woman to woman. So this paper found, these were 3 studies, all with urinary LH monitoring, and they detected 3 particular configurations: a spike, biphasic, and plateau. So essentially, we cannot depend on the onset in terms of definition, duration, and configuration. And urinary testing, is this a good idea? So when we're testing LH in urine, it is very much dependent on the assay that we use, because different assays detect different molecules. If the assay is just looking at intact LH on its own, then this provides the most relevant physiological information. But if it's detecting intact LH with LH beta CF, then it's not so accurate. There can also be a wide variation in the sensitivity of the urinary assays. So if you have a very low peak LH level, you may actually have a false negative result. Thirdly, there is a delay in urinary clearance of LH, approximately 24 hours behind the serum. And some kits will demonstrate LH surges in the absence of ovulation. I think all agreed maybe urinary testing of LH needs a rethink. Now, we would suggest serum LH monitoring, but repeated blood samples are necessary, and we would also suggest you would combine it, very importantly, with progesterone measurements. Now we come to ultrasound for detection of ovulation. I mean, really easy, isn't it? We scan, the follicle was there yesterday, it's gone today, job done, ovulation has happened. We see maybe a collapse in the follicle, free fluid in the pelvis. However, I just want to draw your attention to different patterns of follicular fluid evacuation during ovulation. Very important. Fluid may remain in the former follicle well into the luteal phase. So I don't think we can depend on ultrasound either as a sole method of detecting ovulation. So this is how we do it at our clinic, monitoring for ovulation. So the patient is seen day 2, day 3. We do a basic ultrasound scan to exclude ovarian cyst, and we do a baseline hormonal profile, E2, P4 and LH. And then we see the patient back in a week for a further scan. When we detect a follicle of 14 millimeters, then we start to do the serial hormonal profiling, E2, P4, LH. Coming near to ovulation, the patient may need to be seen up to 2 to 3 days consecutively for accuracy in timing. So day 1, we see the start of the LH rise, the E2 is high, the P4 is low. Day 2, the LH is still high, E2 decreases, LH is low, but we may see this physiological rise in P4 up to maybe around 0.5 ng per mil. Now this sounds like a very low level of progesterone, so it's hard to imagine that in potentiating the ovulatory trigger. But if you look at it and you put it in the correct framework in terms of the baseline P4 levels all through the follicular phase, that physiological increase in P4 can actually be 50 to 200% higher than the P4 level in the preceding days. So very important. And once you start monitoring the cycles, you will begin to see that P4 increase. And then day 3 for ovulation, we have the P4 rise, and in our clinic we would define ovulation as a P4 of 1.0 nanograms per mil, and we base this on Tchaikovsky's paper showing the secretory change at 0.9. Now this was a study that we did in our unit, looking at the time between the onset of the LH surge and the P4 rise. So it included 102 women who were undergoing monitoring for transfer of a frozen embryo in a natural cycle. The women were aged between 18 and 43. They had a BMI between 18 and 35, and they had at least one euploid blastocyst for transfer. And what we detected was 3 specific LH configurations here. So we found in our group that 20% had their LH peak 2 days prior to ovulation, 70% 1 day prior, and 10% on the day of ovulation. So if you base the onset of the LH surge for ovulation, you can see the differences in the timing as opposed to basing it on the day 4 P4 rise. So essentially 30% of our study population would have had a difference of more than 24 hours in timing if we had based this at the time of the LH rise. So that's really worth considering. As an aside, what we found for those who had their LH peak on day 2, they had significantly lower AMH and significantly higher BMIs, but this would need further study as our study population was quite small. Now, just to show you the timing of the true natural cycle, so when we see our P4 rise, and then on progesterone +5 would be the day of our transfer after 6 days of progesterone exposure. And now this is a new paper that was published very recently that's trying to introduce a formulation that we can use for predicting ovulation. And they're basing it really on the presence or absence of the follicle, which we now know is questionable due to the different patterns of fluid evacuation from the follicle. They also incorporated E2, LH and FSH monitoring. And what they found, just to give you a very kind of quick overview, is that if your ultrasound follicle was present, if your estrogen had decreased, they said with 100% certainty that you would then be day -1, 1 day prior to ovulation. And for instance, if you had your scan and there was no follicle, and if the progesterone was greater than or equal to 9, then 99% certainty that you were day 1 post-ovulation. However, I think there's some issues still very questionable about this, so I don't think it's something we'd be quite ready to depend on when making such a critical decision as transfer of a precious embryo in a natural cycle. I think we need further studies, and their model was developed on 118 cycles, of which 113 were validated. And this is a very interesting study. So this study looked at the transfer of euploid blastocysts in a modified natural cycle and in a spontaneous natural cycle. And they found that the optimal timing for transfer of the embryos in both cycle options was optimum at 160 hours +4 and 160 hours +6. So 160 hours from the HCG trigger in the modified cycles and 160 hours from the onset of the LH surge. But this is even more interesting. So when they did the subgroup analysis for the modified natural cycle, the live birth rates here were higher for 160 hours +4, +6, +8, +12. Very clear. But not so for the natural cycle, where the live birth rates were comparable across a wider time frame, but with a tendency towards lower live birth rates. So disappointing when we now consider the natural cycle to be maybe the preferential option for transferring the embryo. But let's take a closer look at the interpretation of the study findings. So the authors here felt that we need to refine the interpretation of the hormonal dynamics. I think that's agreed. We must be able to improve on our methods that we're employing when determining the transfer in the natural cycle. We have to improve the embryo endometrial synchrony. And I would just highlight to you, when the planning of the embryo was made here in the natural cycle, LH surge was the surrogate marker for ovulation and not P4. And therein lies the problem. Now this is another step forward where we're looking at the duration of progesterone exposure when planning embryo transfer. So we know now about the 120 hours plus 4 is the optimal timing, but maybe now we need to look a little bit closer at, we'd say, for instance, the blastocyst stage of development. So this study was very interesting. It looked at the transfer of single blastocysts after 6 or 7 days of progesterone. And what they found was that the live birth rates were significantly higher after 6 days of progesterone exposure. But when they did a subgroup analysis, they found that the day 6 embryos, the live birth rates were comparable between day 6 and day 7. I'll be very quick. This study looked at the transfer of blastocysts on day 5 and day 7, and what they found here was that the clinical pregnancy rates were essentially comparable, but this study was powered to detect an absolute difference of 16%, so they may have missed clinically relevant details. And then this study looked at transferring a cleavage stage frozen embryo following 3 days of progesterone exposure or 5 days. The day 3 embryo was warmed, cultured overnight and transferred on day 4. And what they found interestingly here was that the early pregnancy loss rates were significantly higher on day 3. I'm nearly there. The second last slide. Very interesting paper. The transfer of frozen blastocysts after 6 or 7 days of progesterone. The live birth rates were comparable, but when they did the subgroup analysis for the day 6 blastocyst, the miscarriage rates were significantly higher following day 6 of progesterone exposure, and the live birth rates tended to be higher after 7 days. So, a lot done, more to do. And just in conclusion, the majority of the data does tend to suggest the precise timing around 120 hours of progesterone. 1 day can make a significant difference. LH as the surrogate marker for impending ovulation, I think, needs to be rethought. The period between the LH rise and the P4 rise is by no means acceptably constant. We need to do studies to look at scheduling based on P4 levels and or CTs. And finally, the day of blastulation needs to be taken into account. Thank you so much for your attention.
Dear Carol, thank you very much for this beautiful presentation. And I think it was very clear that we have to look for the trajectory of the hormones before we start planning. Any questions from the audience? No, obviously not. Then for the sake of the time, I think everyone most likely is hungry. I think Dr. Carol will be there in the break. So if anything comes to your mind, please do not hesitate to contact her.
Yeah.
And I wish you all a good appetite. And
Thank you.
See you.
So we are breaking for lunch. Everybody can help themselves in the pre-function area, and we start back again at 2 o'clock. Thank you. University of Kent. Dr. GNR Oli is the author of more than 290 papers in the international scientific journals and publisher or co-publisher of 9 books. He is also an active member of several international scientific societies. I welcome you, sir. And to co-chair the session, I'll call upon Dr. Meenakshi Dua, who is the Clinical Director of ART Fertility Clinics, Gurgaon, India. She is a renowned infertility specialist with a career spanning of more than 18 years in obstetric and gynecology. Dr. Meenakshi is member of many associations including FOXY and RCOG and IMA. Over the years, she has treated thousands of patients with male and female factor infertility. I hand over the stage to you, sir. And
thank you very much. Welcome to the afternoon session. As you see from the program, we now switch to the embryological session, and as it has been said, and all of you know, it's not only a very important part of our work, but is a complementary, anyway, part of our work. I must confess to you that when I was talking with the co-chair, we had a long discussion because none of us wanted to be the first to introduce the first speaker because of almost unpronounceable family name. So I've been asked to do so. So Professor Hendricks, I think that's almost correct, okay? He is full professor at Ghent University, and without wasting time, because you can see his CV, is anyway the team leader of the Ghent Fertility and Stem Cell team. And the topic is I think one of the most exciting topics in our field, because it deals with oocyte activation. Who would benefit from this technology? Which are the pros and cons of the technology? So Henry, Brian.
Thank you. Thank you, Luca. You pronounced it very well. So,
well, I'm training all the night.
Good afternoon. Thank you for the organizers to have me here to present our work about oocyte activation. Who benefits from this technology? So, in our research group, we concentrate our research on difficult to treat patients. So patients who still have difficulties for the normal treatments with IVF or ICSI, so difficult to treat patients. In a more fundamental research, we try to develop new sperm or oocytes for people that don't have oocytes or sperm. For example, from stem cells. We also do some CRISPR-Cas gene editing in embryos to study the function of genes. So we knock out genes to see how it's affecting development, for example. But also we concentrate, of course, on more clinical translational research. So research techniques, developing new techniques that are very close to the clinic or already used in the clinic. So the topic of today will mainly be this failed fertilization after ICSI, and I will present you some slides about a new technology called nuclear transfer. Okay, so you all know ICSI is normally very efficient. We have fertilization rate normally of around 75%, a blastocyst rate close to 50%, but in some cases, some patients have problems still. So for example, oocyte maturation arrest. So when we simulate patients, we only retrieve GV or metaphase 1 oocytes, and these are very difficult to treat. Then the topic of today, sometimes fertilization doesn't work after IVF, but especially also after ICSI, no fertilization. Can be a sperm or an oocyte factor, and I will talk a little bit about embryo developmental arrest. So patients that don't produce good quality embryos and that fail to go to blastocyst stage. Okay, so first fertilization failure after ICSI. So it occurs in 1 to 5% of the ICSI cycles, and it's caused by a deficiency in the oocyte activation mechanism. So what is the oocyte activation mechanism? If the sperm enters via ICSI, for example, there is a protein called PLC zeta, phospholipase C zeta. It will produce IP3, and this IP3 will bind to its receptor present in the oocyte. So the oocyte factor for the oocyte activation is this IP3 receptor. And this will cause calcium rises, so calcium oscillations, as you see here, multiple calcium rises, and this is necessary to start fertilization. And then you end up next day with normal fertilization, but there can be a problem in these factors, PLC zeta or the IP3 receptor, which doesn't cause any calcium rises, and then you have failed fertilization after ICSI. We contributed to the work of John Barrington, so yeah, if you want to prove that a certain gene protein is responsible for something, you can make a knockout. So they made a knockout PLC mouse model, and you see with this sperm, you don't see any calcium rises appearing. So no fertilization when you knock out the PLC zeta. But still, it's a little bit puzzling when we do in vivo mating with this knockout PLC male mice. We still get some offspring. So there is a mechanism that takes it over in vivo. We don't know if this is happening in human, of course. So this is something that we still need to explore further. Okay, so if a couple has failed fertilization, it's stressful. It's stressful for the lab, for the doctors, but especially also for the couple. And the couple really wants to know who is to blame. So if it's the man, the sperm, or if it's the oocyte. Yeah, I will not use blame anymore, because yesterday we had a discussion. So they want to know if it's male or female. And yeah, we also like to know it, because if it's a sperm factor, it's actually better. We treat these patients with a technique that I will show, and if it's a sperm factor, we have a higher efficiency than when it's due to the oocyte. And also, yeah, we have to consider we find a lot of mutations in this PLC zeta, so we have to warn the couple that, yeah, some of the babies that we are making will also have this problem of failed fertilization in the future. Okay, so what are we doing in Ghent in Belgium? So we developed this mouse oocyte activation test, and what do? When a couple has failed fertilization, we inject human sperm into mouse oocytes to see how many of the human sperm can activate mouse oocytes. And then in the result, we divide them, classify them in 3 groups. So MOAT group 1 means that most of the sperm cannot even activate a mouse oocyte. So that's a sperm problem then. In the MOAT group 2, some sperm can activate mouse oocytes, but some sperm do not. We are also quite sure this is a sperm factor also. And then we have a MOAT group 3 that most sperm can activate the mouse oocyte. So in these cases, we suspect that it's an oocyte factor. We also do some genetic screening to identify mutations, and more mutations are published about the male, but especially about the female factors, that they found new mutations in some genes causing this failed fertilization. Yeah, this is less important. We can also do some calcium imaging with staining. So we also do that, but that's less important for today. So one well-known sperm sample that cannot activate an oocyte is globozoospermia. So it's a round-headed sperm. They miss acrosome, but they also miss this PLC zeta. So these sperm cannot activate a human oocyte. Yeah, we also do this genetic screening. So a lot of mutations have been reported recently. You see some mutations here and by different groups. And we also will publish something on this soon, I hope. What about the female, the oocyte? Yeah, there are a lot of proteins present in the oocyte cytoplasma. And you see here some proteins that are very crucial for oocyte activation. So Here you see some examples. And if you have a mutation in one of these genes, you will have failed fertilization. And yeah, a lot of Chinese studies especially have been published very recently showing some mutations in some genes which are causing mostly failed fertilization, but also embryo developmental arrest. So how can we treat these patients? In hand, we already do a long time this treatment called assisted oocyte activation, AOA, to overcome this failed fertilization. So we artificially induce calcium rises. The people we are not the only clinic, so quite some IVF clinics do this assisted oocyte activation, but all use very different products. For example, a lot of clinics use this commercial available called Active, but this is not working in our hands. So I would recommend to not use this. We use this inomycin. I will show you on the next slide this protocol that we are using. So in Ghent, we inject together with the sperm a volume of calcium that gives the first big calcium rise, and then we expose the oocytes 2 times to ionomycin. It's a calcium ionophore causing also a calcium rise. So actually we induce 3 calcium rises. And this is enough to activate, so to fertilize the oocytes. So it's working quite efficient. So this was the first study that we published on this in 30 patients in 2008, so some time ago already. So in this study we treated these patients with assisted oocyte activation, and you see the fertilization rate of these patients was very low, 14% after normal ICSI. So that's very low fertilization, sometimes 0 fertilization. They had 50 cycles, normal ICSI cycles, nothing, because of the low fertilization, no pregnancy, almost no embryos developed. When we applied this AOA, we get 75% fertilization, which is a good normal rate, and we achieved 33% pregnancy rate in these couples, in this small series. We saw that in the group MOAT3, so where we suspect an oocyte factor, the pregnancy rate was a little bit lower than when it's a sperm factor. So we did a larger study published in 2019 in Fertility Sterility, where we published the outcome of 122 patients. So we divided them again according to the mouse result: MOAT group 1 sperm factor, MOAT group 2 also sperm factor, and MOAT group 3 a probable oocyte factor. And you see here the fertilization rate increased. After normal ICSI it was less than 10%, and after doing this AOA it was 70% in MOAT group 1. In MOAT group 2 from 14 to 63%, so a significant increase also. And in the MOAT group 3 from 17 to 57, a little bit less but still quite okay. And most important, the pregnancy rate in this couple. So in the MOAT group 1, a lot of globosome-spermic patients were present there. We see that pregnancy rate increased from 0 to almost 50%, MOAT group 2 from 7 to 35%, and in MOAT group 3 from 7 after normal ICSI to when we do AOA close to 30%. So in most couples it's very efficient to achieve fertilization, to have embryo development, and to establish a pregnancy. Yeah, this commercial called Active that a lot of labs are using, because I get some emails from labs, oh, it doesn't work, we cannot get fertilization, and then I'm asking which product are you using. Well, this called Active and it's not working. We did a study in 2019. It gives, the orange is the calcium rise caused by this commercial product. So in mouse, you see here that it's lower than the ionomycin that we are using, but especially in human oocytes, here you see the calcium rise caused by the commercial one, the orange. It's very low, so it's not enough to activate a human oocyte, so it's not working. And here you see in blue the ionomycin is much higher peak, and that's, you need to have a threshold of calcium released before you have fertilization. Okay, so in most cases AOA is working when there is a problem with the calcium oscillation, so then AOA is working. But you have to keep in mind, it's not only the calcium rises, but downstream of the calcium rises, there are a lot of proteins inside the oocytes that need to do their function. So you see here some names, CAM kinase 2, APCC, and so on. So these are all proteins that need to be functional in the oocyte. And when you have a mutation there, it will not happen fertilization. So what can we do? We see some couples where AOA fails because there is a problem downstream in one of these proteins in the oocyte. We know this, as I said, we know some genes from the oocyte which can be causing this failed fertilization downstream of the calcium oscillations. And as I said, a lot of proteins, hundreds, thousands actually, are present, mRNAs, proteins in the oocyte who have to do their function for successful oocyte maturation, but also for successful fertilization, and very important also for directing embryo development. You know, the first 3 days more or less are purely directed by proteins that are present in the oocyte. So oocyte is very powerful. And if you have a problem in the cytoplasma, in some proteins, you will end up with failed fertilization or bad embryonic development. For example, in this WEE2, so if you have a mutation there, and some Chinese studies have found mutation in families, you will never have fertilization. You see here the characteristics of some patients. You see here 5 couples and the number of oocytes retrieved, number of mature ones, and here you see that in most couples you don't get any fertilization, except for one couple, they had some fertilization, 3 on 15 from the oocyte. So if you have a problem or a mutation in this WEE2, it's very difficult to treat them at the moment because you will never have fertilization. Also with AOA, it will not work. These people have done, what you could do if you know which protein is affected, you could make a recombinant one. So for example, in this study, they made a recombinant version of this WEE2. Complementary RNA, and they injected it into the oocyte, and then they saw that if you do this, you can have fertilization and embryo development. But they didn't transfer. This was purely in a research context, and they did not transfer these embryos back to the patients. But that could be a possible option to do. We think that maybe another technique would be possible to treat these patients which we cannot help with AOA, and that's called this nuclear transfer technology. In the media, the laser is a little bit weak, but okay. In the media, they also call it a 3 parents baby, the 3 persons embryo. So how does it work, this nuclear transfer? If you have, let's say you have a diseased oocyte, that you have something wrong in the cytoplasma, here presented in red. The nucleus is okay, the nuclear DNA, we suppose that it's okay. So you take out the nucleus of an oocyte and you put it in a good, healthy donor cytoplasma. So you need donor oocytes with healthy cytoplasma presented in green. You remove, of course, the nucleus, otherwise you have 2 times DNA. So you have an empty donor egg, and you put here the nucleus in, you fertilize it with the sperm, and you have this so-called nuclear transfer embryo with one nuclear DNA coming from the mother who wants to become pregnant. The blue DNA comes from the sperm, and then why they call it the three parents baby? Well, the mitochondrial DNA, which is present in the cytoplasma, is coming from the donor, but it's only delivering the mitochondrial DNA. So if you do this technique, the parents are still genetic parents of the resulting embryo, because the nuclear DNA is coming from the oocyte and the sperm. Okay, you can do this nuclear transfer on different stages of oocyte development, but most people do it at M2 stage, so a mature oocyte. You take out the spindle, I will show it on the next slide, and pronuclear transfer. That's the most two applied nuclear transfer technologies, and yeah, a lot of studies have been done to optimize it. It's not doing ICSI, it's quite invasive. You have to remove nucleus, you have to re-enter the nucleus, but this has all been optimized both in animal models, but also in human. It works, and it shows good embryo development. And yeah, we think, or we know it's safe because a lot of studies have been done, omics, to check the embryos and to see that it's all working safely. So the spindle transfer, so you have a mature oocyte stage. Well, you cannot see the nucleus, of course, but using polarized microscopy, so it's special kind of microscopy, you can visualize the spindle. So the nucleus here, the white spot, and it's mostly very close to the first polar body. So here you see the nucleus, the spindle, you take it out and you put it in an empty donor egg and you fertilize it and you have your embryo. Some people also do it after fertilization. It's more or less the same, but you first do fertilization. So you first do fertilization of the patient oocyte, and also from the donor egg you do fertilization. And instead of removing the spindle, you take out the two pronuclei from the diseased oocyte and you put them in the empty donor zygote with good cytoplasma. That's PN transfer. Yeah, we published some years ago already about this technique. It was intended to use only for mitochondrial diseases, but now we think it's more useful actually to treat some infertility cases. Okay, I still have 5 minutes. So, has it been done? Yes. Dr. Zhang, he's working in New York normally. He produced the first nuclear transfer baby. It was for a couple with mitochondrial disease, so not for infertility. Yeah, he did it in Mexico, in Mexican lab, because it's not allowed to do it in the US. So he went to Mexico. They are a little bit more flexible in legislation and allowing things, so that's why he did it over there. So it was for a mitochondrial disease. You know, mitochondrial diseases, they are very severe, so it's good that, yeah, we try to avoid transmission, and so he did it for a patient with mitochondrial diseases. We do think that we should first try to use it for infertility, because we still have some issues with this mitochondrial disease, but I cannot explain it right now. So for which patients do we think that we could use this nuclear transfer technology? Well, it's patients that you now refer to oocyte donation. So you see here some examples, but especially we think that we can use it for failed fertilization if this AOA doesn't help. I will show you on the next slide. We did some trials. And also when a couple has very bad embryo development. So if embryos don't cleave, especially during the first 3 days, so if you have a lot of fragmentation, very few cells, that's really pointing to a bad cytoplasma, an oocyte factor. And normally, yeah, these patients, we have to refer to oocyte donation. Okay, so this AOA, if it fails, we applied spindle transfer on 2 couples. Just in research context, I will show you on the next slide. So we did spindle transfer, not PN transfer, because they have a problem of fertilization. So we took out the spindle of 2 patients and we transferred them to some donor eggs that we got to do research on. So we had these 2 couples that had failed fertilization after ICSI-AOA. So this first couple, they had 17 COCs collected, they had 12 M2s. Yeah, we tried again AOA, but you see here it totally failed. So of the 11 surviving oocytes, nothing fertilized, even with AOA. So she had 5 immature oocytes, so metaphase 1, and she donated them to us, researchers, and we did this spindle transfer to change cytoplasma. And of the 5 oocytes that we did the technology, 4 fertilized and developed further. It was in research context. Yeah, I'm close to my time ending. So it was in the research context, so we could not transfer back the embryos, unfortunately. In the other couple, she had 9 and 2 oocytes, nothing fertilized after doing ICSI and AOA. When we did the spindle transfer to another cytoplasma, all 6 fertilized and developed. But yeah, still in research context. Okay, I will end up with some slides on embryo developmental arrest, because yeah, this is more common. Failed fertilization, it's not so common, but this embryo developmental arrest, it's occurring quite a lot in labs. And yeah, we know more and more which genes in the oocytes are responsible to direct good embryo development. So you see here some proteins mentioned, and if you have a mutation in one of these proteins, no, you will have no good embryo development and no blastocyst formation. So yeah, our Dr. Zhang also did it again for a couple in 2016 already in China. He did it. So he did spindle transfer for a couple that always had 2-cell arrest. So normal fertilization, they go to 2-cell and they stop. So he did this changing cytoplasma, and he transferred back 5 nuclear transfer embryos. Yeah, he was a little bit over ambitious. It ended up in a triplet pregnancy with all the consequences of multiple pregnancy. He did the reduction, but finally they ended up with no viable delivery. But this last year, yesterday I also said this year, last year, 2023, a very important study was published from a good colleague of me, Nuno Costa Borges, a Portuguese guy. And they did this study in Greece, because Spain also doesn't allow to do it. He's normally working in Spain. So he went to Greece to do this pilot study. So I will end up with this very shortly. So they did it for 25 couples who never had good embryo development. So all these couples normally never had a blastocyst, and they tried a lot. You see, in these 25 couples, 159 cycles they tried, and almost never, they achieved any blastocyst formation. So they did this spindle transfer, nuclear transfer to donor eggs, and amazingly they got 63% blastocyst rate. So if you compare to 0, it's amazing, no? They did 19 embryo transfers in these couples, and it ended up in 7 pregnancies and 6 live births. So for me, that's very amazing result. Couples that normally never would have an embryo, never would become a genetic parent, with this technology, they get their own genetic child. So I'm quite, this is motivating me to continue, and our doctors, that we continue this research to hopefully also offer it in our clinic in the near future. Okay. Yeah, of course there are some concerns. Yeah, in some countries legally it's not allowed. In Belgium, luckily, we don't have a law that would prohibit it, so we could do it, but we need to get approval from ethical committee. Safety concerns, yeah, it's extensive micromanipulation, but this has all been studied quite well and optimized. We do think that we first should use it much more first for infertility instead of mitochondrial diseases. Yes, I just want to know, yeah, it's a new technology, this nuclear transfer technology. I just want to know if you would consider it to use for mitochondrial diseases. You can raise hands if you would support this. Some people. For infertility only? Yes. For both mitochondrial diseases and infertility? Yes. Okay. That's nice to see. Or you would not allow it, this technology? Or there are people that... Okay. That's nice to see and hear. Okay, that was my story. I want to thank our team in our department, and especially this Arantxa. She's a PhD student from Spain. Yeah, that's the one on the right. Yeah, she's working on this topic on failed fertilization. Thank you.
Thank you very much. We would like to have a final discussion with all the speakers, but if there is a pinpoint question that you like to pose, otherwise, if you're good enough in terms of time, we will keep some minutes for the final discussion. Oh, sorry, just a second. Get the microphone.
Mitochondrial technology, how long have been the offspring study?
Sorry?
The baby is born out of mitochondrial transfer.
Yes.
How long has been the children been followed up?
Yeah, well, this study from Greece, it's only from last year, so these children are only 2-3 years old, so not a lot. And that's very important that we start also, of course, to do this follow-up. But in animal models, a lot of follow-up of the offspring has been done and checked, and no adverse outcomes. Yes, but follow-up is very important to do with this new technology.
Thank you very much again.
Now I invite our next speaker, Ibrahim sorry, I can't pronounce. Ibrahim. Ibrahim the Great. That's an easier one. So now we know that so many causes can happen for fertilization failure, and for everything we keep blaming embryologist. So Ibrahim is there to defend on that. Stop blaming the embryologist. That's the topic for his talk. He is Group Director, Embryology, ART Fertility Clinics. He has completed his bachelor's in engineering, genetic engineering and biotechnology, MSc in healthcare management, MBA in data research, and MSc in IVF biotechnology and human-based research. He has done his thesis in time-lapse monitoring systems and pre-implantation embryo development kinetics. Ibrahim has more than 10 years of experience in field of embryology and was the part of team that started first IVF ART fertility clinic in Middle East. He has contributed to several scientific publications in the field of reproductive medicine in time-lapse monitoring, mosaicism and embryo morphokinetics. Over to you.
Thank you, Dr.
Sorry
Dua.
for pronouncing your name.
Thank you, Dr. Dua Minakshi. So I know your first name and last name. So good evening. My name is Ibrahim El-Khatib, and the title of this presentation is Stop Blaming the Embryologist from an embryology perspective. So this is an embryologist asking us to look for other factors than the normal ones that we normally investigate in the IVF lab. And I think we all agree that this represents our ultimate goal, a successful implantation that would result in a healthy live birth. We saw from this morning's sessions that in order to achieve a healthy live birth, I think we need all of us to work together in every aspect of the cycle. This includes the ovarian stimulation. We've talked about ovarian stimulation. We talked about trigger shot with Dr. Barbara. The IVF lab, I think we are all aware of the importance of the IVF lab, and hopefully we shed some light on the importance of IVF lab in the next few slides, endometrial preparation and so on. But of course, sometimes each one of us, we do our best, and yet we don't end up with the pregnancy or with the live birth that we're looking at. So our goal is to learn, right? Our goal, especially now in an era of individualization, we need to offer something new. And you know, the previous presentation by Dr. Hendricks showed that really there is no limitation. We are looking into a very minor type of patients, fertilization failure or failed blastulation, and we are on the right track to find solutions. And we didn't reach by that by looking into the wrong reasons for this fertilization failure, for example. And hopefully through this presentation, this is what we will be doing. So unfortunately for my colleagues embryologists, the first section of this presentation is why we should blame the embryologist. In other words, more diplomatic words, how important is the IVF lab? Now, if I will answer this question with one slide, I would show you this slide. Look at the amount of factors that are required in order for the embryo to grow. So imagine there is only one mistake. It will affect all the outcome. So of course, whenever something goes wrong, if we don't get proper fertilization, if we don't get good quality blastocyst or low blastulation, of course we will start with the IVF lab, because look how many factors could explain this outcome. And just to give some examples, we all know that temperature is very important. But does it mean if you enter any lab, you put 37 degrees, it means that we're all the lab will the same? Otherwise, we would be all of us, we would have the same results. But how accurate, the technology, the equipment that you use in order to do all of this is extremely important. And unfortunately, this you can see it in the effect of your outcomes, the fertilization, the blastulation, even the quality of these blastocysts. In this paper, they were trying to list the factors that could explain why sometimes euploid embryos they don't implant, and we can see that temperature is on the top of the list. Again, for doctors, I think you are aware of the culture media that we use. Now there are different types of media. Each media that we use, there is a recommendation of a specific pH that we need to have, but it's a range, it's not a specific number, right? So what we said, let's see if even if within the range, we choose two different pH. Of course, we control the pH through CO2. So although both of them are acceptable, but let's see if we have different CO2 concentration, giving both acceptable and within the range pH, if we will see difference in outcome. With the blastulation, with the fertilization, we didn't see any difference. But what we saw is you have significantly higher euploid embryos at 6% compared to 7%. Now, does it mean that a lab in Delhi can apply the same? No. This is considering our conditions, our SOPs, and our protocols in the lab. In our lab, this is better for us. And it's a responsibility of an embryologist in every lab to do the same. Now, this is another nice paper by the group of Danilo Cimadomo. What they did is they compared their results in their lab with their SOPs using two different types of culture media. And what they found is, in their conditions, one of the continuous culture medium had significantly better number and rate of a blastocyst. Another very simple example, let's say that you have analyzed your data, you tried, you found the best concentration of CO2, you found the best culture media. The way you prepare the media can make a huge difference. Because, you know, if there is any delay or you don't add enough oil or so, you get a little bit evaporation in this media. This will change the concentration in this media. And this will have an impact on your embryo development. Very simple, and I think something it's extremely important, especially here in India with the pollution, the air quality inside the lab. So this is a very interesting paper because simply what they did is they installed a new air filtration system. They compared their results this year and the year before. And what they found is implantation, positive, biochemical, live birth rate, everything improved just by taking care of the air quality. Now, these are related to culture conditions. You have also the SOPs and so on. And one of the examples I want to give is the blastocyst biopsy. Now, there are different techniques, different ways how you can do the blastocyst biopsy. We call this one the pulling method because it depends on aspirating these cells, pulling them, and then with the laser we do the detachment, compared to this method which calls the flicking, because as you see, we don't use the laser, we will just rub the biopsy pipette against the holding and we get the cells. Now, in history, a couple of years ago, they compared the outcomes between these two methodologies, and they found that when you use the laser with the pulling method, you have significantly higher mosaic embryos. Now, these are only two examples of many options that, or many small details we can consider during the biopsy. In this paper, they compared doing an opening in the embryo, a hatching on day 3, compared doing the opening at time of biopsy. And what they found is, when you use this method, you have significantly higher mosaic embryos. Now, another group, they compared the same two techniques. They didn't find any difference in euploidy rate or mosaic rate, but what they found is difference in live birth rate. So when you made the opening on day 3, they had significantly lower live birth rate. A third group looked into, again, the same two techniques. They didn't find difference in live birth or mosaic rate. What they found is you have significantly less frozen embryos. It means utilization rate was low. So what is the conclusion of this? Can we conclude that doing hatching or opening on the embryo on day 3 is not correct? No. The conclusion is, if you choose one protocol or one method of biopsy, you need to make sure that you account for all the variables. You need to make sure that it works well with the rest of your procedure. Very simple examples. If you make an opening on day 3, you increase the risk of what? Fully hatched embryos, right? Do you have trained embryologists to do biopsy for fully hatched embryos? If yes, then good. Do you know that manipulation of fully hatched embryos take longer time, right? Do you know that fully hatched embryos, they have significantly lower survival rates? All of these things. So at different stages, you can see the effect of any decision you've taken in the lab. And this is what I was telling you about the survival of the fully hatched embryos. So I think it's very clear why always the first question we ask, did we do anything wrong in the IVF lab? So it shows the importance of the IVF lab. But sometimes there are factors that are not related to the IVF lab. We cannot control inside the lab. However, they affect the same things in the IVF lab. They affect our KPIs in the lab. One of these is patient-related factors. And of course, the most important patient-related factor is age. Why? Because with age, we have significantly higher levels of aneuploidy. This will result in aneuploid embryos. We cannot always use morphology to direct us towards selecting these euploid embryos, because as per this study, 20% of excellent quality cleavage stage embryos are actually euploid. And if you even extend the culture to blastocyst, it's a 50-50 chance. Why? Of course, there are several explanations why the oocyte, or why this happens for older oocytes. It could be related to dysfunctioning in the mitochondria, could be related to shortening of telomere length. Is it related to the weakening of the spindles or the cohesion part between the chromatids? And of course, if you have higher aneuploidy, you have lower pregnancies, lower live birth rate. This is a very interesting non-selection study where they did biopsy for the embryos, and then they stored the samples. They did the transfer. After they did the transfer, they ran the PGTA results, and then they compared embryos that were aneuploid compared to euploid, and we can see that aneuploid embryos had 0% chances of live birth. But what is also interesting, and we published this a couple of years ago, is aneuploidy is also related to embryo arrest. So maybe sometimes embryos, they arrest. We don't get the chance to biopsy them to see if euploid or aneuploid, but it could be that they are arrested because they are aneuploid, because what we've shown is that segmental duplication monosomies are linked to developmental arrest at the cleavage stage. One very important factor is the anti-Mullerian hormone, and several studies have showed that independent of age, it is associated with higher aneuploidy rate. We've published this paper showing that not only associated with higher aneuploidy rate, but also lower AMH is associated with lower blastulation rate and utilization rate. So this is something also to take in consideration. And we published a couple of years ago with our colleague Dr. Laura a paper showing that patients with AMH of less than 1.09, they have significantly lower oocyte survival rate. So I think this is also important for the doctors to consider when they decide the treatment plan for the patients. I think Dr. Fatemi published and talked about this in several occasions. Vitamin D is associated with infertility. They published with Dr. Barbara this paper a few years ago, and this motivated us to perform this study where we measured the 25-hydroxyvitamin D levels in the follicular fluid, and we found that they were associated with higher aneuploidy rate. So, patient characteristics, done. The third thing is ovarian stimulation and also endometrial preparation. We've seen this figure many times, I think, today. We know that this, what happens in nature at time of ovulation with the surge of LH and FSH, and this represents also what do we do when we give the trigger shot. Why I mentioned this and how is that relevant? Because I want you to imagine one thing. The ovarian reserve at time of birth is actually oocytes arrested at the prophase 1, right? And they remain arrested till when? Ovulation. So this could be 20 years, 30 years, 35 years, right? So they initiate from, for the meiosis 1, they go from the prophase 1 till metaphase 2 oocytes, which is this one, when we get the LH and the FSH surge, which shows how important is this trigger shot. Now, this is referred to as the nuclear maturation, but also what is also important and dangerous is the cytoplasmic maturation. Why? Because there is no physical indicator so that we know that it was achieved. The second thing, because during this maturation process, you have rearranging of organelles, you have storage of RNA, metabolites, proteins that are extremely important for what? For fertilization and the first few days of division, until we get the embryonic gene activation. So imagine if anything goes wrong with the nuclear, we will end up with aneuploidy. And if anything goes wrong with the cytoplasmic maturation, we get lower fertilization and worse embryo development. This is a very interesting paper where they aimed to investigate in the lab why do we have high degeneration rate, or in which cases we have degeneration rate. Is it related to the operator of XE, or is it related to the operator of denudation? What they found is none of these operators was associated with the higher levels of degeneration. What they found is cycle with lower levels of estradiol at day of trigger and higher levels of FSH are the ones more subject to degeneration. So eventually degeneration was linked to something related to the patient, number one, and the stimulation, number two. This is a paper my colleague Raquel presented in ESHRE a couple of years ago showing that FSH levels at day of trigger are linked or associated with higher aneuploidy. And this was in concordance with a previously published study with the same conclusion, but instead of doing the biopsy on the blastocyst level, they did it for the polar body. So they gave information about the aneuploidy of the oocytes rather than the embryo. We published this paper last year showing that if you look at the progesterone level day of trigger divided by number of follicles, so the P4 levels per follicle, they were negatively associated with ploidy. It means the higher this level, the higher the aneuploidy rate. And we found even that these type of patients, when you have high mean of P4 at day of trigger, they have lower embryo quality. This was again presented in other study showing that levels of higher than 1.5 nanogram per ml a day of trigger are associated with lower embryo development. The authors of that paper, they think that it could be explained by some pathways during the cytoplasmic maturation that are progesterone sensitive. So these high levels of progesterone will affect the work of these pathways, and then you end up with an incompetent cytoplasmic maturation. That's why we see the effect on the embryo level. We know that there were several studies looking into even the type of gonadotropin used in the stimulation, and it has been linked to the number of oocytes and embryos that you utilize at the end of the cycle. So somehow there is evidence that it could be associated. The type of trigger shot that we use, this is the study in poor responders comparing dual trigger with HCG. Again, better fertilization, better number of M2, and better embryo quality when we use the dual trigger. Dr. Barbara showed the pattern of what happens in natural cycle compares to what happens when we give the trigger shot. So I think the dual trigger is closer to what happened in the natural cycle with the LH activity. That could explain why we get better embryo quality. This was the same study comparing dual trigger SCG but with normal and high responders, and again they came to the same conclusion: you get better embryos if you use dual trigger. We've seen this slide with Dr. Fatemi, so we don't need to explain it anymore. Now we have tools, we have information we didn't have before. Now we can understand or pinpoint the time for window of implantation more accurately, and knowing all of these with the progesterone level after the trigger, what happens, I think simply with a simple change of decision from fresh to frozen, in some cases this can change from our KPIs from negative to positive, because if we think, for example, we have an excellent quality embryo, if we have low levels of P4 at day of trigger, then whether you transfer in fresh or frozen doesn't make a difference. But if there is communication between embryologists and doctors, if we discuss with each other and we found out that the embryo is slightly slower and the levels of progesterone are slightly higher, then changing the decision from fresh transfer to frozen transfers increases the chances for that patient by 3 times. And I think it's worth the discussion or the communication. So ladies and gentlemen, in order to summarize, one hand cannot clap. We need to work together in order to improve. I think in order to be able to individualize the treatment for our patients, we need to explore all the possible factors. If we focus only on one part, then we will miss all the other parts, and that will limit our capability of providing something new or improving a little bit the stimulation or the treatment plan for the patient. Thank you very much.
Thank you, Ibrahim, for the excellent talk. Any questions? Now, with your talk, we know that it's an equal blame for everyone, clinician, embryologist, and the patient. But anything you want to say with which we can just blame the embryologist, it's because of him.
But I hope so.
Thank you.
Okay, so we now move to the third speaker of the session, that is Dr. Mina Popovic. She had her PhD at Ghent University, and now she's the scientific director of the Eugene Group, and she's also the chairman of the special interest group of stem cells in ESHRE. I want to tell you one small thing, just because you understand the importance of all this. Almost 20 years ago, I was not chairman of ESHRE, but I thought that stem cell could have a role in reproduction, so I desperately pushed to organize the stem cell group inside ESHRE. And I had to wait for a few years, because at that time the chairman of ESHRE didn't see, and the executive committee didn't see any advantage in having a stem cell group inside reproduction. There was already the International Society of Stem Cells and other organizations. So at the end, we did it, and for 5 years, the members of the special interest group on stem cells at ESHRE were 5. Then, little by little, since Anna Vega took over, here we have a very important group that Mina is leading at the moment.
So thank you very much. Thank you for the kind introduction, and thank you very much for the opportunity to present here today and for the invitation. And as Dr. Gianaroli said, we're very grateful that we have been able to set up this special interest group within ESHRE, and that within the field of assisted reproduction that the value of stem cells is being recognized. So today I'm very happy to be able to talk about the topic of synthetic embryos. This field is a very exciting one. It really brings together developmental biology and stem cell biology. And I often encourage stem cell scientists to really communicate and share their experience with embryologists, and also to benefit from our clinical practice in some ways. And I really think that this will push the field forward. So the field of synthetic embryology has been a really fast-paced one over the past few years, and I hope that with this talk I can give you a bit of a snapshot of what the current state of the art is. So I think a good place to start is just to put you in the field and to show you some of the latest articles that have been coming up over the years regarding this topic. We've seen many reports in the media of about scientists being able to create models of embryos using stem cells. This has occurred both in mouse, also in human. However, this has also raised some ethical questions, and the main question being, are these synthetic embryos actually getting too real? And as I go through this talk, I'm sure you'll be able to really understand the meaning of this question, and we can talk about some of the ethical issues at the end. So for many years, we have been asking the question of how a complex organism derives from a single totipotent cell. A totipotent cell being a zygote. So a zygote has the potential to develop or to contribute to all cells of the body. And that's why we call it totipotent. So it can contribute to both embryonic but also extra-embryonic lineages, so cells that contribute to the placenta. And we have learned a lot about pre-implantation human development through assisted reproduction, of course. We've been able to really visualize the development of the embryo and see events such as fertilization, also embryo divisions, the formation of the blastocyst, and we have surely learned a lot. We've also learned a lot from animal models such as the mouse, and as you can see, at least during the pre-implantation stages, the mouse development really mimics that of the human. And we've also been able to culture embryos beyond the implantation stages. So we can actually push development so far up until day 14. And why day 14? Because that has been established as the legal limit for culturing human embryos. But we have seen that these post-implantation embryos that are cultured in vitro do have features that are associated typically with these stages of development, such as the formation of the epiblast, also the primitive endoderm contributing to the yolk sac, and also the trophoblast, of course, which contributes to the placenta. However, our knowledge of embryogenesis so far has relied only on the direct observations of these in vitro developing embryos. And of course, this has been the limiting factor for uncovering the more intricate processes that surround embryogenesis. This doesn't give us much flexibility. And also the availability of embryos for research is quite limited. And so still some processes surrounding embryogenesis, specifically lineage specification, still remain unknown. So methods that allow us to study early development that do not rely on regular access to embryos are of great benefit. And this brings me to stem cells. So culturing and being able to derive and culture and differentiate stem cells in vitro has really advanced our understanding of developmental processes. So what are stem cells? Well, these are undifferentiated cells that are present in the embryonic, fetal, and adult stages of life, and they give rise to the building blocks of tissues and organs. And of course, they are critical during development, but also during the adult stages of life for tissue repair and regeneration. So what defines a stem cell, at least in vitro? So in vitro, we are able to derive stem cells, and they have many unique properties. Firstly, that they are able to self-renew. So they are able to proliferate and be renewed basically indefinitely. They are clonal, so they can arise from a single cell, which is very useful for genetic manipulations. And they also, we are able to capture through them this potency, so this potential to differentiate into different cell types. And of course, this is very valuable not only for developmental biology, but also for regenerative medicine. So potency being this very unique characteristic of stem cells, although we can maintain it indefinitely in vitro, in vivo it is a transient characteristic. So as I mentioned, the zygote is totipotent, so it has the potential to contribute to embryonic and extraembryonic lineages and all the cells of the body. But as we progress through development, the blastomeres become more restricted in their potential. So when we come to the blastocyst stage, the Morella cells will either contribute to the trophectoderm or the inner cell mass as part of the first lineage specification. And here we already have a restriction in the potential of the cells. The inner cell mass cells being known as pluripotent because they can now contribute only to the embryonic lineages, and the trophectoderm cells defined as multipotent because they still have potency in the sense that they can contribute to an array of cells within the placenta, but they can of course not contribute anymore to embryonic lineages. And we also have the second lineage division of the inner cell mass. So here we have the formation of the epiblast and also the primitive endoderm, where the primitive endoderm is also known to be multipotent. It contributes to cells of the yolk sac and the placenta. So all of these different phases, let's say, of potency can be captured in vitro. However, this hasn't been easy, and it has really relied on an intricate balance between embryo developmental stages, understanding these developmental stages, and also being to replicate the environment during these stages of development. So we have been able to capture these states through the generation of different stem cell lines. And these are able to recapitulate the morphology, the gene expression, and also the developmental potential of their parent embryonic lineage to varying extents. So perhaps the most attention has been given to embryonic stem cells. And these are stem cells that are derived directly from the inner cell mass of blastocysts. They have been derived in both mouse and also human. But also I would like to mention induced pluripotent stem cells, and these are very interesting because actually we have been able to reprogram differentiated somatic cells, so say a skin cell, to a more stem cell-like state. And this was actually a groundbreaking Nobel Prize achievement. And it really revolutionized the field because it opened many new opportunities for deriving patient-specific applications, so a lot of potential for regenerative medicine. And also the prospect of induced pluripotent stem cells actually eliminated the need for embryos for stem cell derivation. Other types of stem cells that we've been able to capture, first in the mouse, this has been a much easier model to work with, and we have been able to derive embryonic stem cells, as I already mentioned, but also stem cells that recapitulate the primitive endoderm, so these extraembryonic endoderm cells, and also trophoblast stem cells, and these have been derived directly from the mouse blastocyst. In human, capturing these developmental potency states has been a bit more challenging. It took longer to derive embryonic stem cells, but trophoblast stem cells were only derived a few years ago directly from the blastocyst, and we still don't have a good model for extraembryonic endoderm cells from the human, well, derived directly from the human blastocysts at least. We have been able to derive these cells through the conversion of embryonic stem cells, so derived from the inner cell mass, to a more extraembryonic endoderm-like state. And as you can see, when we derive these cells, they do express markers that are associated with the primitive endoderm. And finally, another very interesting type of stem cells that have been captured in vitro are these extended pluripotent stem cells. And these actually have a more totipotent-like developmental potential, which are very interesting for synthetic embryology, which I will explain in a moment, because they are able to generate both extraembryonic and embryonic lineages. So these have been derived directly from the blastocyst, but also from embryonic stem cells through the use of different small molecule compounds, and then also from somatic cells and the 8-cell stage embryo or blastomeres. So all of these different stem cell types have really led to this field of synthetic embryology. What's interesting, we have started with embryos, we have gone back to the building blocks of embryos, and now we are using them again to generate synthetic embryos. And we are able to actually capture varying stages of development, both in mouse and in human. And we are able to capture pre-implantation development, specifically the blastocyst stage of development, but also various post-implantation stages, and I will run through some of these. So first off, let's start with the blastocyst, and the first models of these blastocyst-like structures were generated in the mouse, or from mouse stem cells. And this paper from 2018, published by Nicolas Revron and colleagues in Nature, well, here they actually combined embryonic stem cells, so those from the inner cell mass, with trophoblast stem cells, and they used these special microwell arrays, and they were able to seed the different cells together, and remarkably, these cells in the right conditions self-organized into structures that really resembled a mouse blastocyst, and they expressed the correct markers as well. Interestingly, they actually went a step further and they tried to implant these blastocyst-like structures, or what they called blastoids, into pseudopregnant mice, and they did induce decidulization. However, these blastoids didn't progress through the post-implantation stages. And one reason that it was assumed that this couldn't be the case, or that they couldn't really progress through development, was that they were lacking the primitive endoderm. So for this reason, in a further study by Bernassosen and colleagues, they decided to combine these extended pluripotent stem cells, so the one with a more totipotent-like potential, with trophoblast stem cells, trying to mimic the blastocyst even closer. And again, they were able to actually generate these blastoids that certainly looked very similar to a mouse blastocyst. And when they cultured these blastoids through the post-implantation stages, we can again see that they really do mimic natural embryos. Here in the bottom panel we have the natural embryos, and we compare them to these extended blastoids that were cultured for several days. We can see very similar phenotypes, and they actually form these egg cylinders that are associated or very typical of mouse post-implantation development. Again, they tried to implant these embryos, so they transferred them to mice. However, still, post-implantation development didn't progress further. So they did induce decidulization, but no further implantation. And there are some further models. Also, this one is interesting to mention because it's generated solely from these extended pluripotent stem cells. This is again a mouse blastoid model, and specifically very interesting because actually these extended pluripotent stem cells were derived from somatic cells, which basically shows that we can start from a somatic cell such as a fibroblast and generate a blastoid. So in human, also there have been several models of blastoids. The first one was actually generated exactly like this through the conversion or reprogramming of human fibroblasts, so skin cells. And during this reprogramming process, the researchers isolated a cell population that they then placed into these agri-wells. And again, these cells reorganized and self-organized under the right conditions into blastoids, so into structures that did really closely mimic blastocysts. And also when they did some more detailed molecular profiling of these blastoids, we can see that they really do resemble human blastocysts. They expressed the correct markers and the correct lineages. However, up until this point, these protocols were very inefficient. So the number of blastoids that could be obtained was very low through these methods, until couple of years ago, when again the group of Nicolas Revron and colleagues, they improved this protocol, and as you can see now, they were able to generate hundreds of these blastoids or blastocyst-like structures. So really this was a high throughput protocol, which opens up a lot of opportunities for further research, of course. In this study, they actually went a step further, and they mimicked the process of implantation. How they did this was with using endometrial layer of cells, which they derived from endometrial organoids, which were obtained from endometrial biopsies, and they exposed the blastoids to these cells, or the cells to the blastoids, and they really looked at these embryo-endometrial interactions. And what they observed is that the epiblast in the blastoids induced this local maturation of the polar trophectoderm when interacting with endometrial cells, which is what we assume also happens in vivo. So this was an interesting demonstration that these blastoids were able to really recapitulate in vivo processes. There have been several post-implantation models as well, so these are just some to mention in human. This is a model where stem cells were actually plated into this micropatent culture, and what was interesting is that they also reorganize at least into the pattern of what we expect in a post-implantation embryo, where we have the epiblast in the middle, followed by the primitive endoderm and the trophoblast. So this is an interesting model for studying interactions between these lineages. And further models that capture only the epiblast-like structure of the post-implantation embryo have also been developed, and these are interesting because following the formation of the epiblast, we have gastrulation that occurs, which is a very important step in development where the three germ layers actually start. So these was also, the scientists were also able to recapitulate these processes. And they went a step further, creating these human embryoids. Again, these are embryos at the post-implantation, or embryo-like structures at the post-implantation stage of development. And as you can see, they really do look very much like the textbook embryos that we are used to. There are some specific models as well that look at specific aspects of development. So this is a human model of the amnion that has also been generated from stem cells. And this is an interesting model because the researcher applied this microfluidics system to grow these structures. And in fact, as you can see here, this is the channel for the loading, and they can actually load the cells here, and they can alternate different compounds with this gel. And in fact, you can see the formation of this amnion-like structure and also these large embryoids. And in fact, when they looked at these structures further, they actually observed cell populations that resembled primitive streak-like cells. So these are cells that are involved in the gastrulation process or initiate gastrulation, endoderm-like cells, and also primordial germ cell-like cells. There are also models that capture different aspects of gastrulation. As I said, this is a very important moment in development, and it's a very late moment in development. It occurs around day 16, at least during the early post-implantation stage. And what different models have been generated for looking at neural tube structures, also or these elongated gastrulation models that look at interactions between different cell lineages, and more complex models. So up until now, we've been discussing models that mimic certain aspects of development, so certain stages that don't really seem to have the potential to progress further throughout development. However, recently there was a major breakthrough with the culture of synthetic mouse embryos for an unprecedented length of time. So here the researchers started from early post-implantation stage, and they were actually able to culture these embryos ex utero up until day 8.5. So this was performed in mouse, and actually the embryos or these embryoids were cultured for a third of a mouse pregnancy ex utero. And some of these embryo-like structures also formed beating hearts, early brain structures, and spine-like structures, which is quite remarkable. And they even developed extra embryonic tissues, and this was all without the need for maternal tissues. So how this was performed is that they used this rotating device in which they seeded the cells that formed this early post-implantation embryo that then progressed throughout development. And this system was originally used to culture natural embryos from day 5 to day 18 in the mouse outside of the uterus. So this corresponds to about day 15 to 21 in human. And in fact, what was interesting that natural embryos can be cultured longer in this system, but still with the synthetic embryos, we can really reach quite an unprecedented length of time. And last year, this was taken a step further also with human embryos. So again, and these were synthetic embryos that were generated from stem cells, and they were again able to be cultured all the way up until day 14. So this is the first time we were seeing these embryos in these 3D configuration, and they actually contained all cell types and captured key hallmarks of post-implantation stage embryogenesis. So here, as you can see, these types of models are really in stark contrast to the non-integrated synthetic embryo models, which are the ones I was discussing previously. They're really modeled only specific stages of development. Here we can really see the capacity for further developmental potential, as these synthetic embryos contain all the correct structures. So this field of synthetic embryology certainly offers a paradigm-shifting experimental system. It offers a lot of promise and potential for advancing the field of developmental biology, for allowing us to understand all kinds of aspects of development, but also for providing a very good experimental model. So, for instance, for testing, for drug testing, for looking at the effects of different compounds on development. And there are several technical advantages of this system. First, that these synthetic embryos can be generated in large numbers, so they really do allow a high throughput. They also allow lineage-specific genetic modification. So we can take these stem cells, we can perform gene editing, such as CRISPR-Cas, and then we can look at how these cells behave within these synthetic embryos. And they, of course, will reduce the need for animal and human embryos for research. However, we have to keep in mind that these embryos really need to mimic in vivo development. And there is a very elegant quote from Husser and Streeter, who said the embryo is a machine that needs to function while it is being built. They actually stated this in 1941. So this is something that we really have to keep in mind. Although these embryo-like structures do look like embryos, they need to really represent in vivo development, and we need to continue to benchmark these models with in vivo processes. But this also really complicates their validation, because some of these in vivo processes are, of course, very difficult to study. And finally, just for the last minute, I will just mention the ethical reflection and the societal debate that really is necessary. So as you can see, there is a striking resemblance of these synthetic embryos to natural embryos, and they continue to improve. So this, of course, raises ethical questions, and really this possibility that these synthetic embryos could one day be cultured ex utero to full development. And this remains a critical question. Another thing to keep in mind is that the genome of these synthetic embryos is a genetic clone of the stem cells or the donor cells of origin, so this needs to also be evaluated. And again, the culture of synthetic embryos beyond the current day 14 limit has also been a topic of discussion. And we really see several sides of this debate, that some scientists believe that these synthetic embryos will never really reach full developmental potential, so they shouldn't be regulated like human embryos for research, whereas others really do see the potential. And I think it will be a very important question in the future. And having said that, we have to also avoid the sensationalization of these findings and really try to discuss and understand the potential of these models. So I think that this system really is valuable, and it is becoming certainly more and more prominent, and novel opportunities for exploring the early days of development through this system really give us an opportunity to look at development in real time and in unprecedented detail, and I do believe that we are faced with exciting times ahead. So thank you very much for your attention.
Thank you very much, Mina. It's fantastic presentation. Do we have
I want to ask a question.
Yes.
Okay, sure.
I have a very basic layman question. We know stem cells are totipotent, they can convert into any type of cell. So how do you in the lab actually differentiate them? That, okay, you become a fibroblast, you become another kind of a cell. What do you, is it any radiation or media? How do you do that?
Yeah, so it's done with different protocols, different media. And the more we learn about how these cells actually develop in vivo to these different tissues and lineages, the more we can adapt these cultural conditions and the better we can improve them. So currently not all differentiation protocols are efficient. Some lineages are easier to get to than others. So certainly even in terms of regenerative medicine, we are not, there's still a lot to learn, but it's basically the more we understand about development, the more we can improve the cultural conditions and push these cells to the state or the stage or the tissue that we want.
Another thing, this synthetic embryo seems to be like one single parent baby. It's coming from the same person, right? So how it is different from cloning? Is it same like cloning?
Well, basically, yes, it's the same because we're deriving, as you mentioned, if they are derived from fibroblast or the embryo, the genome will be the same to the fibroblast or the embryo that the synthetic embryo is derived from. So we have to keep this in mind, and this is very important also for consent forms because originally when, say, patients have agreed to donate their embryos for stem cell derivation, they may have not had this in mind. So it's an important consideration.
Thank you.
Thank you very much again, Mina.
Thank you.
I invite our next speaker, Raquel. She'll be talking on artificial intelligence in ART. She's head of clinical data management unit at ART Fertility Clinic at Abu Dhabi. Raquel holds master degree in biotechnology of human assisted reproduction and PhD in medicine, magna cum laude at the University of Valencia. She has authored or co-authored of many over 50 peer-reviewed research papers and abstracts in international journals and conferences. She specializes in time-lapse systems, especially on improving embryo selection through morphokinetics and the introduction of AI in the IVF lab. Welcome, Raquel.
Thank you very much for the very kind introduction, and appreciate it for everyone that made it to this talk, because I know after lunch is always difficult. Last year, for those who were able to attend the conference, I made a little introduction on the applications of artificial intelligence that are getting introduced into the IVF lab. And this year I wanted to make a little update on the lessons that we've learned with all of the new publications that we have in the research. So basically, many papers have been published since the beginning of AI started in IVF. And we've been able to answer many of the questions that we had in the beginning. However, many others have been generated thanks to them. And just as a number, only in 2023, 55 publications were done on AI in IVF, which are a lot. So let's go through them. I wanted to focus on these lessons that we've learned, and I've stratified them into three main groups. One is data selection, another one is methodology, and the third one is transferability. So starting with data selection, I'm going to start with an example of one lesson that apparently we haven't learned, because this one is one of the first papers that we published in using deep learning to be able to predict fetal heartbeat in embryos, and they were using videos of the embryos. And as we can see here, it's really impressive what they achieved, and because the predictive was with an area under the curve of 0.96, which is perfect. So, however, when we were looking into the materials and methods, we can realize that they didn't use the right labeling of the outcomes. What does this mean? That if you realize the positive pregnancies were only an 8% of the data set. However, negative pregnancies were 8,000, which was the majority of the images. So in the end, we realized that the negatives, they not only included those embryos that we transfer and they didn't do a fetal, healthy fetal heartbeat, but they also included embryos that were blocked in cleavage, blocked in day 2. So maybe the embryologists would have never chosen those embryos for transfer, and this is not a right way of selecting these embryos. And why I'm saying that we haven't learned the lesson is because a couple of years after, we have been seeing other papers doing the same mistakes. And they were using for live birth rate in this case, and the positives were, of course, the live births, but the negatives were including as well all of these discarded embryos that an embryologist would have never looked at. And in the end, the positive live birth was only a 15% of the data set, and that's why the area under the curve is so high, but it's not realistic. Another controversy that has been very well spoken about is whether we should use static images at specific time points or dynamic videos of the full development of the embryo. And the majority of the papers, I would say 90%, have been using static images because it was easier to find this data. The majority of the labs nowadays, they are using normal microscopes, so it's easier to make a picture of our blastocyst rather than having time-lapse systems. However, this has been debunked by a very nice paper that has been published recently, and what they were seeing is that the embryologist can assess the embryos at many different times throughout the day. And sometimes because you have way more patients or maybe less people in the lab, you will have to delay the assessment that you do to our day 5 embryos a bit later or a bit earlier. And what they realize is that the time at where we assess these embryos can affect a lot to the prediction of live birth. So maybe if you were taking the picture a bit earlier and maybe the embryo was a bit collapsed or not looking as good, but then it was recovering, we will be predicting a bad live birth rate when we could have predicted a baby. So a next point is whether we should use clinical data or not use clinical data into the models. The majority of them are only using images or videos, but they are not using the clinical data. However, papers that like this one have represented that whenever we were using only single images to then the full video and then even including clinical data, morphokinetics, and even optimization of these videos, the prediction was improving in all of the models as we were introducing more and more data. So it's really interesting that we keep adding these clinical data points. However, we need to be careful because sometimes the clinical data points are very strong and they can blur our image analysis. So like for example, in this paper here, they were predicting for ploidy and they were using morphokinetic data. And what they realized is that when they created these two models, one using morphokinetics and 3 clinical variables, and the other one using morphokinetics only, the predictions were pretty similar. However, the age in these clinical variables was so strong in the prediction of ploidy, as we all very well know, that it was blurring the data of the morphokinetics. It was not as predictive. So in the end, they realized that an age model was predicting as good as any of the other models using morphokinetics. So in the end, we have to be very careful because age was so significantly associated that it was very difficult to beat. However, age is affecting equally to all of the blastos that we have in the cohort, and we cannot differentiate and rank between different embryos. So this we have also to take into account, and that's why they were concluding better to use the morphokinetics only, although it was not the best model. And here as well we can see it very nicely how the use of clinical data was improving our model. This one, the blue one, is the video model alone, and the hybrid was including the data and it was improving the prediction. And we could see which ones of those parameters were the best and the worst in the prediction. And very nicely, when they tested the model, they realized in 6 different clinics that the clinic that the model was working the worst, they realized that 38% of the data points were missing. So they realized of how important it is to have these clinical data points. And a big shout out to all of the clinicians and embryologists in the room that we need to maintain our data very clean and filled in. Never forget to put the information into our EMRs. This study was checking something similar because they were also comparing between clinics how the model that they developed was performing. And they realized that these 2 clinics were performing significantly worse. So when they checked into the patient characteristics, they realized that these 2 clinics in particular, the mean age was way lower. They were very young patients, as compared to the rest that were in the late 30s. So they realized that maybe it's not about the model not being to predict well there, but about our data sets being biased. Because the model learned how to predict on these older population patients, but maybe it didn't have enough data to learn to do these predictions in younger populations. So we should increase the younger populations. So of course this is very important at the time that when we are going to introduce the models into our labs, because if these trained models are not trained in similar characteristics, similar practice, and similar data as our lab conditions, they will not be able to predict as good as another model done by our own data. And these are called the noisy labels because they are confounders that are inside the data that we don't know about or we haven't seen properly. Okay, and these, however, we've seen that when the younger patients were not well predicted, it was because it was an unbalanced data set. However, when we balance the data set and we have similar numbers of young and old patients, they saw that still there was significant difference between the prediction of young and older patients. Our models are predicting better when the patients are older than when the patients are young. And they started discussing why is this, and the 2 main theories came into the picture. One of them is that maybe in these young women, the infertility could be due to non-embryonic causes. Maybe these patients, of course they are young, maybe they have very good embryos, but in the end something in the receptivity on the endometrium or any uterine problems can be affecting these pregnancies. Another point was that maybe these patients, because they are young, they have way more good quality embryos. So it's more difficult to rank between better, very good looking embryos rather than very different ones. And they also saw this with the transfer protocol. When they were comparing how the models were working with fresh transfers and cryopreserved transfers, they realized that they were doing way worse with cryopreserved transfers. And this has been explained possibilities because we are not introducing clinical data points on the transfer information in cryopreservation. We are not putting information of how the embryos reacted to the vitrification and the thawing, how did we do the endometrial preparation. So maybe this lack of information is affecting how these predictions are done, and we should be adding this information as extra. Okay, and now we are moving into methodology. And it's very important to do a very strong pre-processing step before we move on to the creation of the models. And there's so many different images coming from so many different microscopes, time-lapse systems, different wells, different dishes that we use, different saturation, brightness. There's so many things that we need to homogenize so that the models are predicting accordingly, that it's very important step that we do this properly. And if we don't, we can see in this example that when they got embryos from 1 and 2 clinics, the first one were way better quality than the second clinic. And if you realize here, the clinic A, they were predicting better score even if they were positive pregnancies or negative pregnancies than the clinic B. The clinic B positive pregnancies were even scoring worse than the negative pregnancies. And it's because the data was not properly homogenized, not properly similarized like the images. So it's not a real data set, it's biased into the image. So we need to standardize and calibrate this. And an interesting part of this paper as well is that they realized that when the inner cell mass of our blastose is well defined in focus, this is way more predictive of how it's going to become into a pregnancy than when the trophectoderm is properly in focus, giving it more importance to the inner cell mass. So now that we have the preprocessing stage done properly, we move on to methodology, the creation of the model. And this has created a lot of controversy because there's a little bit of clashes now between traditional statisticians and computer scientists. And there's many different ways of doing this artificial intelligence. We can do more traditional machine learning models, and we can go more deep into now that it's very trendy, deep learning and the neural networks. However, even published papers are trying to compare how the different methodologies can affect the result. However, this is a bit of nonsense because they are all similar tools. They are there for the same function, and each one has a specific function. So we should combine them into models that could be predictive, but we shouldn't be comparing them because they are doing, in the end, different things. So, and this study in particular was able to find this correlation. They ended up saying that logistic regression was the most reliable one, but it was only because they were using morphokinetic data. And these more traditional methods are good with data points. However, if we were about to use image analysis, we wouldn't be able to do it with them, because for image analysis we need stronger models of deep learning that will be able to analyze all of the information that an image has. So of course we are still not convinced on it. But still, of course, this deep learning creates a lot of concerns. And many papers have been saying the black box, we don't trust the black box, maybe we are not being able to interpret what the model is looking at. But this is not the reality. And in fact, there are many, many ways we can see what's inside this black box. And they are saying that maybe if we do things more manual, like we've been doing it forever, doing normal Gardner criteria, normal morphokinetic annotations, we will be able to create a model that is very subjective because it's very dependent on the embryologist, but very interpretable because we know what we are looking at. However, if we do this deep learning, which are all hidden layers and we don't know what the model is getting, we will be able to do it very objectively, but we will not know what's happening inside. So they were suggesting to do something in the middle. However, as I was saying before, we've been creating many things to see how the model is getting information from the images. And for example, these mappings can tell us in which points of the image the model is finding useful information to predict live birth, pregnancy, or whatever endpoint. And here we can see similarly how the inner cell mass and parts of the trophectoderm are also very important in the prediction. As well, in this other project, they did similar things with gradient waist class, and they were seeing, if you can see, the lighter color, the yellow, was the important parts of our blastose, and the more purple were the less important parts. So we can see what's the black box looking at. And also, in the clinical parameters, we can always do this SHAP analysis that will weight the different clinical points, which ones are more important, like for example, age is always there, and which ones are less and less important in our model. And this will be help us to find new biomarkers maybe in the images. Maybe it's showing us that a specific point in the blasto or in the cleavage stage is very important, and maybe we can find new things to look at in our embryos. Okay, and then the last point is transferability. Like, how are we going to transfer these models into other clinical settings? And this is very tricky because these models are trained under very specific settings. And the only way of doing this is that the models were trained with all of the data in all of our clinics, all of our countries, so that it could fit everyone. However, this is impossible. And whenever we want to put one of these models into our labs, we need to really see what's the patient population it has been trained on, what are the culture conditions or any other lab conditions, and what are the stimulation regimes, the protocols, anything that we are using to see if it matches our lab. And there has been this editorial published by The Lancet saying, like, stating the importance of doing this transfer to other clinics because there have not been randomized controlled trials done. In not even this, there have not been any prospective studies to validate these models. So of course we should be very, very, very careful before we implement it into our labs. So just to summarize, our objectives with AI are still the same. We want the models to be effective and to mimic at least our practice. We want them to be automated to help us in our normal workflow, in our normal practice. We want them to be non-invasive so that we mimic the natural environment as much as possible. And we want them to be objective, to reduce the human error and to homogenize the experience level inside the lab. And to summarize what we discussed today, we need to really understand the patient characteristics. To add always clinical variables, we've seen how important this is. To maintain the good quality of our data and always fill in the fields. Time-lapse is crucial because we've seen that dynamic images are so important. Strong pre-processing step to homogenize our images. A good methodological combo, we can always use several analyses to achieve this. The black box is very effective with image analysis, so let's not be that afraid about it. And be careful with the very noisy labels, which are always a problem. And we really need to understand our population and our data. And all of this is to have data-driven solutions and to be able to interpret well these results so that we can communicate to our patients to have a baby born at home, which is our ultimate goal, of course. So just as a thought, as a little conclusion, I want to say that it's very important to do a bit of critical thinking when we are developing these new technologies, because everyone wants to be the first one in publishing these papers because it's so innovative, and we all love Usain Bolt. But this is not a sprint, this is a marathon. And we need to do more like Kipchoge, which was the first man that has beaten the 2-hour record of doing a marathon under 2 hours. And we need to go little by little and learning from the mistakes from the past and doing more critical papers rather than going quickly to publish whatever we can so that we are the first ones. So that's the conclusion. Thank you.
Thank you, Raquel. Are there any questions?
So if there are no questions for you, thank you very much again. And on behalf of my co-chairman, I would like to close this session saying that for many of us as clinicians, I think it has been an extremely important session. I think that we learned a lot. And once again, the combination of different specific knowledge in the embryo lab, in the clinical lab, it really will help us to improve the results. So once again, thank you to our speakers, and thank you to you to have attended this session.
Thank you so much, Dr. Luca and Dr. Meenakshi. Now, as we move forward, we have panel discussion, how to select the best embryo. For that, I'd like to call upon Dr. Surleen Kaur, who is going to moderate this panel. She is Lab Manager, ART Fertility Clinics, Delhi. And Nandita Sanjay was going to be the co-moderator, but unfortunately she is not here right now due to personal reason. So Surleen, please can you conduct?
Good evening, everyone. I feel privileged to moderate this session on how to select the best embryos, and I call all the panelists to come onto the stage. So we have with us Akshi, Abhinav, Bhagyashree, Parita, Ibrahim, and Afreen. They are all the embryologists from different ART fertility centers. Yeah, can you please help me how to move the slides? With this? Okay. So I welcome you all. Okay. So more specifically, it is like the blastocyst selection, because we are in the era where we do culture and we take all day 3 embryos to blastocyst culture and we select the best. Okay, so we'll focus here to select the best blastocyst. Okay, in addition to this, there is one more shift, that we are shifting from double embryo transfer to single embryo transfer, which makes the selection more important and difficult also. So in order to select the blastocyst, we have different parameters like developmental fate, kinetics via time lapse, then blastocyst stage and grade, day of blastulation, and of course the ploidy if it is available. So we'll start with the first parameter, that is the developmental fate. So whenever we have more blastocysts, we look back and we check and we compare the cleavage stage pattern, like what is the fragmentation, symmetry, number of blastomeres, and then we check on the nucleus also, day 1 stage, that is 1 PN, 2 PN, or what is the shape and the size of the PNs. And then on day 0 we check for the morphology, specifically of the oocyte. So suppose we take a case and we start from the Bhagyashree. Suppose Bhagyashree, you have a case, okay, and you have 2 blastocysts and 4 AA, blast number 1, and the second blast is 5 BB, which is hatching blastocyst. Okay. And for 4 AA, it is developing from the embryo, which was 5 cell on day 3, and the second blast was 8 cell on day 3. Which embryo will you select for the transfer?
Okay, and this is a fresh cycle, fresh transfer.
Is a fresh cycle, transfer cycle, both are day 5 embryos.
Yes, so I would, for fresh cycle, I would prefer 5 BB over 4.
And why?
Because we see the overall development and it was perfectly growing fine on day 3. And the first one was 5 cell stage on day 3 as well. So we'll take consideration for that as well.
Okay, so your selection will be like to go with the 5 BB. And if I add more information and we go back a little more, like day 0 information, where on day 0 the 4 AA is from IVF, from the mature oocyte, which is looking good on day 1 at least we can see. And the second blastocyst, it was coming from the oocyte which had SER. Okay, so will you change your decision or it will remain same? And why?
Well, then yes, probably, but I would, it would be better if we have time-lapse kinetics data for this embryos as well, because sometimes IVF, we don't know the exact time of fertilization, and sometimes they are a little bit slower, like 1 or 2 hours. So probably that could be the reason. Then yes,
Right, but if you have a morphology comparison of day 0, the blast number 1 is coming from the good morphology oocyte, and the another blast is coming from the SER. So
yes,
will you change your decision based on that?
Yes.
So which embryo will you select, without SER or with
Without
SER?
SER.
Without SER. So this is how the developmental fate, when we check, we change our decision and we select the best embryo. So more information we have, we get more clarity which embryo is the best one for the transfer. Let's go to the second parameter, which is kinetics, and time-lapse helps always. Time-lapse always gives us more information about the various things like fast-growing embryo, slow-growing embryo, and whether to differentiate between the 1PN and 2PN. Then gives information about direct and the reverse cleavages, collapses, number of collapses, and the multinucleation. So suppose we have a second case for Parita. Let's see, and you have 2 blastocysts. Okay, these both are day 5 blastocysts, and you have to select one for the fresh transfer. Blast number 1 is hatching CC, and the blast second is the expanded BB. Okay, and when you check the time-lapse video, you found that the 5cc has the 0 collapse, and 4BB embryo collapsed thrice. So which embryo will you select?
We would go with the first one, because even though it's a CC, the fact that it is hatching out and it does not undergo multiple collapses, the multiple collapses can be a reason that it is aneuploid probably,
right,
because we are not genetically testing it. So I would go with the CC, and I would probably freeze the BB for the future.
Okay, or can we do the laser-assisted hatching on the 4BB? It might be the reason that because it's looking beautiful embryo 4BB as morphologically, but can we give the laser-assisted hatching and support the embryo and select for the embryo transfer, or no?
We could do that, but the point is, if it's not able to do it organically, by giving it the shots, we'll help it go out. But if it inherently does not have the capacity to be euploid, it might still not implant.
Great, thank you. Yes.
So this is an exam, huh? I didn't sign up for an exam.
Okay.
So in order for the audience to know that there could be another choice or another decision, maybe we limit it to a couple of questions, and all of us, we give our opinion for the same question.
Right, I agree, because...
No, yeah, you know, if we go to the first one, for example.
Right. Maybe you have a different opinion, because...
That's why, so that they know also the doctors that not necessarily all of us we agree with the same decision, or why did we choose this compared to the other. Yeah. And maybe you explain if these are realistic scenarios or you have created these scenarios.
No, these are, a few are realistic and only very few
so
are
just
likely.
in the meanwhile, because it will be, for example, if I was also a physician, if you tell me an embryo 5 cells on day 3 became AA, the other one was 8 cells became CC or less development, maybe we will not be able to relate, right?
Right, but that's why the IVF was mentioned in the 5 cell, because IVF sometimes you have, little slower growth as compared to the ICSI embryo development.
So did I convince you or no? To go back to the first question?
No, we have a question for you, because you have time lapse in your lab and you can answer this question better.
Okay.
So you have 2 embryos, again 2 blastocysts, same morphology, 4AB and 4AB, both day 5. And then when you looked at into the video, the time lapse video, you found that this first blastocyst was multinucleated at 2 cell stage. Then it was at 4 cell stage it becomes mononucleated, and at 8 cell stage it was binucleated. And the number of blastomeres that showed the nucleation is mentioned in the bracket. And the second blastocyst, 4AB, it was mononucleated at the 2 cell stage, both the blastomeres. And at the 4 cell stage, the 2 out of 4 blastomeres, they were multinucleated. And then at 8 cell stage, there was a binucleation in 2 of the blastomeres. Which embryo will you select based on the multinucleation factor?
So based on a study my colleague Ashna has recently submitted, and it's under review, we saw that one of the factors that associated with euploid implantation failure was multinucleation at the two-cell stage. So I think this is a very detrimental step, so I would go with the second embryo.
Okay, thank you. Let's go to the next parameter. Blastocyst stage and grading. Grading itself is a very subjective and it varies from embryologist to embryologist. So we'll have a different opinion we'll take. So we in the lab we grade the blastocyst as early blastocyst BL1, BL2, then BL3 is the cavitated blastocyst, then comes the BL4 expanded or BL5 as hatching blastocyst. Then we have day 6 which is hash out blastocyst, and we grade in our lab BL8 to those embryos, those blastocysts which are collapsed in a collapsed stage. So let's move to the Akshi. You have a case in your lab where you have two blastocysts, okay, both are day 5, both are hatching, one is CB and the another one is BC. So which embryo will you select for the fresh embryo transfer cycle? To which stage you give the more importance, to the ICM or the trophectoderm?
So I will select the second blastocyst, which is 5BC.
Okay, and why?
Because ICM, the quality of ICM can be related to the, can be positively related to the live birth rate. And for me, I feel if given some time to the trophectoderm, the cells can divide and we can have a better trophectoderm in that case.
Okay, Ibrahim, what's your opinion on this?
Yeah, I agree.
Yeah, so we have less miscarriage rate if we give more importance to the ICM and have better live birth rate. And the second scenario is that if we have for Akshi, that if we have 3 blastocysts, 3 BB, 4 CC, and the third one is 5 BB, which is in the collapse stage. So which embryo will you select out of these 3?
So for 5 BB, I'm not sure, I'm checking at one point, and I'm not sure if I don't have a time lapse that how many times it has already collapsed. So that's not a good sign if it has undergone spontaneous collapsing maybe 2 to 3 times. And for 4 CC, the grades are not so good. So probably if I have time in hand, I will observe the 3 BB, and I would hope that if it stays a BB grade, so I would go with the first one if I have time in hand.
Okay.
If I can culture for more time.
Okay, so Ibrahim, do you agree with the opinion? Yes.
Yes.
Okay.
Yes, I agree.
Okay, then we move to the next one. So blastocyst developmental day, which is important because each day has their different probability or success rate, day 5, day 6 or the day 7. So here we have a case for Abhinav. So there is a patient who is 40-year-old, and the patient has 3 blastocysts frozen, and there is a SCT cycle for the patient, and you have to select the best embryo out of 3 embryos for thawing and transfer. So first embryo that you have is day 5 embryo, which is 5 PB non-PGT, day 6 4AA non-PGT, and day 7 with 5 BC euploid embryo. So which embryo will you select for a thaw transfer for this patient?
I think since it's a 40-year-old patient, I would be much confident in knowing the ploidy status of that embryo. And also the research says that female counterpart above 38 years, the overall pregnancy rate of even a day 7 embryo tends to increase in a significant manner if a euploid embryo is transferred. So I think I would go with the third blast, which has a euploidy known.
Okay. What about if I say one will select the day 6 AA grade embryo non-PGT because it is still not detected, and being a day 6 has a better probability.
Day 6 has a better outcome in terms of the implantation, but I think since I know the ploidy status of a day 7 embryo, I would want to give that as a priority in my opinion.
So Afrin, do you have any comments on this? Do you agree with Abhinav's statement?
Yeah, I agree.
So is it because of the age factor we are giving more importance to the euploid embryo even if it is a day 7 embryo? Okay. So the next is if we have to select the blastocyst which is coming from the cohort of euploid embryos, in this scenario we give importance to grade, day of the blastocyst, blastulation day, mitoscore, and after thaw we also give the importance to re-expansion. So here's the case. This case is for Ibrahim specifically, that patient which has 3 euploid embryo frozen at frozen stage, and this is the last attempt of the patient. So it is decided to thaw all 3 embryos and select the best one for the transfer. So these are the embryos. So before thaw we have this scenario that we have a day 5, day 6 and day 7 embryo. Day 5 is a very good embryo for AA with mitoscore 38.1. Day 6 embryo which is for BB, mitoscore 25. Day 7, 5cc, 19.7. So which embryo will you select for?
The first day 5 for AA.
Done. And when you thaw all the embryos and you kept it for 4 hours after thaw, so you see that for day 5 AA embryo there was no expansion even if you cultured it for 4 hours. BL1 stays at BL1. For day 6 embryo, when we culture it for 4 hours post thaw, there is a partial expansion. And for day 7 embryos, the embryo was expanded to hatching stage after 4 hours. Now will you change your decision or you'll go with the same, with the partial?
Yeah, look, I appreciate what you're trying to do with these scenarios, but we should be very careful when we compare, when we use the evidence, the scientific evidence, using different factors. For example, now there was some studies suggesting that we can use mitoscore as a factor for prioritizing embryos. Now most of the recent studies, they show that this is not useful, okay? But we never had a study to compare morphology versus mitoscore. Which one of them is a better predictor? Now, I would first investigate the lab, because if a 4AA day 5 does not re-expand, I indicate something. If a day 6 doesn't re-expand after 4 hours, there is something, or could be something. The day 7 embryo, which was CC after 4 hours, is a BL5. I think this is not a realistic scenario. Now, assuming that this is the scenario we have now, we are preparing one paper to be submitted hopefully in the next few days. What we found, we do a lot of PGTA, and it's not very clear, there is not proper consensus or guideline on what is the best time to freeze the embryos after you do the biopsy. So some recommendations, they are saying less immediately or less than 1 hour. Some they say no, if you wait it's better. So what we did is, for our PGTA cases, we froze the embryos 1 hour post biopsy. Why 1 hour, not 45 minutes, not 30 minutes? Because this is the shortest time that we can guarantee we can do the biopsy. Because you know, you're an embryologist, if you have a case with 5 embryos for biopsy and I tell you freeze immediately, it means after you finish the biopsy, for embryo number 1 it will be 30 minutes, for embryo number 5 it will be 1 minute. But within 1 hour, we accept that in most of the cases you will be able to do really within 1 hour. And then what we did is, we checked the re-expansion of the embryo at time of freezing, so 1 hour after biopsy. After 1 year of collecting data, we wanted to see if this re-expansion potential of the embryo 1 hour post biopsy is a predictor for ongoing pregnancy and live birth. And interestingly, what we found is, it's a highly significant factor. It means that we added to our list of variables that we can use in order to decide to select the best embryo, we added the re-expansion potential as a very important variable. And even our embryologists in the lab, sometimes they prioritize this over the quality of the embryo. Okay, if they see BB and BA, the BB was BL2 compared to BL1, they prefer that one. So I think that is very useful for us and for everyone, so hopefully this will be published. Now, interestingly also, what we found is, we also check 1 hour post-warming the re-expansion of the embryo. And we found that there is a direct correlation between the re-expansion after biopsy and the re-expansion after worming. And our statistician, Dr. Erkan, what he did is, we took the timing of worming, the timing of transfer, the grade 1 hour after worming, the grade at time of transfer. He modeled it, so we had like a model, a slope to show the re-expansion potential. And what we found is, this slope, which represents the re-expansion, how fast is the re-expansion, is in direct association with live birth. So if I cancel the days of the embryos, of course, the third option has the highest chance of live birth.
Okay, thank you. So it's important to know the expansion before vitrification, after biopsy and before vitrification. Okay, thank you. So these were the questions. Any questions from the audience? Yes, please.
Yes, can we go back to the second last case, that one with the PGT? Okay, I think that the decision is a little bit risky because it's not based on some clinical data from these patients. Let me explain what I want to say. If the patient has a history of previous miscarriages, if the patient had a history of biochemical pregnancies, if the patient is older than, it belongs to a 40 years old group with a normal ovarian reserve, it's changed. So you could prioritize embryos that have been generated as euploid after PGTA. But if you have a certain number of fertilized eggs, so good fertilization rate, good cleavage rate, and grade 1 embryos in day +3, then you have to think about, because that means that also those blastocysts in day +5 and +6, mainly those in day +5, have a high potential of implantation. Because if we still think that PGTA represents the health of the entire embryo, is a mistake. What we know that the nucleus is euploid, nothing else. We know zero about cytoplasm. So if I would make a choice, I would go deeper in this case to the clinical history of the patients before taking the final decision. And maybe PGTA is the right one, but I'm not so sure.
Yeah, definitely, that's a right point, that if there is a more recurrent failures for this patient, then it is better to choose the euploid embryo over the non-PGTA embryos. But if it is a patient coming for the first time with the age 40 years, even then we can choose the day 6 embryo if it has a good fertilization and the cleavage pattern and the kinetics are good enough.
Right, so I'm not an embryologist, so with all due respect, like mitoscore, I think the idea is fundamentally flawed, right? So it shouldn't be calculated, it shouldn't be reported, it shouldn't be regarded in choosing embryos. It's like the basis of it is you quantify the amount of mitochondrial DNA, which you assume is mitochondrial DNA, in proportion to nuclear DNA. Okay. So for that calculation to be accurate, you need to be biopsying cells in their entirety. You need to get the whole cytoplasm and whole nucleus. But yeah, unless I'm wrong, when you do the biopsy, you can never ensure you're really getting the cells intact, okay? So sometimes you're getting whole cytoplasm, sometimes you're getting part of the cytoplasm. So that proportion will never hold, and the better quality studies never show it has any predictive value. So it only has the potential to mislead you.
Yeah, doctor, you're completely right. And just to add to what you said, even at the beginning, the idea was the higher the mitoscore, the better. And then they saw that it's not matching with the outcomes. No, it's the opposite. And then they changed from reporting numbers to reporting no priority to transfer. So it's an internal comparison. And even something very simple, especially because at that time also there was still this cleavage stage was prominent. Which stage of replication is the cell made a huge difference. at which stage, if it's the S phase or not. The number of cells you take for biopsy, which we cannot count from trophectoderm, has an influence, because as you said, if I took 5, if it took 5 cells, it's different than if you took 10 cells, right? And it could be for the same patient with same number. Anyway, so I think now nobody is using it or reporting it, but yeah, this is sometimes how it's a little bit confusing or dynamic in science.
Okay, so for the euploid embryos, we can say that we can trust more on the grade of the embryo, day of the embryo, and the expansion after biopsy, before vitrification, and post-thaw. So these should be the major parameters to select the blastocyst, euploid blastocyst. Yes, Dr. Parveen. No. Okay. Any more questions? So to summarize the session is that more information that we have with the various parameters, so better it brings the clarity to our understanding of which embryo, which blastocyst is the better one, and it helps in the selection. So thank you so much all the panelists. Thank you.
Thank you, Dr. Surleen and the panelists. With this, we come to our final session. And to chair this session, I would like to call upon Professor Dr. Mustafa Barisata. He is Professor of Obstetric and Gynecology and Specialist in Reproductive Medicine, ART Fertility Clinics. And he has performed over 5,000 IVF cycle, and he is President of Turkish Society of Reproductive Medicine and past Executive Committee member of ESHRE. Additionally, he has more than 150 publications in leading journals and textbooks. I welcome you, sir. And to co-chair this session, I call upon Dr. Dakshayani Ravi Kumar. She is Clinical Director, ART Fertility Clinics, Chennai. And she is a gynecologist and infertility specialist with vast experience of more than 20 years. Dr. Dakshayani is a brilliant fertility specialist and follows evidence-based treatment strategies. So, over to you. Thank you.
Thank you so much. Can I start, sir? We are into the last session of the day. It was brainstorming and out-of-box thinking, and I think we have more now. I invite Dr. Ayse Sehen. She is Associate Professor at American Hospital, Istanbul. A graduate of Istanbul School of Medicine, has excelled in obstetrics and gynecology. She pursued additional specialization in infertility and assisted reproduction at the American Hospital of Istanbul. She has been working at the same hospital, which is most well-known and respected reproductive center in Turkey for the last 10 years. She is also the education coordinator of the Ministry Certified IVF Training Certification Program at the American College. We welcome you, ma'am, to speak about ultrasound diagnosis of endometriosis and adenomyosis.
Thank you for the invitation, and it's a great pleasure for me to be here with you. So let's talk about endometriosis and adenomyosis. Well, we're not doing well with the endometriosis patients in terms of both the diagnosis and also the management. The reason is we missed the diagnosis. I mean, in the times that while we were doing the diagnostic workup with the laparoscopy, the endometriosis was found in almost 40% of the infertility patients, and then after we switched to the imaging, it dropped to 11% according to the SART data. And we cause delays in the diagnosis. The mean time from the onset of the symptoms until the diagnosis is roughly around like 12 years, so we're not good there as well. And we keep having surprises during the surgery with incomplete consents taken from the patients and incomplete team for the appropriate surgery, and we end up sometimes leaving some residue disease and need for repeat surgery. So it's not that the patients are not coming to the doctor for their symptoms. Like the average of visits until the patient receives the diagnosis is around 6 physicians or 6 visits. And most of the time they have an ultrasound report which says, you have a normal ultrasound and there's nothing wrong. But the reality is far from that. So we need to look for the deep endometriosis for these patients, check the mobility of the pelvic organs, and check the site-specific tenderness. So endometriosis is not just a disease of the age of 30 years old. It's a disease coming from the adolescents and the young women as well. So in this study, what is surprising and interesting is that the isolated finding of an endometrioma is less frequent than having only posterior deep endometriosis or isolated adenomyosis, even in the patient of 25 years old. So a patient can have posterior compartment endometriosis and no endometrioma. So not seeing an endometrioma doesn't mean that the patient doesn't have an endometriosis. And even you see an endometrioma at the size of 2 centimeters, it's a myth that you're going to end up having this kind of an abdomen. This would be true for only 15% of the patients with isolated endometrioma. Most of them are going to have adhesions, adenomyosis, or deep endometriosis. So hopefully, by the end of this presentation, you're going to have some idea about what we're looking at here, what is the problem here. Another example, this one. So keep in mind these. So a consensus was published in the White Journal by the IDEA group with the goal of to increase our awareness as gynecologists while doing the ultrasound, to detect the endometriosis, better manage them, and standardize the terminology that we use to describe the pathologies that we see with the implants, their locations, how to measure their size, and on. So basically it has 4 steps. You don't need to do them in the order, but you can do it in any order, but you need to complete them at the end. So how we started is, first we have to do it in a standard way. So the bladder should not be too full or too empty. It should be empty-ish. Always be gentle because the patient is already under pain. Prepare the probe with like a 12 millimeter gel. This is going to help you especially to see the vaginal wall and the rectovaginal septum. And use plenty of lubricant, slowly insert the probe. And at the beginning of the examination for the site-specific tenderness, please ask the patients to indicate if she feels any tenderness while you're doing the ultrasound. So ultrasound has become part of the physical examination at this point, so it's kind of extension of your hand. So just ask it before we start the examination. Always, always perform it in the same way. Do it in a systematic way, okay? And note the pelvic organ mobility and tenderness. Do a transabdominal scan to check for the kidneys because 3% of the patients without knowing have advanced hydronephrosis. So let's start with step 1. Let's check the uterus. So this uterus, this is an anteverted uterus, so the cervix is pointed forward to the bladder and the uterus is also pointed forward to the bladder. So this is an anteverted. And what we see here, the cervix is pointed towards the bladder, but the uterine fundus is pointed backwards. So this patient has anteverted but retroflexed uterus. The reason is, most likely she has adhesions here. That's why she has this formation. This is also described as the question mark sign. As you see, the cervix is pointing to the bladder, but then the fundus is pointing backwards, and this is more common in patients with adenomyosis and also endometriosis. Let's move on with the uterus, with the adenomyosis. Also for the adenomyosis detection, Musa group published ultrasound features of the adenomyosis. The idea again was to uniform the terminology and to have a common language both in daily clinical life and also for the research purposes. Oh, that was supposed to be a movie. Anyway, it's not. Okay. So let's take a look at the ultrasound features of the adenomyosis. First, we need to check if the walls of the myometrium are symmetrical. So this is the anterior wall, this is the posterior wall. So the ratio should be 1. And how is it here? There is an asymmetry here. This is an ultrasound feature of adenomyosis. Presence of myometrial cyst is a very good indicator of adenomyosis. So you see cystic structures, and if you look at it during the luteal phase, you're going to see the rim, the white rim, just surrounding the cyst as if you have gestational sac in the myometrium. This appearance is also suggestive of adenomyosis, and it's a good idea to put a color Doppler so that you're not going to mix it up with a vessel, a cross-sectional part of the vessel. So this is a myometrial cyst. Hyperechoic islands are the echogenic islands, just as like the same echogenicity as the endometrium in the myometrium, and they're not in continuum with the endometrium, so that's important. They shouldn't have a connection with the endometrium. If you take, do you see here? There. This is a hyperechogenic myometrial island, and you see that it even has a peristaltism like endometrium. Fan-shaped shadowing, it's alternating hypoechoic and hyperechogenic linear stripes across the uterine wall. Echogenic subendometrial lines or buds, these are again echogenic structures, but this time they're perpendicular to the endometrial stripe and they have a connection with the endometrium. So this is an anteverted uterus. There's something in here, ill-defined, can't tell what that is. So to have an help with the Doppler, just put the Doppler and you're going to see that the Doppler signs are translesional and perpendicular to the endometrium as well. So that's also suggestive of adenomyosis. And sometimes this is the cervix, and the anterior and the posterior seroles, they just kind of diverge from the cervix and giving rise to the appearance of the globular uterus. Junctional zone is a very important part of the diagnostic part of the adenomyosis as well. Junctional zone is the inner part of the myometrium, which is adjacent to the endometrium. It is a unique tissue. It's different than the rest of the myometrium because it's hormonal dependent. It has cycle dependent contractions, and it's very important for the implantation and placentation as well. So what happens with the adenomyosis is that this is a normal junctional zone, that you can get this image with the 3D coronal section. And what happens with adenomyosis is you have the irregular junctional zone or interrupted junctional zone. So these are a couple of examples of that. And you see here, this endometrium is kind of penetrating inside the myometrial part. Why is it not moving? Okay, so quiz time. What do we see here? What features of ultrasound do we see in this patient? Go ahead. Okay, so let me go over it. So there's asymmetrical thickening. The anterior and the posterior walls are not the same. Fan-shaped shadowing, myometrial cysts, hyperechoic islands, and then when I put the color, you see we also have the translesional vascularity. So more or less it has everything. This patient has everything. So why is it important to diagnose adenomyosis? It's because adenomyosis and endometriosis are kind of dancing together. With the features, if you have the ultrasound features of adenomyosis in almost 44% of the patients, there is endometriosis, and vice versa. If you have an advanced endometriosis, you have adenomyosis features more often as well. So we need to know how to diagnose this. So there are direct features and indirect features that we've been talking about. So if you see the direct features of adenomyosis, yeah, more likely you're going to end up having a histological diagnosis of adenomyosis as well. But if you have only indirect features without the presence of direct features, the diagnosis of adenomyosis is a question mark. So you can use junctional zone if you are not very sure as well. If you have a healthy junctional zone, it's unlikely that the patient has adenomyosis. So let's check the ovary. So endometrioma, this is easy. Unilocular cyst with ground glass echogenicity. And sometimes you see solid-like structures inside the endometrioma. Don't worry, you have ultrasound. It's a dynamic tool. So just move the probe, and you will see that this sludge, this amorphous sludge, is going to be moving with your probe as well. So this is not a solid component, this is like fibrin deposits. If you see a kissing ovaries, then that's raising a red flag, because the presence of this kissing ovaries, two endometriomas just like stick together at the posterior part of the uterus at the Douglas, but there's a very high risk that you're going to have a tubal involvement and posterior compartment endometriosis as well. So this is, you see, there's nothing is moving here. They're attached to each other, they're attached to here. The second step is to look for the soft markers. You don't need, it doesn't require too much of an experience. As I told you before, from the beginning of the ultrasound, we need to ask the patient to indicate if she feels tender while we're touching the ovaries, the uterus, sacral ligaments, sacrouterine ligaments, and so on. So again, we're using the dynamic property of the ultrasound. Let's check for the ovaries. So to do that, just apply a pressure between the uterus and the ovary and see if the ovary is moving or not. If the ovary is moving, it's a good sign. If it's fixed, then please take a note. Also search for the hydrosalpinx, and presence of loculated peritoneal fluid in the pelvis is also suggestive of adhesion. So we'll see some couple of examples. I'm moving it, it's moving, the ovary is in the screen, out of the screen, but here this is ovary with the follicles. I'm trying to move it, but I cannot separate it from pelvic side wall. There is a nodule there. And while I'm doing this, look at the patient's face. She has already focal tenderness there. So this is she has right lower quadrant pain, and just next to the right ovary, she has filmy adhesions with some fluid there. For the hydrosalpinx, we know how it looks like. It's a unilocular tubular mass with irregular walls, with an anechoic content and incomplete septum here. And if you just make it a transverse section, this is how it looks like. Don't confuse it with an ovarian cyst. It's next to the ovary most of the time. And you can use a VCI to have nicer pictures as well. The third step is, again, doesn't require experience. It's the sliding sign. So the idea of the sliding sign is to assess the status of pouch of Douglas. Okay, so if we have an anteverted uterus, to see the cervix better, the probe needs to be inserted to the anterior fornix. If you have a retroverted uterus, the probe needs to be inserted to the posterior fornix. Let's see some examples. Before that, let's check how we do the sliding sign. So the vaginal probe is inserted. This is an anteverted uterus to the anterior fornix, and then you move your probe, and while you're moving, what you need to check is whether the anterior part of the rectum is moving freely behind the cervix, and also with the other hand, your free hand, just below the uterus, and see if, again, the bowel is moving freely behind the uterine fundus as well. So if there's sliding in the retrocervix and the posterior uterine fundus, then there's no obliteration. It's very unlikely that you're going to end up having an obliteration at the part of the Douglas. So sliding positive or negative? Yes. Everything is moving nicely here. The bowel is gliding behind the cervix and the uterine wall. And how about here? Nothing is really gliding from anywhere. Everything is moving all together. So that is sliding negative. Again, this raises a red flag for the gynecologist. Either you just go on screening for the other parts of the compartment in the pelvis for the deep endometriosis, or refer it to an experienced center. Okay, so this is what we expect after this ultrasound, and this is what we expect after this ultrasound. When it's retroverted, this is the retroverted uterus, this is the anterior part, this is the posterior part, so this is gliding, and here it's not gliding there. So this is a negative sliding sign. So the fourth step, it requires experience. But keep in mind that the nodules, they more or less always look hypoechoic, so dark nodules. They have really very minor vascularity and sometimes surrounded by white fibrotic tissue. Okay, so you remember that we talked about this 12 milliliter of gel. We use a glove because it gives more resistance. So this is how it's going to look. You will see this, the gel and the probe cover here. The idea is to increase our acoustic window actually between the probe and surrounding vaginal structures. So divide the pelvis into two, anterior compartment and the posterior compartment, to look for the endometriosis. Let's start with the anterior compartment. It's like among the endometriosis patients, it's only 3 to 5% of them is in the anterior compartment. So the bladder, as I told you before, should be empty, not too full, not too empty. So this is the trigone. Trigone is the place, as we all know, it's within the 3 centimeters of the urethral opening. So if you see a lesion here, the patient may have voiding dysfunction after the surgery of this. So that needs to be, again, noted. So the base, this is the most common spot for the anterior compartment location for the endometriosis. It is just anterior to the vagina and the cervix. It's the extraperitoneal part of the bladder. And then we have the dome, that's the intraperitoneal, intra-abdominal part. So also check for the sliding sign of the bladder relative to the uterus. And whenever you see a nodule, try to measure its distance to the orifice of the ureter. That is really important for the urologist and the patient's well-being after the surgery. So what we see here is this patient was treated multiple times because of a urinary tract infection, because she came with hematuria. She was looked for kidney stone, but actually she just has a nodule at the bladder base. And if you do a 3D ultrasound, this is how it looks like. And you need to find the ureter, so you need to move the probe to the very lateral pelvic wall. And from the intravesical part of it, you can just follow it until the bifurcation level. If you cannot do this, it's okay, but check for the kidneys, because keep in mind that 3% of the patients with endometriosis, without knowing, they have advanced stage hydronephrosis. And this is hydroureter. And let's move to the posterior compartment. We're going to draw an imaginary line passing from the base of the bladder and to the internal cervical os. Another line passing from the very inferior part of the cervix. Okay, so the tissue, the layer between the vagina and the bowel, is rectovaginal septum. Top third of the vagina between these two lines is posterior vaginal fornix. Lower than this green line from the torsoterinus is the lower rectum. This is the upper rectum, and beyond the fundus it's sigmoid. So we can have, there's implants in the rectovaginal septum, posterior vaginal fornix, bowel, and it can be all over there too. So, although the gold standard to diagnose endometriosis has been told to be laparoscopy, keep in mind that rectovaginal septum and posterior vaginal fornix are below the rectovaginal pouch peritone. So if you don't know what is below this, all you will see is, oh, there's a small nodule at the sacrouterine ligament, but actually if you just dig deeper, you will see that there's more than that, like this. So there's posterior vaginal involvement with the lower anterior rectum involvement. So if you don't know what is below this, you will leave residue disease. And also when you have such a surgery, this looks like almost a frozen pelvis. So to have an idea what to look for, again, it's important for the mapping. So rectovaginal septum, this is the glove, and there's this gel inside it. So it's going to come back again. So this dark area is the vagina, and this white area is this hyperechogenic level layer is the rectovaginal septum, and thereafter you will see the vaginal wall. So let's look from here. This is the vaginal wall, and this white thin layer is rectovaginal septum. So white thin layer, rectovaginal septum. Am I out of the battery? And you see that white thing, there's an interruption here, and it's a nodule. Posterior vaginal fornix, again, the glove is here, the gel is here to better visualize the vagina and the surrounding structures. And this is the posterior vaginal fornix. The patient on the left side, she had a surgery, removed the uterus and the ovaries. She is postmenopausal, but she was in pain, and this is her posterior vaginal fornix. As you see, there's thickening, and she is in pain when we are touching that area. And always do a speculum examination. With the vaginal fornix, you can see these. Sacrouterine ligaments are the most common locations of the endometriosis patients, and just keep in mind that the sacrouterine ligaments, they blend in the peritoneum posterior to vaginal fornix. So let's move backwards from here. So this is the posterior vaginal fornix, and this is sacrouterine ligament, and it's going to blend in posterior to the posterior vaginal fornix. Yes. That's what I'm talking about. This is the sacrouterine ligament, and it is blending there. So let's start from the backwards. Okay, again, insert the vaginal probe in the posterior vaginal fornix behind the cervix. Aim for the rectum. Identify this thin layer, hypoechoic. So the vagina is dark, and the hypoechoic layer is the pouch of Douglas. It's here as well. That is the sacrouterine ligament, and just start rotating your probe. And also, let's say that you're looking for the left side, just sweep the probe to the right at the same time. Just rotate your probe not more than 45 degrees. You're going to be able to see the thickening of the sacrouterine ligament. Here is the sacrouterine ligament. It is white, hyperechogenic, and you see this is the nodule. There it is. Okay, let's have a look here again. This is the thickened sacrouterine ligament, and we see some darkness here. This is the nodule at the sacrouterine ligament, and a bowel nodule is also sitting on top of it. So for the bowel, again, we see hypoechogenic thickening for the bowel. Let's have a look at the cross sections. So this is the longitudinal way that we see the bowel. What we see is this is the serosa, and this is the muscularis. This is the submucosa, mucosa, and lumen of the anterior part of the rectum. So if it's only at the serosa, it's not deep. It's a superficial endometriosis. So this is the serosa, and this hypoechogenic layer that you see here is the muscularis layer. So almost always, it's here. The nodule is always here. And how does it look like? This is the regular, normal muscular layers. Okay, my time is up. It always involves the anterior part of the rectosigmoid wall. And let's see how it looks like here. You see this is nicely thin muscularis propria, and then you have two thickenings here. Nicely it comes in here, and then you have increased thickness here. There's a nodularity. It's a thick muscularis layer. Keep in mind this is the normal one. This is comet-like or tail-like. This is a mushroom cap-like, and this is Indian heteros. Depends on the fibrosis around it, depends on the retractions and the adhesions. So when you detect, when you find out that there is a nodule in the bowel, the two questions that you need to ask yourself: is there stenosis? Is there vaginal involvement? So in this case, there's a bowel involvement here plus rectovaginal septum. Remember, it was white, and now there's nothing white here. It become darker, and this is a vaginal wall. So it is this nodule starting from the bowel penetrating the rectovaginal septum plus the vaginal wall. So if the nodules are going to be removed, you need to be careful about the rectovaginal fistula. So if you find one nodule, always look for more. In this case, you have the bladder base one here. It's going to come out there. That's how it looks. This is the cystoscopy. And then you have one in here for this is the bowel, thickened muscularis propria, and this is the specimen. So quiz time. What is this? That's a nodule at the bowel. You see, this is a muscularis propria. This is thin here, and then it's getting thicker here. And this one? Okay, this is the sacroiliac ligament. The nodule is here, and also there's another nodule here at the bowel. So learning curve is not that difficult. Roughly around 20 to 44 evaluations is enough to learn how to search for the deep endometriosis. As a gynecologist, we are expected to know how to diagnose PCO, fibroid, endometrial polyp, and somehow endometriosis assessment with the ultrasound still didn't get its attention from us. I think we need to work more on it, because keep in mind that 10% of the women has endometriosis around us, so we need to invest more in this. Thank you very much.
Thank you so much, Dr. Aisha. Any questions? Any quick questions? If not, I have a question for you. Sorry?
Do you think that the new generation of diagnostic tests, like for instance the infection tests related to some aspergillus or the molecular biology tests that are coming up?
There has been some tests that has been in the studies as well, but they haven't been replicated in other studies, that it hasn't been popular. And with the ultrasound, we can already see it. After watching someone for 2 weeks at an endometriosis clinic, roughly around like after 45 patients, you'll be able to do it yourself.
No, I'm wondering about if we can make a shorter time to diagnosis using, if in the future this test will
yeah, why not?
Yeah.
And one small question, like when we are talking about ultrasound, regularly we see most of our patients have retroverted, retroflexed uterus. Some of them with adenomyosis, endometriotic cysts also. But many of them apparently looks a normal uterus but retroverted. Do you feel that is one of the reasons? But I honestly feel it is one of the reasons for their fertility problems also.
Well, the thing is, you know, the myometrium contracts as well. So once you see like anteverted retroflex uterus, another time when you check it, it can be just an anteverted uterus as well. So to resolve this issue, I think it will be a good idea to check for the sliding sign. So if you don't see the sliding sign, it means that there's an adhesion there. So I think that can help you to distinguish whether this is a normal finding or not an abnormal, whether that. Other than that, I mean, it doesn't cause infertility just to see this question sign. It's not the reason of infertility. It just gives you a hint about, okay, maybe there is some more than what I see here. Let's look deeper. Thank you.
May I make a comment too? Just give me a second. I don't know how, but we're a bit ahead of time, so I'd like to make one comment and respond to Luca as well. The one is, since he's busy, I'll start with the other comment. I am yet to see a colleague who didn't start to see adenomyosis in every single patient after learning about this criteria for the first time. So I think overdiagnosis may be an issue as much as underdiagnosis as well. Okay, so you made a distinction between direct and indirect signs, okay? But like, it's important to highlight that most of those indirect signs are also findings associated with aging of the uterus, like hyperechogenic spots. I always find it easier to understand and like kind of interpret if you consider how the disease starts and evolves. So if you suspect for adenomyosis,
it starts from the endometrium
that you would look for to confirm your diagnosis. I mean, I would tend to rule out adenomyosis unless I see subendometrial hyperechogenic buds or myometrial cyst, and if I can see an all-round, I mean, as you said, intact, junctional zone. Otherwise, thickening, hyperechogenic spots in the endometrium, in the myometrium, especially towards the side of the uterus, are pretty common. So how do you decide if you're seeing someone who's 40, the uterus looks somewhat asymmetrical, and there are a few, like hyperechogenic dots around?
Okay, so the good thing is that most of the time, the real patient with adenomyosis, they don't have only one ultrasound feature. They have 3 or more. Most of them, more than half of them has 3 or more ultrasound features. So that helps, not just one. If you see many of the ultrasound features, that's more suggestive of adenomyosis. And number 2, as you told you, if the direct signs, if you see direct signs, okay, you're more for adenomyosis. But if in the absence of direct signs, if you just see indirect signs, it's hard to call that patient as adenomyotic. And if you're in doubt, always check for the junctional zone. If you have a healthy, nice-looking junctional zone, just be away from the diagnosis of the adenomyosis. That's what I understood from what I read and listened.
We'll discuss
Thank
later
you.
Anyways. Any other questions or comments? No? Thank you.
Bence yeter.
So now it's my pleasure again today to introduce Professor Stopp, who is the head of Department of Reproductive Medicine at University of Ghent, who is a distinguished expert in reproductive surgery and medicine, and who is now focusing on vitrification, oocyte cryopreservation, and leading a periactive research program in the department. And he'll be talking about modified versus pure natural cycles for frozen embryo transfers. Thank you. Looking forward to the talk.
Thank you, Boris. It's a kind introduction. I'd like to thank the organizers, people from ART Fertility Clinics, for this kind invitation. A pleasure to be here. I have worked a couple of years with Professor Fatimi in Brussels, and we now have the pleasure also to have Barbara Lawrence as a guest professor with us in Ghent. The talk I'll be given is about the frozen embryo transfer cycle, and then more specifically about natural cycle and how to do the natural cycle. Lots of it has come up already today in different lectures. It's about the ovulation and how complex it is. Now, as an introduction, we all realize that cryocycle has become very important. So if we think about how we in the clinic could further improve our outcomes, then I think the natural cycle or the cryocycle, how we put embryos back for implantation, is an important point where we can actually still learn a lot and further improve our way of handling this. And this, of course, is because we do so many cryocycles. It's because no longer just a tool to store our supernumerary embryos going for fresh transfer, but in many centers we just go for freeze-all, for many indications, as you all know. Now this is an overview of the types of cryocycles that we actually all use in our clinics. And the first is a natural cycle, in which there is a distinction between two, either the true natural cycle, where you basically have the ovulation as it happens naturally, and I made a distinction there between the one without progesterone program, so basically the obvious natural true cycle, and the one who has been in a natural progesterone program cycle. For those who never heard of this, I'll come back to that later. And then, of course, is the modified natural cycle, where you give the ACG trigger for scheduling, so for triggering ovulation and scheduling the transfer of your embryos. Then there's the ovulation induction cycle for those without a regular cycle. And then there's, of course, the HRT cycle, which in many places is still the most commonly used way of transferring embryos. There's this distinction between those with and without GnRH agonist, but it's quite clear nowadays that there's no need to give agonists to our patients. It's only burdensome and doesn't add to pregnancy rates. Now we first have a quick look at the HRT cycle. So basically, it's fallen from grace because we have seen many papers showing that implantation is not optimal. There are, of course, meta-analysis showing it's equivalent, but also specific studies showing that implantation is lower, specifically more miscarriages are seen. And another point which is even more important, I think personally, with regard to the benefit of our patients with this kind of cycle is a safety. So it's also come up earlier today, and it's something you probably know already or knew already, is that it's not so safe to give your patient ART cycles if you think about her future pregnancy. So it's a hypertensive disease, is far more common with all problems that it's causing. And so this is very nicely done in the study, where actually they were seen either to have a corpus luteum or not, and all the metabolites, relaxin and so forth, that's been produced by the corpus luteum appears to be important for our patient, and it's important for her to have that corpus luteum in place in order to have a good start of a pregnancy, and with effect on the future pregnancy much later than the first trimester. A nice study performed in the team from ART Fertility Clinics, also looking at the uterine artery to see whether that effect could also be noticed there. Was not the case, but was a nice idea to explore. And just a last paper which I want to mention on this topic of HRT is this, where a recent paper has shown that the risk of that hypertensive disorder is also linked to the thickness of the endometrium of the patient when she's getting her embryo transferred. Now we move on to the ovulation induction cycle, and we're very brief on this. There's a meta-analysis and has shown that actually better than HRT cycles, and also reasons to believe that there's lower miscarriages rates. So basically, if your patient does not have a regular cycle, just don't go for the HRT. If you have the alternative, you can go for letrozole, clomiphene, cider, the many alternatives to help your patient having a regular cycle. So basically, this is for the anovulatory cycles, or those with cycles which are too long to be practical, like PCOS patients. So this brings us to the natural cycle. Natural cycle, and has been shown many times before, you've seen this 1,000 times in your life. This is just the hormone fluctuations we see within a cycle. And if you look at this, you think it's very, very obvious how they fluctuate. So we see LH peak, FSH peak also, but a bit lower, and an estradiol drops, and then we see a progesterone rise at time of ovulation. But it's also become clear from lectures earlier today that it's not that simple. I call it an endocrine signature. It's quite individual and can vary a lot, and it's sometimes harder to read than you would think based on what you know from textbooks. So it's of course a challenge if you go for natural cycle, because you need to be able to interpret this to make your decision about when to transfer your embryo or to when to trigger your ACG. And this is illustrated here by the study that's also been shown earlier today, where you see there's a variation 1 to 2 days between when you see first an LH peak in the blood and when you have actually progesterone at a level where you're sure that there's an ovulation. So just observing this makes you wonder how it's been working in the last couple of years. And that brings us to the last part, of course, and this is the most important part. It's also been discussed with Professor Fatemi, the endometrium, and because basically all these hormones, they wouldn't matter much if it wouldn't have such a big effect on the endometrium and the gene expression in the endometrium. So that's why we need to read that good in order to predict what's happening in the uterus and when we need to transfer our embryos. So why would it matter actually to add an ACG trigger or not? First of all, timing could not be optimal in either strategy. So we could be mistaken when we give an ACG trigger, or whether we just observe and wait for an LH peak. So that's been clear for those who attended previous lectures. Just waiting for the LH peak, especially if you do it just checking in the urine, could be wrong. And also if you determine the readiness of your patients for an ACG injection, what criteria will you follow to determine now she's ready, I will give the ACG trigger. And then of course also the effect of the triggering on the endometrium. The receptors there, it's different than just LH, which is not naturally produced, and what could that potentially do on your receptivity. So all these questions, let's have a look at what's published so far. Basically, there isn't much published, but I'll go over it with you. So first paper is from Dr. Fatemi when he's done it in Brussels, so 2010, so quite some time ago, and it was actually not such a large study, and it's actually been terminated earlier during an interim analysis which showed that the differences in outcome were so huge that it was no longer ethically okay to continue that study, and the difference was in favor of the true natural cycle. I just wonder whether this is my latest slides from yesterday, but anyway, we'll see. So pregnancy rates are 31% versus 14%. Another thing is that in this study, of course, patients where you wait to give your ACG trigger, they could also have an LH rise. And then, of course, if you have an LH rise, what to do? And this study, they decided to still give the ACG trigger. The study also been a long time ago, as I mentioned, and it was in day 3. Embryos which were thawed on day 3, transferred on day 4. Of course, nowadays, blastocyst is the norm in most places. Second study is a study by Weissman. It's a year later. It's even a smaller study. Actually, this was sample size for this size. It's under 60 patients were included, and the primary endpoint was not looking at ongoing pregnancy rates, but was just the convenience to see how many visits did patients need to have her transfer scheduled. But here I put it for the sake of the outcome, and there they saw no differences. Of course, like I said, small sample size would be very unlikely to see any difference with this number of patients. And then more recently, people from Brussels then did the effort to do a larger trials, and unfortunately still with day 3 embryos, so not with the current clinical practice. And also what was quite surprising for more recent study is that they did not use any luteal phase support, as you will see in other papers that probably would have been more in line with how we do it today. But that study, just where with LH assessment, did not see any difference between the two arms, so either with a true natural cycle or a modified natural cycle with ACG triggering. Looking at the visits, that was not the primary endpoint for this study, but the study showed one additional visit. The additional visit is not an ultrasound visit, it's just drawing of blood to see ACG rise or progesterone rise. And then the other RCTs which I just mentioned, the smaller ones, also with their small sample size, did find significant difference in the number of visits in favor for the modified natural cycle, so with ACG triggering, as you could of course expect, as you don't need to follow up for ovulation. So clinical challenges of the true natural cycle, like I said, there's more clinical visits, so in your clinic you need to decide whether you have the manpower of girl power to do all this and the time, and the clinically more complex. You need to read the LH peak, which is not easy. And sometimes ovulation is not identified. Sometimes it's delayed. So there's all kinds of problems that can occur, not in a large chunk of your patients, but a significant part, which makes it quite challenging. And then, of course, limited schedule opportunities, because as soon as you see that ovulation, of course, you need to act on this, and you need to start counting your days to plan your embryo transfer. For this reason, a study has been performed to see how flexible you can get. I just told you ACG triggering is more flexible, but how flexible can you get? And here, as published just last year, RBM Online, it's a group with Garcia Velasco, also President Samuel Dos Santos Ribeiro from the EV group, were the authors, and it's a large sample size. It's over 3,000 cycles where they did only single blastocyst transfer, so high quality blastocysts, so 3BB or better were transferred, and they were just looking at the outcome. And actually they did not see any difference with regard to the ongoing pregnancy rate, no matter what size the follicle had. There were some criteria, so the patients need to have an endometrium of minimum 7 millimeters, but that was about it. And the second thing was that the progesterone was measured, and only the progesterone. Progesterone needed to be below 1.5. And that, of course, is something where you could have your thoughts about, because 1.5 is like really a full-blown ovulation, but just a bit lower than that. And we've seen that before. If you have progesterone of 1, you also have already the initiation of your secretory transformation, and of course these patients could also be then considered as not being ovulated or not being ready, having started their secretory transformation. But anyway, given all these limitations to the study, they did not see any difference with regard to the follicular size. So either having a follicle of 13 or follicle of 22, if you give your ACG triggering, pregnancy outcomes are the same. And this gives, of course, a huge flexibility if this is confirmed in future studies, preferably also looking at live birth, because this study just looked at ongoing pregnancy rates. The rock curve you see here is a straight line showing that basically that follicular size does not matter at all in their data. And that's what they also put in their paper as an illustration of how flexible it could get. They say soon if you see follicle 30 millimeters, you have a whole range from 5 to 7 days in between which you could transfer your embryo. Luteal phase serum progesterone. So we've always been reading papers in the last couple of years about how important it could be to measure the serum progesterone on the day of embryo transfer, either on the day itself, or some centers do it the day before. And these papers originally came from the HRT cycles, and also meta-analysis have already been performed and putting like a cutoff of 10 nanograms per ml. But every new paper that comes out has a different threshold. So it's 9.2, 8.8, some go even low as 7. We've been looking at our own data in our clinic. We'll submit it for ESHRE. We've seen a cutoff of 5, and we see no difference. Of 5 or above, it doesn't matter. Under 5, we give additional subcutaneous progesterone, but we don't even know whether that's necessary. But of course, for safety and given what's in literature, we do supplement, although we now have actually stopped doing HRT altogether. Nevertheless, in the natural cycle, there's such fewer data available whether that progesterone measurement is any predictor about the outcome and the chance of miscarriage. And a first paper that actually looked at this only came out in 2020, and that's from the group from Professor Nicolas Polizos from Barcelona. And he had patients in PGTA cycles and in non-PGTA cycles, and actually for both he could draw this curve showing that the more progesterone they had on the day before embryo transfer, the higher the chance of having a live birth rate. Important to know here is that these patients were in true natural cycles, so it was with LH measurements, and also that there was no luteal phase support given. And then he of course confirmed the 10 nanograms per ml, and it seems like it was exactly the same, at least that was a conclusion from this paper, in natural cycles as in ART cycles. So we also started doing blood measurements in our natural cycles to confirm. But then came this paper 3 years later from Professor Barbara Lawrence, and the study was more fine-tuned for several things. An important one is, first of all, the timing of embryo transfer was not based on LH in the urine, but it was based on blood tests. so a more precise timing of when the embryos were scheduled for transfer. And I think that's probably even more important, they were given micronized vaginal progesterone during the luteal phase. And if you do it that way, and it's of course euploid embryos that were used, then the progesterone no longer seems to relate with the outcome of the embryo transfer. So basically it's contradicting the original conclusions that came from that paper from 3 years ago, and actually could perfectly be explained by the way the treatment was offered. You see the ROC curve again, so age, BMI, embryo quality and so forth. The classical parameters that relate to outcome still mattered, but if you add progesterone on day of ET, it didn't play any role in the prediction of a pregnancy or not. Let's have a look at what literature says on whether to add progesterone, because you just saw that adding progesterone appears to annihilate the effect of the progesterone measurements on day of transfer. So should we give progesterone during the luteal phase if we go for natural cycle or not? And again, as has already been said before, meta-analysis are done very easily nowadays. And there's just 3 papers, and that appears to be enough for a meta-analysis. And even more, it's actually also enough to show a difference. So it must be that the effect is quite large. And if you take them together, so this is a meta-analysis with both natural cycles, I mean true natural cycles, and modified natural cycles. And then you see the diamond of the graphic being in favor of adding progesterone if you look at live birth rate, clinical pregnancy rate, and also in favor of adding progesterone if you're looking at miscarriages. There's fewer miscarriages if you add luteal phase support in a natural cycle. Now, we're interested in knowing what it's about the 2 different strategies, with or without ACG triggering. If you look at this one, this is true natural cycle. There you see significant benefit from adding progesterone. There's only 2 papers that have been performed. 2 studies, 2 papers of course, and they were large studies, and so the significance was there. If you look at the only paper where it was with modified natural cycle, so with ACG, there was no significance, but of course that sample size was so small that it's very unlikely that of course you could do, and it's actually ridiculous to do meta-analysis on a single paper. These here is an overview of the 2 papers. As the Björksten is the one in above, and the Wagren is the Scandinavian study on below. 2 studies, randomized controlled trials, a decent sample size, especially the lower one, sample size 600 to 700 patients with or without luteal phase micronized progesterone, and looking at the outcome. And then they both saw it's actually beneficial to add the luteal phase progesterone. There's some kind of heterogeneity in this study because there were embryos on day 3, day 2 actually also, and also day 5 and day 6, and the initiation of progesterone varied according to the day of embryo transfer, so 3 or 6 days after LH peak, and both also just looked at LH peak and not at blood measurements, so there's no measurement of progesterone in the whole thing, but both concluded that it's better to give luteal phase support to our patients in natural cycles. Now, last point I'd like to share with you is the natural progesterone program cycles. The first mentioning of that concept came at the ACRM in 2021. It was the group of Professor Santos Ribeiro from EV in Lisbon who presented it there, and then last ACRM in Copenhagen it was also mentioned, but there's no publication yet on the topic. So what we do there is we have a natural cycle, follicle grows, and then we do it at day 11. We started on day 9, but then there were too many visits, so we started on day 11. And then there are criteria, and these are the criteria that he came up with himself, and of course makes sense, but we're thinking of making them more liberal to have more flexibility. Endometrium of 7 millimeters, leading follicle of 13-14 millimeters, and estradiol of 140. Actually needs to be 120. These were not my latest slides, which I submitted, but anyway, it's 120 picogram per ml. And then ovulation trigger, and luteal phase support. I mentioned luteal phase triggering because the exogenous progesterone that we administer, so this is micronized vaginal progesterone, 400 milligrams in the evening the day you have this criteria, and then from the next day 400 in the morning and the evening, and then on the 5th day of this administration of vaginal progesterone, embryo transfer is performed. These patients also have an ovulation, although they're not triggered with ACG, although they're under progesterone. Are we 100% sure that they ovulate? No, we're not 100% sure, but just looking at the progesterone measurements and comparing that to patients in HRT cycles, they must ovulate. So Professor Santos Ribeiro, he has looked at and has seen corpora lutea, so he has checked that, but he hasn't checked them in all, and measuring progesterone doesn't make sense because there is the exogenous progesterone, but, and I'll show you that also, the mean progesterone levels are significantly higher, indicating that there is endogenous progesterone from ovulation and the corpus luteum, which we actually want for the safety of pregnancy, and then on top of that, the exogenous progesterone, which we administer to prevent anyone having a luteal phase defect or insufficiency. So that's the data he presented. There were 277 natural progesterone program cycles, and then he compared it with historic data of HRT cycles and natural cycles, and then no difference was seen on this large data set in ongoing pregnancy rates, nothing about live birth. I think that's why we're waiting for the paper. And that lower miscarriage rate was seen if you compare the NPP compared to the HRT cycles. This is data from our own center in Ghent, where we also actually started then, halfway 2023, we also started doing this as in a way to get rid of our HRT cycles. And then we looked at the first 300 cycles which we performed. Patients, 227 individual patients doing these 300 cycles. Age, the median age is 34, AMH 2.2, BMI 23, and only 80% non-PGTA, minorities PGTA cycles. This is how the patient characteristics are. Number of visits is 2, so it's actually, this is the median number of visits, so it's a low number. Remember, it was 4 on average in those who do a true natural cycle. And the progesterone on the day of embryo transfer was 19, which is actually a higher number as what you would see in HRT cycles, so indicating an ovulation. And the outcome we've seen in our clinic was 49%. It was all single blastocyst transfers. ACG positive ongoing 35%. You see, I didn't feel like, this is not my final slide deck, but I can tell you the miscarriage rate was 11%. So it's recent data, so we're just preparing it fresh, that's why it wasn't filled out yet. And then the age and the blastocyst quality, so the 2 classical predictors for all of our patients and all of our treatments come out again, as expected, where all the others, which is also quite interesting, did not. So no significant influence also of progesterone on the day of embryo transfer as predictor for outcome, so which is reassuring. So this means that all our patients, as this was shown in the Lawrence paper, probably in her true natural cycle, probably have enough progesterone for progesterone to matter on outcome, which of course frees us from doing blood tests on the day of embryo transfer. And then here, just to illustrate, 61% of our patients were done with 1 or 2 visits. And I just mentioned the criteria. We make them more liberal. If we say, for instance, if we initiate the micronized progesterone from endometriums of 5 or maybe 4 millimeters, and we just have as criteria a follicle of 13, as was done in the Velasco paper, then maybe we could actually reduce that, because the main reason why we had to add multiple visits was the endometrial thickness. We were actually for the 7 millimeters. So if we could let go of that, have a lower threshold, I think we could actually further reduce the number of visits needed in this kind of protocol. The percentage of patients under 10 nanogram per ml is actually 3%. So not 2%, but still very low. In our clinic, in our data for HRT cycles, we have 30% under 10 nanogram per ml, indicating endogenous progesterone production by ovulation. So, back to nature. I would say yes, back to nature. Many people write about this as a common thing in titles nowadays. but how far would you go back? And do we need to go back? So I think natural cycle, yes, if that means go back to nature, yes, for sure. We need to go to the natural cycle. I'm quite convinced that we need to add luteal phase support for all, because we're not able to identify those with luteal phase insufficiency. We can't. And basically measuring progesterone day of transfer isn't informative enough to pick them out, those who need it. And the natural cycle apparently is no longer needed. So take home messages. Use of HRT cycles, I would just abandon it if you can, in a way. Lower implantation, high miscarriages, and obstetrics outcomes are not as favorable. Frozen embryo transfer cycles in a natural or an induced one, if that would be necessary for a patient, is preferable in all patients. Generalized luteal phase support seems beneficial and then takes away the need for progesterone measurements, and promising data about schedule options in ovulatory frozen embryo transfer cycles, so the natural progesterone program, and then the flexible HCG triggering. An HCG trigger or not, I would say the jury is still out, but I said potentially, but actually probably very likely dependent on how you're scheduling it, how you are following up your cycle, and how you're able to determine when to transfer your embryo. I thank you very much for your attention.
Thank you, Professor. Any questions?
Thank you, Professor Stoop. You know, yesterday in Dubai, I gave a presentation about mistakes of studies made in the past. And while you were presenting, I was reading the paper of Wangren from Karolinska in Sweden. And so basically, I don't know if you read that paper, because this is the biggest contributor to this meta-analysis, whether you need progesterone or no progesterone for luteal phase support. So the conclusion is, in a natural cycle, you benefit from progesterone. That's the conclusion. That means all our mothers should not deliver us, because I assume all of us were conceived naturally, right?
I think.
Wait, now the question comes. So if you read that paper, you see that day 2 embryos were transferred day 3 of stick in the urine LH rise, right? So they put a stick in the urine and they say, okay, maybe you have an LH rise, and we're going to transfer 3 days later. Day 3 embryos were transferred 4th day of LH rise. Day 5 embryos were transferred 6th day of LH rise. Now, Carroll published a paper and Erdem published another paper. First of all, you miss 30% your ovulation incorrectly with stick in the urine. That's already 30% wrong. Now imagine you capture your LH rise correctly, then you can have a progesterone rise between 20 hours up to 60 hours. So it means the timing of progesterone exposure has not been detected correctly. This is one point. Now, the group which received progesterone, they obviously might have received much earlier progesterone because the endometria were not exposed to progesterone rate. It means the secondary transformation has already initiated earlier with the ones who received progesterone. Maybe the other ones who did not receive progesterone, they did not initiate the secondary transformation yet. It means the window of implantation was misplaced in the group which didn't receive progesterone because simply they did not ovulate correctly yet. The timing was wrong. This is number one. Number two, they had several centers being included there, and they transferred single and double embryos. They transferred day 2 embryos, day 3 embryos, day 5 embryos. So you have so many variables here that personally I don't understand how you can accept it, number one, okay, it's human reproduction, and number two, how you can include it in a meta-analysis.
There's a long question. First of all, your comment with regard to are women around the world getting pregnant without luteal phase support. It is just a difference. It's not a matter of not getting pregnant. So they would still get pregnant without luteal phase support. And secondly, I think maybe our women would get pregnant more easily if they would be taking luteal phase support. If they don't start, because the study shown fewer miscarriages, in repeated miscarriages with luteal phase support. So basically, they could potentially benefit. A second comment with regard to the variation of the Carroll paper of LH peak. And then when does progesterone get above the 1.5 on that same day, or one day before, or one day after, or 2 days after? That's true, but that's of course a mistake in both arms of the meta-analysis. So both are exposed to that same flaw, and still they saw a difference in pregnancy rates. And the third thing is that, imagine, again, go back to our women having natural conception. If the fact of that LH being so loose from progesterone rise, then it would also mean that LH is also very loose from time of ovulation. Is that what you suggest?
The main issue here is the time of progesterone exposure. That's the main issue.
Yeah, but I mean, I haven't the opportunity to ask her myself. So you see the LH rise coming, and then some have progesterone rise the same day, ovulate the same day. Some
May I comment on that?
What? Yes.
May I comment on that?
Yes.
So I understand what Professor Fademi is saying. So basically, in a modified natural cycle, once we inject HCG, we assume it's the start of the LH rise, then we transfer +7, right? Because it will rise, then progesterone will start rising, and the embryo, based on the majority of the data, fares best when it's transferred on +1 day progesterone exposure of its developmental stage. If it's a day 5 embryo, it does best on the 6th day of progesterone. If it's a day 3 embryo, it does best on the 4th day of progesterone. So when you detect LH by urine, so we think it's somewhere around the tip, and you would expect progesterone to start rising, like on average, mostly a day later. So if you start transferring, say, day 3 embryos on the 3rd day after LH, so it is probably like 2nd day of progesterone exposure, right? So you may argue these errors affect the comparison groups, like luteal support or no luteal support. They would be affected similarly, but this is suboptimal in general. We can't generalize that information to what would happen if the embryos are transferred on the proper day of progesterone exposure. So I think that is the point, right?
I think the correct way to do that, that's correct what Professor Bari says, would have been defining time 0 of progesterone rise. So both groups, you have progesterone now rise, you have progesterone now going up. You receive luteal phase support, you do not receive luteal phase support. You have day 5 embryos, you have day 5 embryos, and we compare the outcome. So the length, and this is a mistake almost all studies do looking into frozen cycles. Not only luteal phase, no luteal phase, also studies, for example, comparing fresh versus frozen. There are studies, they say there is no difference. It's simply they did not understand the basic physiology.
Yeah, but the question, of course, then is, if that would have been different, and more in line with what you say, whether the findings would be different. So the question now is then, do these people benefit from luteal phase support because there's luteal phase support because of wrong planning? That's basically what you say.
Exactly.
Yeah. So in the study, the human reproduction paper by Barbara Lawrence, there was luteal phase support given, and there was no effect of progesterone day of transfer. So basically, would you consider stopping luteal phase support, or why are you still giving it if you think that correct triggering no longer requires it?
That study of Barbara has one major flaw. The one that we published.
Yeah.
I mean, we published that it has a flaw. So we measured progesterone because we gave luteal phase support, and the conclusion was that it doesn't matter, but all patients received oral dydrogesterone. It's also mentioned.
Yeah.
So the oral dydrogesterone cannot be measured as a progesterone. So this is the flaw of that paper. So I think that is not a good reference to refer at, because they received other kind of progesterone which cannot be measured.
Yeah.
But I think a correct study which needs to be done is diagnosing. You see, there are two things which are important. One is the time of progesterone exposure. This is number one. Number two is whether progesterone as a luteal phase support would add any benefit. But if you have two variables, then you cannot draw any conclusions, because you have two major variables. The time of progesterone exposure and the concentration of luteal phase support are two variables. And then you have the day of embryo transfer, day 2, day 3, day 5. Then you have one embryo, two embryos, then you have many centers. So you have too many variables in this equation to draw any conclusions.
Okay. Okay, great.
Conclusion is obviously to the point. Like, this is one study, so we need obviously more studies, and looking at the quality of the study really, like multiple. If you look at the subgroups like day 2, day 3, there are even day 4s, day 5s. Individually, they're not significantly different, right? So it's not a great study, but yeah, it is something maybe worth studying.
Yeah, it would be nice to have an RCT comparing the natural progesterone program one with a true natural cycle to
But
see
that's
what
a
that
study we can do, Dominic.
Yes,
I mean,
yes.
we can say, okay, we're going to detect, we do exactly what they did, exactly the same, but we detect the ovulation correctly. We say, okay, time 0 is now, time 0 is now.
Yeah.
We go with day 5, one group we give luteal phase support, the other group we don't, and then if it comes out that it's beneficial.
Yeah. But the great thing about the NPP cycles is because there you initiate progesterone and you have a perfect idea when progesterone is there. As long as you are following your cycle with blood tests, it's always quite unpredictable. And we've seen that curve also, that how progesterone creeps up. When are you going to find the ideal time that actually the secretory phase is actually changing to that extent that you need to start scheduling transfer? But still lots of opportunities for studies.
Thank you so much, sir. If I remember very well, sir, last year in Abu Dhabi clinic, you used to get about 96% in all the natural cycle transfers. And it was calculated the way Professor was explaining now. Calculate the ovulation day, and then from there onwards, if it is day 5, 5 plus the next day we transfer.
Yeah, if you do that correctly, and obviously we are running a study, luteal phase support, no luteal phase support, PGTA, so eliminate all the variables. We have, with no luteal phase support, if you have a good embryo quality or transferable embryo quality day 5, you are above 80%. You are above 80%. So I think whether luteal phase support is required, the first question is to detect ovulation correctly, and then luteal phase support or no luteal phase support.
Thank you, sir.
Okay.
Thank you so much.
Thank you.
So, to top it all, sir, we want your closing remarks.
Thank you.
Thank you so much.
So I would like to thank all of you staying so late here, listening to these interesting discussions that we have. You see, these are brainstorming discussions. It's interesting. I think we all learned from that. I would like to thank all our speakers who made their travels from Belgium, from Spain, to us also from Abu Dhabi and Dubai, where we came over. I would like to thank you all. I think we have learned. I always say science is dynamic, it's moving, so we have to unlearn and relearn. And I hope that it was inspiring for you. I hope you have learned something. I hope that you can implement that in your daily practice. And I'm really looking forward repeating this meeting next year, hopefully with new data, maybe with the data of a natural cycle, diagnosing correctly the ovulation with or without luteal phase support. Having said that, thank you very much and have a nice evening. Thank you. Yes, with you, of course.
Yes. Can I request all faculties to come on stage, please, for a photograph?